Okay, chalo. So good afternoon, everyone, and let us start with our today's session. So we are going to start with cardiovascular system. Right. So our approach today also same. Okay, so volume is maximum. Okay, right. Okay. So our simple approach once again remains the same. So we are going to learn cardiology today, right? So we are to learn cardiovascular system today. So we are going to learn it in an integrated approach. Integrated approach means rather than starting with disease, we are going to start with our first step. We are going to start with review of physiology. So we are going to start with review of physiology in the cardiovascular system, that is review of basics. So I'm going to start here. So hello, yeah, adjusting the volume. Hello, yes, can you hear me now? Okay. So we are going to start with the simple review of basics. Then we will understand the symptomatology of the disease. Okay, then we are going to learn the symptomatology of the disease. Once we know the symptomatology, we want to understand the assessment methods. Once we understand symptomatology, we go on to understanding assessment methods of cardiology. Right. So please remember that how it is that we have to start always with first MBBS. Okay. So like always say, first we want to know what is normal. First MBBS, that what is normal about the cardiovascular system is where we must start with. Once we know that what is the problem, we will able to know symptoms. Based on symptoms, we will know how to suspect the disease. And with the use of assessment methods, we will be able to diagnose the disease. We will be able to reach the diagnosis of the disease. Okay, so we have to go step by step. So in cardiovascular system, we want to start with first review of basics. We want to learn the symptomatology of the cardiovascular system disorders, and then learn what are the assessment methods to reach our diagnosis. And only after we do that, we are going to go to number 4. We are going to classify the disorders. We are going to classify the disorders and then study individual disorders. Okay, and then study the individual disorders. So we have to go step by step. There is no hurry. We will be covering each and every aspect of cardiology, the approach to medicine, and so on. Okay, so we want to go one by one. So we are going to start with your review of physiology, symptomatology, assessment methods, and classification. And then we will go on to individual disorders. Right? So today, irrespective of what time we have started, I will take class till 10 o'clock max. Okay? We will cover the topic and then we will take it step by step. So this is the approach we are going to have here. Okay, that is the approach we are going to have here. About each individual disease, I have taught you before, but understand this. About each individual disorder, we must know the definition. About each individual disorders, we must know the definition. About each individual disease, we must know the definition. We must know epidemiology of the disease. We must know the pathophysiology of the disease. The pathophysiology of the disease. We must know the clinical features. We must know the clinical features. Then we must know the diagnostic tests. Then come the treatment of the patient. And finally, Last but not the least, we must be able to predict prognosis of the patient. Okay, so keep it very simple. Okay, so this is the approach we are going to follow throughout the next 2 days, that is today and tomorrow. We are going to start with the basics of cardiovascular system. So whether you are a foundation or a regular batch student, you will be able to understand all these topics very clearly. Okay, so please remember, this is the approach. I want each student to be aware of how we are going to approach the class, how to prepare your notes, and how to study them properly. Right? So we are going to start here with review of physiology, go on to symptomatology, assessment methods, classify the disease, and then discuss individual disorder. About each individual disorder, we want to be sure that we know the definition, the epidemiology, the pathophysiology, the clinical feature, the diagnosis, the treatment, and the prognosis. Yes, so keep it very simple. Every system that you study, I want you to follow the same order as much as possible. This is called as integrated approach to medicine, right? So with this brief introduction, let us start with the number one point, that is review of physiology in cardiovascular system, right? So let us come to that. So we will start with the physiology, cardiovascular system. So let us come to the physiology of the cardiovascular system. So if you look at the physiology of cardiovascular system, you tell me that what is the main function of the cardiovascular system. In one word, we can say that the cardiovascular system is there to maintain. The job of the cardiovascular system is to maintain adequate perfusion. It is to maintain adequate perfusion, that is same as adequate circulation. So the job of the cardiovascular system, the job of the cardiovascular system is to maintain adequate perfusion. Maintain adequate perfusion. That is what we want to do, right? So maintain adequate perfusion is the job of the cardiovascular system. So to maintain this perfusion, what does the cardiovascular system do? So we know the centerpiece of the cardiovascular system is the heart. The centerpiece of the cardiovascular system is the heart. So heart is actually not the producer of blood. It is only acting as the pump of the human body. The heart is acting just as the pump of the human body, right? So you just have to take down the notes in the same order. Okay, same way we have to go through. So cardiovascular system, the job is to maintain adequate perfusion. The heart is the pump of the body, but for the pump to function well, there has to be normal preload. There has to be normal preload as well as adequate afterload. So physiology review of the cardiovascular system. The job of the heart cardiovascular system is to maintain adequate perfusion to the different organs and tissue. But heart is just a pump of the body. For the pump to function effectively, there has to be adequate preload. So what is the preload? Preload is the venous return to the heart. The preload is the venous return to the heart. So why is preload important to us? All of us have studied in our first MBBS, we have studied the Frank-Starling law. In our first MBBS, all of us have studied the Frank-Starling law, which says that the force of the contraction is directly proportional to the stretch of the myocardium. The force of the contraction is directly proportional to the stretch of the myocardium. This we are already aware. So based on this, you can understand here that the venous return is extremely important to maintain the pump function. It is extremely important to maintain the pump function because the force of the contraction will depend upon the stretch of the myocardium. On the other hand, the afterload also needs to be normal. Why? Afterload is the systemic vascular resistance, the SVR. Afterload is the systemic vascular resistance, that is the SVR. That also has to be maintained normally. So the heart is pumping against the vascular resistance. Heart is pumping against the vascular resistance. Why is it important? Because to maintain adequate perfusion, it is not just about giving adequate volume of blood, but the blood also should be delivered under adequate pressure. Adequate pressure. So we must know what is blood pressure. We must know what is the blood pressure. So the cardiovascular system, in its effort to maintain normal circulation, has to maintain adequate blood pressure. And the blood pressure is nothing but the cardiac output. It is nothing but the cardiac output. We will put the CO into systemic vascular resistance. So the blood pressure is nothing but the cardiac output into systemic vascular resistance. Okay, so very simple point. Why I want you to know this physiology? Because later in pathology we will understand that if there is any reduction, so what happens in disease condition? In a cardiovascular disease condition, there can be reduction in the cardiac output. There can be reduction in the cardiac output. And in this situation, to maintain the cardiac output, maintain the blood pressure, there is increase in the systemic vascular resistance. All of you are familiar with the renin-angiotensin mechanism. All of you are familiar with the renin-angiotensin mechanism. So please remember that it is important to know the basics so that you will be able to correlate when you come to the medicine part of it. So we want to know this because the venous return, if it is adequate, the force of contraction will be good. That means adequate volume will be pumped by the heart. But just having adequate volume is not enough. It must also reach the tissue and organs with adequate force. And that is the role of systemic vascular resistance. That is the role of systemic vascular resistance to maintain the blood pressure. So blood pressure is nothing but cardiac output into systemic vascular resistance. And we all know that whenever there is a drop in blood pressure, the RAS, renin-angiotensin system, is activated. What it does? It increases the SVR and helps to maintain blood pressure. Okay? Helps to maintain blood pressure. Everybody, very simple slides I am giving you. Just we have to take it one by one. Okay? Simple slides. This is our simple slide. Physiology review of cardiovascular system. So next step, how do we measure, how do we assess the heart function? So the next question can be, okay, this is the job of the heart, we have understood. How can we assess the cardiac function? Okay, so next let us write down what are the parameters. What are the parameters that we can use to assess the cardiac function? What are the parameters that you can use to assess the cardiac function? That is step number 2. Okay, so all of you, just you have to listen and follow with me. So what we are discussing here is just we want to know that how to proceed. Okay, how do we understand this? So we know that the cardiac function is important to maintain adequate perfusion to the tissue and to the organ. Okay, to maintain adequate tissue perfusion. So how do we assess cardiac function? how do we assess cardiac function? So suppose the patient wants to know that, doctor, how do you tell me whether my heart is working well or not? Okay, so take it down. Number one, can we measure the stroke volume? Number one, we can measure the stroke volume. Number one, we can measure the stroke volume. Okay, number one, we can measure the stroke volume. So what is this stroke volume? Stroke volume is just the amount of blood pumped during each beat. It is the amount of blood which is pumped during each beat is called as the stroke volume. It is called as the stroke volume. So stroke volume is the blood pumped during each heartbeat. So can we measure the stroke volume? Answer is yes. But do we use it often in clinical practice? Answer is no. Because हम लोग ऐसे कभी नहीं कहते ना कि आपके हार्ट का स्ट्रोक वॉल्यूम 60 ml per beat है. No, we don't use that term, right? So here we don't use that term because it has got beat to beat variability. It has got beat to beat variability is present. Okay, so hence it is not used to in clinical practice to assess the cardiac function, because every beat is unique. Every beat has a different output. That's why we do not use this in clinical practice. So what can we use? We can measure the minute volume. We can measure the minute volume, which is also called as the cardiac output. So we can also measure minute volume, which is also called as cardiac output. Because what is minute volume? Minute volume is nothing but the stroke volume into the heart rate. Minute volume is nothing but the stroke volume into the heart rate. Stroke volume into the heart rate. So every beat may be pumping different quantity of blood, but over a minute you will get an average that how much blood is pumped within each minute. Okay, how much is pumped within each minute. So even a non-medical person knows that in an average adult, it is approximately 5 liter per minute. In an average adult, the cardiac output is approximately 5 liter per minute. All of you understanding 5 liter per minute. But what is forgetting? That we also must look at the demand of the body. So when you talk about adequate perfusion, it is not just on the heart to deliver the goods. It is also on the body to conserve its demand. So we want to know that what is the difference. So best marker, the best parameter is to measure the cardiac index. The best parameter is to measure the cardiac index. So what is better in cardiac index as compared to cardiac output? Cardiac index is the cardiac output divided by body surface area. It is the cardiac output divided from by body surface area. So it takes into account the demand of the body also. It takes into account the demand of the body also. So the best parameter, if somebody asks, that is MCQ is going to ask you that how do we assess the cardiac function? So cardiac index we can use to assess the cardiac function, because it is nothing but cardiac output divided by body surface area. And the normal cardiac index ranges from 2.8 to 4.2 liter per minute per meter square of the body surface area. Okay, so this is our second slide only. This is our second slide. You have to leave one page and you have to start from here. One page you can leave and start from here. So we have started that the cardiovascular system the main job is to maintain adequate tissue perfusion. To maintain adequate tissue perfusion, keep reviewing. There has to be normal heart, normal preload, normal afterload, normal blood pressure. If everything is normal, the patient will have no symptom. If somebody wants to assess the cardiac function, we want to know how the heart is whether doing well or not, we can ask the patient to undergo measurement of stroke volume, minute volume, and best is to measure cardiac index. So if the cardiac index is normal, we can say that the cardiac function is normal. Cardiac function is normal, right? So one page, the first page devoted to the physiology, basic understanding of physiology of the heart. So I'll keep going with you. So this is our page number 1. What we have understood is the basic physiology that is relevant to understand medicine. This is not a physiology class. We are reviewing only those physiology which is clinically relevant to understanding medicine. Let's go to step number 2. Step number 2 is the symptomatology of the cardiovascular system disorders. It is the symptomatology, right? Meter square. Body surface area, meter square, we have got the unit here. Symptomatology of cardiovascular system disorders. So let us write it down. Which are the 3 cardinal symptoms? Let us understand. Symptomatology of cardiovascular system. Symptomatology of the cardiovascular system. What are they? Number 1, when you think of heart disease, we can never forget angina. Number 2, we can never forget breathlessness. So there can be angina, breathlessness, and palpitation. Angina, breathlessness, and palpitations. What are we going to call them? These are going to be the 3 cardinal symptoms. These are the 3 cardinal symptoms of cardiovascular system disease. 3 cardinal symptoms of cardiovascular system disorders. We are going to call them. So why do we call them this? Understand, each point has got a value. Each point has got a specific reason. So when we think of any one of these symptoms, we call them as cardinal. Cardinal means characteristic. Cardinal means characteristic because you will suspect cardiovascular disease. So if the patient has any one or more of the above symptoms, if the patient has any one or more of the above symptoms, what we must do? We must suspect cardiovascular system disorder. We must suspect cardiovascular system disorders. So in short, cardinal means characteristic. The cardinal means characteristic of cardiovascular system disorders. So understand and write. So we know what is the normal function of the heart, we know. Now second step we are taking in a clinical medicine. When do we suspect that there can be a heart problem? And that clue comes from the presence of one or more of the cardinal symptoms. If one or more of the cardinal symptom is present, you are going to suspect cardiovascular system disorders. Okay. Before we evaluate, let us take up each symptom one by one. Okay. Once you suspect, then you will evaluate or you will assess. Then you will evaluate or you will assess. But before we go to this step, let us come to the angina, breathlessness, and palpitation. One by one, let us go like that. Okay. So first symptom, angina. Let us take the first symptom, angina. So angina actually does not come to you saying that it is angina, but rather comes as chest pain to the emergency department. Comes as emergency to the department. So, what is this chest pain? Why is it very important? So, chest pain is the number 3 symptom in the emergency room. It is the number 3 symptom in the emergency room. Please remember. So all of you are going to become soon interns, or already you are interns practicing doctors. If you work in the emergency room, even if you do one duty of 8-hour duration, you are likely to see a patient who has come to you with complaints of chest pain. It's a common symptom. Chest pain is a common symptom in the emergency room. Chest pain is a common symptom in the emergency room. So please tell me, all of you, when the patient walks to you with chest pain, what is the most common cause of chest pain coming to the emergency room? Most common cause of chest pain coming to the emergency room. Please remember, always remember the country we stay in. We are all hardcore Indians, no? We love to eat, and that too we love to eat spicy food. We love to eat spicy food. So the most common cause of chest pain is GI related. Most common cause of chest pain is GI related. Most common cause of chest pain is the GERD or the gastritis. Very good. So most common cause of the chest pain is the spicy food. Very good. But that's not serious, right? That is not serious. But please remember, as a casualty medical officer in the emergency room, you are not expected to diagnose and treat most common cause, but you are supposed to look for the most dreaded cause. You are supposed to look for the most dreaded cause. And the most dreaded cause is the angina. So cardiac angina is the most dreaded cause of the chest pain coming to the emergency room. Most dreaded cause is the angina, which is cardiac in origin, coming to the emergency room. So you have to understand. So number 3 means it is the third most common symptom coming to emergency room. I want all of you to listen carefully as the class is played, okay? Because there is no point keeping on repeating things that you have not heard. And do not ask questions till the session is over, because all your answers will be in the part of the discussion, okay? Wait for the end, then you ask the questions. Most dreaded cause of the chest pain can be cardiac, that is angina. So I want you all to tell me, what is the definition of angina? How do you say this is angina? Please write down. Okay, so chest pain. So chest pain having the two out of the three following features. Angina can be described as the chest pain having 2 out of the 3 following features. We can describe it as the chest pain having 2 out of the 3 following feature, okay, is going to be this definition of angina. Please remember that. So chest pain having 2 out of the 3 of the following feature. So note down, what are the feature? Feature number 1 is the typicality of the chest pain. Feature number 1 is the typicality of the chest pain. All of you, please remember, in Bailey and Lau, when you come to clinical history taking, there is a common format for all pain history. If the patient is telling after headache, abdominal pain or chest pain, what are you supposed to record? You are supposed to record A, the site of the pain. You are supposed to record B, character of the pain. You are supposed to record radiation of the pain, radiation of the pain, and you are supposed to record aggravating and relieving factors. You are supposed to record aggravating and relieving factors. Aggravating and the relieving factors. So this is a common points, relieving features we want to ask. So we want to know that now, okay? So typicality of the chest pain we want to know. So what is angina? All of you remember what is angina? Chest pain having 2 out of the 3 following features is chest pain. So number 1, you will take proper history which should include the site of the pain, character of the pain, radiation of the pain. Site of the pain is classically precordial. Left side, it is precordial. It can be retrosternal also. It can be retrosternal, substernal can be the description. So you will note down the point. Precordial, retrosternal, substernal could be angina. What is the character of the pain? It is described as heaving or constricting type of chest pain. It is described as heaving, constricting type of chest pain. And what does the patient have? Levine's sign. Patient comes with Levine's sign. What is that? Clenching the fist to the chest. Clenching the fist to the chest. It is called as Levine's sign. So we all have seen in Hindi movies or in your movies that patient comes with that is typical of chest pain. Angina, that is typical of chest pain. So heaving or constricting as if some heavy load is placed on the chest. Where does the pain radiate? The pain radiates. Where does it go to? Radiates to the classical left arm along the ulnar border. The pain classically radiates to the left arm along the ulnar border. It can radiate to the jaw. It can also radiate to the epigastrium. And that is why it's a very important differential for gastric pain. Please remember, angina can very often mimic gastric symptoms. Okay, so many times we may mistake and make a wrong diagnosis, but we must always focus on most dreaded cause in the casualty. And for that, first you will record the feature of the pain. So that should include site, character, radiation. If all 3 are present, we are going to call it as typical chest pain. We are going to call it as typical chest pain. Followed by that, you will take history of aggravating and relieving symptom. Aggravating and relieving symptom. Aggravating symptom, we know it worsens with exertion. Angina worsens with exertion. It worsens with exertion and it relieves with rest. Worsens with exertion and relieves with rest. This is the classical feature. So please remember, any cardiac symptom, I am telling you again, any cardiac symptom classically worsens with exertion and relieves with rest. That is one of the hallmark of cardiology symptom. But we all have heard that each symptom, angina, may not come with typical feature. There can be atypical presentation also. If both these are satisfied, suppose the patient comes with typical chest pain and has got aggravating with exertion, you can directly label this chest pain as angina because we need only 2. So if 2 are already there, you can say the chest pain is angina. But in a atypical chest pain, you will have to look for the third point, that is prompt relief with nitrates. That is the prompt relief with the sublingual nitrates. prompt relief with the sublingual nitrates is character number 3. I'm sure all of you know, in every casualty department you will see sorbitrate tablet is available. So prompt relief within 5 to 10 minutes. 5 to 10 minutes is characteristic of angina. Within 5 to 10 minutes is characteristic of angina. Please remember, very simple. Simple definitions are often not known to the students. That's why I make it a point to teach everything. I'm going to teach you everything from ABCD. After the basics are covered, then I will expect more answers from you. Okay, right now I want you to focus, understand, and grasp the basics of cardiology. So, number one symptom, angina, we are discussing. Angina presents to the casualty as chest pain. Chest pain is important because it is the third most common symptom presenting to the emergency room. But in India, most common cause is gastric. So how do we know that it is angina? You have to look for 2 out of the 3 of the following feature. 2 out of the 3 following feature you want to see. So typical chest pain aggravated by exertion, relieved with rest is angina. If it is not typical, if the symptom is relieved with rest, you must give a trial of sublingual nitrate. You must give the relief with sublingual nitrate, and you can say that this is also angina. Okay, so very simple. Let's take it step by step. So patient, now imagine the patient walking into your casualty. You are the casualty medical officer. Patient came to you with chest pain. You took the history. And you reached a diagnosis that this chest pain looks like angina. So you are going to tell the patient that this looks like angina. Let's take it forward. So the moment you say that patient that this is going to look like angina, he wants to know what is the cause. The patient is going to ask you what is the cause. So we want to know what are the mechanisms of angina. The patient is going to ask you what is the cause of the angina. What is the cause of angina? So once you tell the patient that your chest pain appears like angina, the patient wants to know what is the cause, what is the probable cause of the angina. So to understand the cause, you want to know what are the mechanisms of angina. So please remember, what does angina indicate? Angina basically indicates that there is imbalance between. Angina basically indicates there is imbalance between. There is imbalance between the demand and the supply. So there can be either due to decreased supply to the myocardium, or the angina can be due to increased demand of the myocardium. Can be due to decreased supply or increased demand of the myocardium. So we can broadly categorize the mechanism into two groups. So if the patient has angina, you will start thinking what is the probable cause of the angina. Pay attention, it's like a story. What is the cause of the angina? So more commonly, the defect lies in the supply. It shows it is in the supply. And the most common cause we say is the coronary artery disease. I'm sure all of you will agree with me that when a patient comes to the casualty with the chest pain, and the chest pain is angina, then we say that most likely क्या हुआ है आपको? आपको heart attack हुआ है. What do we say? हार्ट अटैक हुआ है, आपके हार्ट के नस में ब्लॉकेज है, coronary is blocked, that is the first thing that you are going to tell the patient, that more often than not, angina is a symptom of coronary artery disease. It is a feature of coronary artery disease. But remember, what is common in practice may not be asked in MCQ. May not be asked in MCQ. So MCQ क्या पूछेंगे? That what are the causes? MCQ is going to ask you causes. What are the causes in a patient with of angina with normal coronary? What are the causes of angina with normal coronaries? इसका मतलब क्या है? मोस्ट कॉमन कॉज को हटा दिया. It is not coronary artery disease. Okay, that means where is the problem? Problem is in demand. Problem is in demand, not in the supply. Supply is normal, but demand is more. That is when the patient will come with angina, but the angina will be with normal coronary. So think of the causes. What is the mechanism? There has to be ventricular hypertrophy. So why is there increased demand? There is increased demand due to ventricular, secondary to ventricular hypertrophy. Increased demand is due to ventricular hypertrophy. There is increased demand secondary to ventricular hypertrophy. So enumerate what can be the causes of ventricular hypertrophy. Number one, very good. There can be hypertensive heart disease. It can be due to hypertension. Hypertension, very good, can lead to ventricular hypertrophy, which can lead to angina in spite of having normal coronary. Number two, if it is not hypertension, myocardium muscle means disease of muscle is cardiomyopathy. Disease of the muscle is cardiomyopathy, especially hypertrophic forms. Later we will be learning what are the types of cardiomyopathy. We will be learning the types of cardiomyopathy. So we can understand that it can be due to defect in the muscle itself, cardiomyopathy, especially hypertrophic forms of cardiomyopathy, or it can be seen in valvular heart disease. Can be seen in valvular heart disease. Classical example, aortic stenosis. Very good. Classical example is aortic stenosis. Very good. I am very happy. So what are the points we want to learn? Make clear charts. Please remember. So again I am telling you the story from the start. You know the normal function of the heart. If the patient has heart disease, one of the cardinal symptom is angina. When angina patient comes to the casualty with chest pain, you have to exclude gastric cause. Confirm it is cardiac cause. If it is cardiac, most likely problem is coronary artery disease. But coronary normal also can come with angina, and there the causes will be hypertensive heart disease, cardiomyopathy, valvular heart disease, example being aortic stenosis. So we have got causes of angina. We have got the causes of angina. Right till here? Next step. So you have told the patient that you have got angina. You have got angina. Patient asked you, why do I have angina? You said mostly it is due to blockage in your coronary. The next question is, patient wants to know whether he needs to be admitted or not. Whether you need to be admitted or not. Next question, admitted or not. So that answer is to be still identified. So to understand that, we have to learn what are the clinical subtypes of angina. To understand the risk stratification, we want to understand the clinical subtypes of angina. What are the clinical subtypes of angina we want to understand? So go with me one by one. We have understood that this is angina. Now the patient wants to know, does he need admission or not? To answer that question, we want to know the clinical subtypes. Please remember, this is for risk stratification, to understand whether the patient needs to be admitted or not. Whether the patient needs to be admitted or not. So we want to know clinical subtypes of angina. In coronary artery disease, we want to know clinical subtypes. So one subtype can be the unstable angina. One subtype is the unstable angina. And by exclusion, please remember, unstable angina is the diagnosis. If you exclude that it is not unstable angina, you can use the word chronic stable angina. By exclusion, you can use the word this is chronic stable angina, can be identified. So clinical subtypes of angina we must know for risk stratification. So after we have made the diagnosis that it is angina, to decide whether the patient has to be admitted or not, you have to take further history to know, because clinical means history, no test. Clinical means history, no test. You want to know what are the clinical subtypes of the angina. As you can see, if it is unstable angina, patient needs immediate evaluation. If it is unstable angina, how do we say unstable angina? Unstable angina means all new onset angina. All the new onset angina less than 2 months duration. All the new onset angina less than 2 months duration should be considered as unstable angina. Those angina where there is progression in the NYHA class of symptoms. Progression in the NYHA class of symptom. NYHA is the New York Heart Association. So classification, if the patient has got recent worsening of the symptom. So patient might be having angina for 2 years, but recently he has noticed that the pain has become more severe, pain has become more frequent, or the pain has become more delayed in recovery. That is called as progression. Or if the patient has 3 or more episodes per day. If the patient has got 3 or more episodes per day, or the patient is continuously having angina at rest. So there is incomplete relief with rest. Incomplete relief with rest. Or the patient has history of MI, myocardial infarction, within the last 1 month. So please remember, when will you say that the patient has got unstable angina? Unstable angina are those patients of angina who are new onset less than 2 months, or progression in the past 2 months, having frequency more than 3 episodes per day, having angina at rest, or having history of myocardial infarction within 1 month. So why it is important? It is important to know this unstable angina is important to know, because in 85% of the cases it indicates acute coronary occlusion. So if the patient comes with any one of these features, in 85% of these cases, it indicates acute coronary occlusion. That means this is a part of acute coronary syndrome. This is a part of acute coronary syndrome which needs urgent evaluation and management. This patient needs urgent evaluation and management is required, we can say. Okay, so please remember, today first session we are discussing angina. Dr. Arvind sir has already covered myocardial infarction for you, In the topic of acute coronary syndrome, one of the topic was unstable angina. So these are the definition of unstable angina. So when patient has got any one of these symptoms, you call it as unstable angina. And these are the patients who need urgent hospitalization, evaluation and treatment. Urgent hospitalization, evaluation and treatment. By exclusion means what? If it is not unstable angina. Think of it, no? Very simple English language. If it is not unstable angina, means one of these is not there. None of these features are there. None of the features are there. That means it is not unstable. Then you can call this chronic stable angina. Chronic stable angina usually indicates chronic coronary occlusion. Not urgent. Okay, not urgent. Indicates chronic coronary occlusion. Okay, so less than 2 months of the present symptom. New onset means patient is having chest pain for duration less than 2 months. New onset means now, recent onset. The symptom is for less than 2 months duration. Okay. So chronic stable angina indicates chronic coronary occlusion. Yes, any one feature is called as unstable angina. If none of the features are present, we call it as chronic stable angina. These patients don't need hospitalization. This is a chronic problem. Indicates chronic coronary occlusion. But what is the pathology of coronary occlusion? What is the pathology of coronary occlusion? If you look at the pathology of coronary occlusion, the problem can be arteriosclerosis or it can be atherosclerosis. Arteriosclerosis or it can be atherosclerosis are the two potential pathology. It can be the two potential pathology. Okay, so indicates chronic coronary occlusion. It can be due to arteriosclerosis, atherosclerosis. Why is it important to know the difference? Important to know because arteriosclerosis. What is this arteriosclerosis? Arteriosclerosis is age related. It is age related. Degenerative process. It is a age related degenerative process because of which it is non-modifiable. Okay, because of which it is non-modifiable. I cannot do anything to prevent the progression. So when we hear family history, we say that when the patient is got family history, we say that patient have got family history of young MI. We cannot prevent it because it is a genetic process, maybe not modifiable risk factor. that is called as arteriosclerosis. While atherosclerosis is basically lipid deposition. It is our lipid deposition, which is preventable or modifiable risk factor, which is a preventable or modifiable risk factor. Okay, preventable or modifiable risk factor. Okay, so when the patient comes to you with angina, so we have to see the angina symptom is most important. ECG does not tell you anything. ECG requires clinical correlation. So based on the symptom, first we confirm that it is angina. If it is angina, we want to confirm if it is unstable angina. If it is unstable angina, immediately admit and treat the patient. If it is not unstable angina, we can say that it is chronic stable angina. We can say that it is chronic stable angina, which can be either due to arteriosclerosis or due to atherosclerosis. Can be due to atherosclerosis. What does the ECG show? You have discussed. It can show non-specific STT changes. It can show non-specific ST segment changes can be seen. Non-specific STT segment changes can be seen. The cardiac biomarker should be negative. It is chronic, no? Cardiac biomarker should be negative. That means you can say that it is not an emergency. We can say that it is not an emergency. Okay, it is not an emergency. And this patient, what is the drug of choice? What is the drug of choice for chronic stable angina? For chronic stable angina, during the acute attack, drug of choice is nitrates. In acute attack, it is nitrates. But the drug of choice for chronic prophylaxis, the drug of choice for chronic prophylaxis is going to be beta blocker. The drug of choice for chronic prophylaxis should be beta blocker. How does beta blocker work? Beta blocker reduces the demand of the myocardium and hence reduces the recurrence of angina. Hence it reduces the recurrence of angina. Right, everybody? Simple. Slide to slide I am going to give you. So what is the point here we have understood here? So look at the story from the start. Okay, I want all of you to listen carefully. Okay, listen carefully. We have started with chest pain. Then we confirmed it is angina. Now chest pain is over. Within angina, we further subclassified into unstable angina versus chronic stable angina. Unstable angina versus chronic stable angina. The treatment of acute coronary syndrome you have already studied with Arvind sir. Okay, you have already studied management of myocardial infarction. We are not going to go there. So this is the basic algorithm. So classical angina means the one due to coronary disease. It can be unstable or it can be chronic stable angina. Unstable angina, immediate hospitalization. Chronic stable angina, you will treat on OPD basis. You will treat on OPD basis only. So these are common. These are common where in practice. But what is common in MCQ? What is common in MCQ is the Prince metal angina. What is common in MCQ is the Prince metal angina. Let us read that, please. What is common in MCQ is the Prince metals angina. So we have to follow the trend here. I am telling you again and again, medicine is a unique session. Okay, medicine is a unique subject where you have to know the theory also and able to correlate with practical medicine. In the MCQ, your theory has to be strong. In practice, your application has to be strong. In our class, we want to achieve both objectives. I don't want you to become just good, knowledgeable people. I want you to become good doctors. Again, remember. Okay. So just we have to go step by step. So what is this? Prince metals angina. Prince metals angina is an important topic. Prince metals angina is a very important topic. So Prince metal is a very old terminology, described almost 50 years back. So what is this Prince metals angina? Let us see. What is this Prince metals angina? So according to original description, please write down. Okay. So Prince metal, original definition, we will write it in black. Update, we will write it in red. So Prince metal angina was described as angina due to coronary vasospasm. It was first described as angina due to coronary vasospasm. The definition: Prince metals angina was described as angina due to coronary vasospasm. इसीलिए प्रिंस मेटल एंजाइना को वैजोस्पास्टिक एंजाइना भी कहते हैं. Prince metal is also called as vasospastic angina. It is also called as. Okay, also called as vasospastic angina. Use our algorithm. ये vasospasm किस में होता है? Commonly affecting epidemiology, commonly affecting middle-aged females. Commonly affecting middle-aged females. So angina due to coronary vasospasm, typically affecting middle-aged females. The vasospasm is precipitated by intense stress or emotion. है ना, ओरिजिनल डेफिनेशन के तरफ ध्यान दीजिए. है ना, थिंक ऑफ ओरिजिनल डेफिनेशन के तरफ ध्यान दीजिए. Prince metal angina was described as angina due to coronary vasospasm affecting middle-aged female, which is precipitated by stress and emotion. Okay, but new points. है ना, old definition में क्या था? With normal coronary. Okay, old definition contained normal coronary. अब present day में वो valid नहीं है. So what has changed? So new points. We know vasospasm can also be precipitated by tobacco and illicit drug use. It can be precipitated by tobacco, amphetamine and cocaine. It can also be precipitated by tobacco, amphetamine and cocaine. So these are additional points now we have. So angina due to coronary vasospasm affecting middle-aged female, precipitated by stress, emotion, tobacco, amphetamine and cocaine also can cause vasospasm of the coronary. How do they present? Clinical feature. How do they present? They present as episodic angina. Very important word. All of you note it, please. Episodic angina. Episodic means unrelated to exertion. It is unrelated to exertion. That is the hallmark. And that is why it is also called as variant angina. Okay, that is why it is also called as variant angina. तो स्टार मार्क करेंगे. Why is it called as a variant angina? Because it is different from the routine ones. Coronary में हमने क्या पढ़ा? classical relation to exertion. But Prince metal comes as episodic angina, which has no relation to exertion, which has got no relation to exertion. इसीलिए ये बाकी सबसे अलग है. अलग का मतलब वेरिएंट है. अलग का मतलब है वेरिएंट है. वेरिएंट एंजाइना एपिसोडिक है. एपिसोडिक है. ओके, एपिसोडिक चेस्ट पेन लेकर आते हैं, एंजाइना ही होता है. पेन इज एंजाइना बट इट इज एपिसोडिक, अनरिलेटेड टू एक्सर्शन. तो आप अगर ईसीजी करोगे तो क्या मिलेगा? सो इफ यू डू ईसीजी, if you do ECG during the episode, if you do the ECG during the episode, you can see transient ST segment changes. You can see transient ST changes. So जब पेशेंट को दर्द हो रहा है during the episode, if you do the chest ECG, you will be able to see transient ST changes. Elevation भी हो सकता है, can be elevation also. Okay, fine. Elevation also can be there during the episode. Elevation can also be there in the given ECG. But important is to say, if you record ECG during asymptomatic period, the ECG may be normal. If you record it during the asymptomatic period, the ECG can be normal. And that is why what can be there? It can be wrongly mistaken. It can be wrongly mistaken as panic or stress disorder. So that is why it is a differential diagnosis for panic or anxiety attack. For a panic or anxiety attack it can be. Okay, so we must remember that if you record the ECG when the patient does not have symptom, you will wrongly refer the patient to a psychiatrist, because the patient ECG looks normal and it is precipitated by stress and emotion. So Prince metal angina, remember, always you must remember as a differential in a panic attack. You must exclude coronary vasospasm. Next point, what happens if you do cardiac biomarker? Come on, what will happen to the cardiac biomarker? Biomarkers are always negative because there is no infarction. This is only angina. There is no infarction. This is only angina. So biomarkers are always negative in variant angina. They are always negative. So how do we confirm? We proceed for coronary angiography. We go for a coronary angiography, short form. We go for a coronary angiography. In the coronary angiography, 50% cases can be normal. 50% have normal study, but the remaining 50% can have significant coronary artery disease. 50% can show significant coronary artery disease. Patient can have both places. So please remember, previously कैसा था situation? Prince metal angina, original definition था angina due to spasm in middle-aged female precipitated by exertion with normal coronary. But that is no longer true. It is seen that 50% can have additional significant coronary artery disease also. Please remember, that is an important change in the variant angina. It has got change, important change can be present. So how do you confirm? Because coronary angiography normal भी हो सकता है, abnormal भी हो सकता है. So coronary angiography can be normal as well as abnormal. So to confirm the diagnosis, gold standard, to confirm the diagnosis, gold standard is to go for intracoronary. Go for intracoronary acetylcholine injection. Intracoronary acetylcholine injection to demonstrate the vasospasm. To demonstrate the vasospasm. So coronary anatomy is not the problem. Physiology is the problem, no? So basically, you have to, during the coronary angiography, the cardiologist has to inject intracoronary acetylcholine injection to demonstrate the vasospasm. It is the gold standard test. Okay, it is the gold standard test. It is the gold standard test. Once you confirm the diagnosis, what is the treatment? Once you confirm the diagnosis, what is the treatment? Again, the treatment during acute attack, you will give nitrates. During the acute attack, the drug of choice is nitrates. During the acute attack, drug of choice is nitrates. Drug of choice is nitrates, but different from the others. What happens here? For chronic prophylaxis, in the previous page, what did we say? What is drug of choice for chronic prophylaxis in a classical angina? We said beta blocker. GS का मतलब है गोल्ड स्टैंडर्ड. ओके, सो क्रॉनिक प्रोफाइलैक्सिस में यहां पर हमें क्या देना है? हियर द ड्रग ऑफ चॉइस इज कैल्शियम चैनल ब्लॉकर. द ड्रग ऑफ चॉइस इज कैल्शियम चैनल ब्लॉकर. ओके, दिस इज द डिफरेंस. स्पाज्म का ऑपोजिट है. स्पाज्म का ऑपोजिट इज डायलेटेशन. यू हैव टू गिव वैसो डायलेटेशन. You have to give vasodilatation. Unlike classical angina, here beta blockers are avoided. Beta blockers are contraindicated because they can precipitate vasospasm. So rather than confirming, they can precipitate vasospasm by allowing unopposed alpha action. By allowing unopposed alpha action on the coronaries. Okay, so this is the difference. That's why the topic is commonly asked. Yes, gold standard investigation of choice is the same. It is the same. Beta blockers are contraindicated because they can precipitate vasospasm by allowing unopposed action on the coronary. Unopposed alpha action on the coronary. So when we all know, during stress, okay, during stress, what will happen? There will be sympathetic overactivity. Catecholamine release will go to the coronary. If you have given beta blocker, heart rate may not increase, but alpha action will occur and it can precipitate vasospasm. Can occur. And that is why the drug of choice for calcium channel blocker is to go for chronic prophylaxis is calcium channel blocker. Okay, is the calcium channel blocker. Now in this also, calcium channel blockers are divided into two groups. The calcium channel blocker can be divided into two groups. We have got the non-dihydropyridine and the dihydropyridine group. And we have got the non-dihydropyridine group of calcium channel blocker are present. So we have got two groups of calcium channel blocker. This is the one which is commonly used. This is your nifedipine, amlodipine, etc. We have got nifedipine, amlodipine, etc. are the dihydropyridine group. Dihydropyridine group, right? But what is the problem here? They also have significant reduction in BP. They cause significant BP reduction, which can cause hypotension in this patient, because the patient is not a hypertensive. Patient is not a hypertensive. So remember, you have to take it in the context of the patient. Patient is a middle-aged person who is not hypertensive. So if you give nifedipine, they can start getting hypotension. So the non-dihydropyridine, which is your diltiazem, verapamil, are preferred in practice. Verapamil are preferred agents. They are the preferred agents for Prince-Metal's angina. They are the preferred agent for Prince-Metal's angina. Okay, so look at this whole point here. So first, very good, what we have to do when the patient, take the whole topic together, everybody with me. Okay, first points we have covered. Let us start from the beginning. Everybody focus with me. Once you have finished writing, you focus with me. We will do a quick recap now. Has everybody finished writing? Right? So again, let us start from the beginning. Start from the beginning again and again. I'll make sure that every single word is registered in your cortex. Okay? So please remember, one of the cardinal symptoms of cardiovascular system disease is angina. What is angina? Chest pain having 2 out of the 3 features is called as angina. If the patient is angina having classical relation to exertion, most likely cause is coronary artery disease. Within the coronary artery disease, if the occlusion is acute, it can be unstable angina. If it is chronic, it is chronic stable angina. Unstable angina treated with protocol of ACS, acute coronary syndrome. Chronic stable angina, acute case, give nitrate and start patient on beta blocker for chronic prophylaxis. But if angina is there but not related to exertion, angina is there but not related to exertion, we must consider the diagnosis of Prince-Metal angina, vasospastic angina, and variant angina, Okay, so this is how to approach the point. Please remember that the acetylcholine does not cause vasospasm in normal person. Acetylcholine does not cause vasospasm in a normal person. But in patient of Prince-Metal, it can cause the problem. It can cause vasospasm. And that is how you confirm diagnosis. Clear? So every point I'm going to give you page to page notes. Okay, one topic, one page, and we should be sorted. Okay, so that is the rationale. Intracoronary acetylcholine does not cause vasospasm in you and me. Normal में नहीं होता. Only in Prince-Metal angina it will cause vasospasm. Right? चलिए, let us go ahead further. So first symptom we have taken care of. I'll keep taking you back and forth. First symptom, I hope you are all clear. Angina. Clear हो गया सबको? Right? So we have got angina. We have got clearly angina. चलिए आगे चलते हैं. Second symptom, breathlessness. Second symptom पढ़ते हैं breathlessness. right? Second symptom, let us study. Breathlessness, we want to study, right? So as one of you already pointed out, very important step. What is breathlessness? So breathlessness is same as shortness of breath. Breathlessness is same as shortness of breath. Everybody write with me. Everybody write with me. Simple है. Breathlessness, shortness of breath. Okay. We don't do in all patients acetylcholine. Clinically suspect होना चाहिए ना. If you suspect variant angina, तो angiography के time पे you can give acetylcholine injection. Not routinely. It is not done routinely. Okay. Not done routinely. अरे classical angina means angina related to exertion. Classical means angina related to exertion. ठीक है, चलते हैं. So breathlessness, shortness of breath. So as you say, what it is? Number one most common symptom in the emergency room. Most common symptom in the emergency room. Most common symptom in the emergency room. Shortness of breath. SOP का मतलब है shortness of breath. सो पेशेंट का सेकेंड सिम्टम है हमारे पास शॉर्टनेस ऑफ ब्रेथ. इट इज द मोस्ट कॉमन सिम्टम इन द इमरजेंसी रूम. सो हमने क्या पढ़ा? चेस्ट पेन थर्ड कॉमन सिम्टम है, ब्रेथलेसनेस मोस्ट कॉमन सिम्टम है. तो सेकेंड कॉमन सिम्टम कौन होता है? एनकेफेलोपैथी. इमरजेंसी रूम में है ना. न्यूरोलॉजिकल क्लासिफिकेशन, neurological classification, okay, is number 2 encephalopathy. तो क्वेश्चन आप पूछ रहे थे ना, what are the three common symptoms in emergency? Three common symptoms in emergency. Most common symptom in emergency room is breathlessness. Second common symptom is altered sensorium. Third common symptom is chest pain. Okay, third common symptom is chest pain. So breathlessness or shortness of breath, इसमें most important step, what should we do? Most important is to differentiate. Most important is to differentiate between the breathlessness of cardiac cause versus respiratory cause. Most important step is to differentiate between breathlessness, whether it is cardiac cause or respiratory cause. That is the most important step. When you get a patient of breathlessness in the emergency room, already I had questions before. What if it is angina? That is what we will discuss now. What if it is asthma? So the patient, when patient you see a patient of breathlessness in the casualty, you see a patient of breathlessness in the emergency room, the first step you have to look for is to know whether it is cardiac cause versus respiratory cause. To help understand whether it is cardiac or respiratory, let us take an example, clinical example. So let us say patient is a 65-year-old male. Patient is a 65-year-old obese male. Patient is a 65-year-old obese male who is also a chronic smoker. Patient is a 65-year-old chronic obese male, also a chronic smoker. Now all of us know obesity, male gender can be risk for coronary artery disease. So the patient can be, the breathlessness can be due to acute heart failure. The breathlessness can be due to acute heart failure. Okay, so breathlessness can be due to acute heart failure. But the patient is also a chronic smoker. patient is also a chronic smoker. So this could be infective exacerbation of COPD. It could be infective COPD exacerbation also. ठीक है? So what is we understanding here? कि when patient comes with the breathlessness or shortness of breath, which is the most common symptom in the emergency room. The most important job of the doctor is to differentiate whether it is a cardiac problem or a respiratory problem. Common example, if an elderly male who is obese smoker comes with breathlessness, the one of the cause can be heart failure or it could be COPD exacerbation. We have taken an example to help differentiate between the two. Infective means patient has a viral infection, bacterial infection, which will cause exacerbation of COPD. So how to differentiate, ये point याद रखिए. How to differentiate, ये point को याद रखिए. So how to differentiate means what? So we have to always, for all of you, remember the dictum. Whenever you are asked to differentiate between two conditions, you must learn the differences in the symptom, difference in the sign, and difference in the test. So jabhi, when we want to differentiate, you must learn what is difference in the symptom, differences in the sign, and differences in the testing. Then only we will be able to reach the final diagnosis. So first symptom के बारे में. So what we will take history about the breathlessness itself. What you will ask about the breathlessness? You will ask for relation to exertion. First history, you will say what is the relation to exertion, whether the breathlessness is associated with exertion or not, and we learned in cardiac it is classical relation. There is a classical relation. We have learned angina क्या होता है? Aggravated by exertion. Same way, cardiac breathlessness aggravated by exertion. Cardiac breathlessness is aggravated by exertion. Respiratory has no relation. It has got no relation like Prince metal. इसीलिए नाम क्या दिया हमने? Episodic breathlessness. Can you recall? Prince metal के साथ हमने क्या लिखा? We have written that episodic angina means there is no relation to exertion. In respiratory disease, there is no direct relation to exertion. It can occur paroxysmally. Patient can get a breathlessness attack in sleep also. So it has got no relation. Okay, ये breathlessness की बात चल रही है ना नियति. There is no question of Prince metal. There is no angina. We are talking about different symptom. So relation to exertion we will ask. Number 2, what we have to take history? History of associated symptoms. We must take history of associated symptom. We will ask for. Take history of associated symptom. हमने पूछना है. Because the dictum in medicine says that disease is known by the company it keeps. The disease is known by the company it keeps. बोलते है ना? So what it is? Associated symptom. We will ask. If the breathlessness is due to cardiac, before the breathlessness, patient can also have complaints of angina, palpitations, syncope, and edema fit. So patient can have other cardiac symptoms also. Patient can have other cardiac symptom also. While if the cause is respiratory, if the cause is respiratory, then the patient problem क्या है? Infection है. So patient gives history of cough. Patient can have fever. Patient can have hemoptysis. Patient can have hemoptysis. So please remember, so respiratory patient can have cough, fever, hemoptysis history before the onset of breathlessness. Before the onset of breathlessness. Based on the history, you can probably say what is the problem. Probably cardiac, probably respiratory. ऐसे हम बोल सकते हैं. But फिर we examine the patient. We examine the patient. So we start with general examination. In general examination, what are we going to see? Pulse, blood pressure, respiratory rate. We look for central cyanosis. We look for cyanosis. So we can start with general examination. We can start with general examination. Yes. So general examination, we can look for pulse, blood pressure, respiratory rate and presence of central cyanosis. Okay, this is the very important place where we make a wrong point. Okay, you tell me, suppose the patient of breathlessness has got a pulse rate of 126 per minute. Patient has got tachycardia. Patient has got tachycardia. Can you tell me whether it is cardiac or respiratory? Can you tell me whether it is cardiac or respiratory? On general examination, if the patient has tachycardia, can you tell me whether it is cardiac or respiratory? Yes or no? Answer type करिए. Yes or no? Can we say tachycardia means cardiac cause? Yes or no? Answer yes or no? Answer is definitely no. Okay? Please remember, general examination correlates with severity. Very good. It correlates with severity, not the cause. It correlates with the severity, not the cause. Yes, it does not confirm that it is cardiac. The tachycardia, etc., correlates with severity, not the cause. It can be present in both. It can be present in both. So if the patient has tachycardia, if the patient has tachycardia, if the patient has tachypnea, if the patient has hypotension, if the patient has cyanosis, what does it indicate? It indicates severe disease. Does not tell you where is the problem. Very good. Very good. It can be seen in both. So this feature does not help identify the disease. Then what will help? What will help? Auscultation finding. Auscultation can help you. Auscultation findings can help you. Auscultation findings can help you differentiate between cardiac and respiratory cause. Cardiac and respiratory cause. In cardiac cause, what we get classically? Inspiratory crepitation. Classical point. Inspiratory crepitations. And respiratory में classical finding expiratory wheeze. Classical finding is expiratory wheeze is present. So we can say that auscultation can help identify the probable cause of the disease. Help identify the probable cause of the disease. Okay. But unfortunately, if I ask you that to differentiate between crepitation, RAL, Ronchi and V's, all of us may fail that exam. Okay, trust me, it is not just us. Even Rajnikant will fail that exam because it is literally impossible to differentiate. एग्जाम में हम फेंकते, एग्जाम में वी जस्ट से समथिंग है ना, मस्ट बी दिस मस्ट बी दैट, यू कैन नेवर बी श्योर बिकॉज इट इज सब्जेक्टिव है ना, मैंने सुना तूने सुना अलग हो सकता है, यू कैन से समथिंग एग्जामिनर कैन से अदर थिंग, इट इज पॉसिबल. So it is not wise to focus on the sound, but what is important? Focus on the phase affected. Focus on the phase affected, not on the sound. So in auscultation, focus on the phase affected. Focus on the phase affected, not the sound. So please remember, these are the important practical points that we must know. That we can just say anything, okay? But to help differentiate in practical medicine, I want you to look for the phase affected rather than the sound itself. And finally, we want the best test. Come on, what is the best test to differentiate? The best test to differentiate is to go for a pro-BNP assay. The best test is to go for a pro-BNP assay. Best test is to go for a pro-BNP assay. We can go for a pro-BNP assay. That is our best test which can come. Pro-BNP assay can be done. So in this pro-BNP assay, what is the point? Okay. So what is this pro-BNP assay? Let us learn about it, then come back and fill the table. Okay. The best test to differentiate is to learn about the BNP assay that we will learn here. So let us learn what is this pro-BNP. So let us learn what is BNP. So BNP is the brain natriuretic peptide. It is the brain natriuretic peptide. BNP is the brain natriuretic peptide. Right? So this is got here that there is brain natriuretic peptide. This brain natriuretic peptide is secreted. Brain natriuretic peptide is secreted by the ventricular cardiomyocyte. It is secreted by the ventricular cardiomyocytes in response to the stretch or strain on the ventricles. In response to the stretch or the strain on the ventricles. So BNP, the pro-BNP, is secreted by ventricular cardiomyocytes in response to the stretch or the strain on the ventricles, and that is why elevated BNP is specific for heart failure. It is specific for cardiac cause of the disease. Okay, it is the specific for cardiac cause of the disease, and it is prognostic in heart failure also. Prognostic also, because when the BNP is more than 1000, it indicates poor prognosis. So elevation in BNP is specific for heart failure, and in heart failure it is prognostic also. It is prognostic also. That is, if the BNP is more than 1000, that means it indicates severe form of heart failure. So this BNP is available as a card test. The measurement is available as a card test, and you can get the results, rapid result, within 7 minutes. rapid result can be there within 7 minutes. Okay, so available as a cart test, and hence it is most preferred in emergency. Hence it is the most preferred biomarker in the emergency. Most preferred biomarker in the emergency. No, it has got no relation to renal failure. Renal failure has the fluid overload state. That is why it can be more. But otherwise, it is still a feature of heart failure. It is a feature of heart failure. है ना? BNP, ANP सेम कैसे हो सकता है ना सर? अगर if I am writing it separately, why are you asking such questions also? है ना? So ANP is atrial natriuretic peptide, that is from atria. This is from the ventricular vessel wall. है ना? So ventricular cardiomyocyte. So why it is termed BNP? Because it was first discovered in the bursa of birds. Okay, that is why it was there. It was first in the bursa of birds, and that's why we have it here. So specific for heart failure. So we must also know the new approved markers. Which are the new approved biomarkers for the diagnosis of heart failure? Approved biomarkers for the heart failure. So basically they are alternative to BNP. That means they are alternative to BNP. That is what it is. Okay. So new approved biomarkers for heart failure. So you have got the answer 1. In heart failure, most preferred biomarker is BNP, brain natriuretic peptide. But which are the new approved biomarkers? Which are the new approved biomarkers? Approved biomarkers include soluble ST2, and the galectin-3 for MCQ. Soluble ST2 and the galectin-3 for MCQ. So what is the advantage? Both of them have got equal sensitivity. They have got equal sensitivity like BNP. They have got equal sensitivity for diagnosis of heart failure. Equal sensitivity for the diagnosis of heart failure. They have actually better prognostic value. They have better prognostic value as compared to BNP. So in comparison to BNP, their sensitivity is same, specificity is same, and prognostic value is better. But still, why it is not used in emergency? Because no rapid test available. Yet, no rapid test available yet. No rapid test available yet. And that is why in the emergency room, the most preferred biomarker remains BNP. In the emergency room, most preferred biomarker remains the BNP or the pro-BNP assay. So BNP has got a short half-life. It is derived from the pro-BNP. So we write it like that. Pro-BNP assay. We derive it from the pro-BNP. Troponin has got no role in heart failure. Please note it very clearly. What is the role of troponin in heart failure? What is the role of troponin in heart failure? It has got only limited prognostic value. It has got very limited prognostic value only. Troponin is not for diagnosis of heart failure. Please remember, don't make it a mistake. So brain natriuretic peptide is secreted from the ventricular cardiomyocyte. Hence, if it is elevated, it indicates that there is increased strain on the ventricle. which can be taken as a marker of heart failure, can be taken as a marker of heart failure, it is called as. So going back to complete our table, what we can say, in a evaluation of breathlessness, in the evaluation of breathlessness, we can go for pro BNP assay. If BNP is elevated, it is specific for heart failure. Specific for heart failure. While respiratory, the BNP remains normal. In respiratory, BNP remains normal. Okay. So please remember, do not confuse the class. Okay. Confusing yourself and confusing the class by asking random question. अभी नेफ्रोलॉजी चल रहा है क्या, है ना, तो वेट करते ना. Let us now focus on what is being taught. Then I will allow you to ask all your questions at the end and we will discuss it also, है ना. तो ऐसा नहीं है कि हम बीच क्लास को डिसरप्ट करें, है ना. So that's not the way, because it's not running away. Okay. So for troponin what I have written, that troponin heart failure में it has only limited prognostic value. It has got only limited prognostic value. Okay, right till here. So we have completed the second symptom. Second symptom is breathlessness. We have completed second symptom, that is breathlessness. Breathlessness is important. It is most common symptom in the most common symptom in the emergency room, and it can be either respiratory or cardiac also, right. So coming to the third symptom of cardiology, we have got palpitations. So third symptom of cardiology, we have come to palpitation, third symptom of cardiology, right. What is, okay, third symptom of cardiology? Palpitation. Okay, so tell me, if I say palpitations are awareness of, palpitation is defined as awareness of one's own heartbeat. Palpitation is defined as awareness of one's own heartbeat. Is it right or wrong? So palpitation, okay, palpitation, awareness of one's own heartbeat, is it right or wrong? That's what we have to know. Is it right or wrong? Is it right or wrong? Answer, not complete. The important word to make it a symptom is the word unpleasant. ये बहुत जरूरी है. The word unpleasant बहुत जरूरी है, because we all have experienced na, in Hindi cinema, in Bollywood movies we have seen, when hero sees the heroine, है ना, गाने बजने लगते, you start getting heart rate, palpitation, दिल धड़कता है, but that does not bring the hero to the doctor, because that is a pleasant sensation, है ना. Pleasant awareness is not a symptom of heart disease. Pleasant awareness is a symptom of romance probably, but not of the cardiovascular disease. Cardiovascular disease का symptom होने के लिए the sensation has to be unpleasant awareness of one's own heartbeat. Unpleasant awareness. If it is unpleasant awareness, we want to look at the mechanism and the causes. So how we remember? Palpitation indicates either a disorder of rate and or rhythm. It indicates disorder of rate and or rhythm. It can also indicate a disorder of force of contraction. Disorder of force of contraction, which is seen in hyperdynamic states, which is seen in the hyperdynamic states, can be seen in the hyperdynamic states. Okay, so we have got here palpitation is an unpleasant awareness of one's own heartbeat. It indicates if the patient has got palpitation. Mechanism dekh rahe. Mechanism can be disorder of rate, rhythm or force. So three principles: rate, rhythm or force may problem. Okay, so this is how we are going to see. So what is the definition? Disorder of rate and or rhythm is arrhythmias. Disorder of rate and or rhythm is nothing but arrhythmias. Rate and or rhythm is called as arrhythmia. So arrhythmia, which arrhythmia? Please remember, palpitation can be seen in both brady and tachyarrhythmias. In both brady and tachyarrhythmias, you can get palpitation. In both brady and tachyarrhythmia, you can get palpitation. That is why we say in arrhythmia, palpitation is the most common symptom, most common feature of arrhythmia, not the other way around. So in patient of arrhythmia, irrespective of the arrhythmia, the most common feature is palpitation. But that does not mean most common cause of palpitation is arrhythmia. No, most common cause is just a hyperdynamic state. Most common is the hyperdynamic state. So tell me, which are the hyperdynamic states? Hyperdynamic state always start from physiology. Physiology, it can be exercise, pregnancy. Whenever you are asked in the Viva question, Viva exam also, always start with physiology. What are causes of palpitation? Palpitation can be due to exercise, can be due to pregnancy, that is physiological cause. Common pathology. Common pathology can be due to fever, can be due to anemia, that is common cause. Fever, anemia, common cause. Little rare, thyrotoxicosis can be seen in thyrotoxicosis. And last rare cause, you will say beriberi. Rare cause is beriberi. This is due to your thiamine deficiency. So this is how you will answer the question. So when you read also, I want you to read it. I want you to read in a way of commonness. There should be a pattern in which you answer the question. If you form a pattern, you are likely to remember more information accurately. Okay, more information accurately. That's why we want to learn in a simplified manner. Okay, so we have taken care of three of the symptoms. We have taken care of the three cardinal symptoms of cardiovascular symptom disorder. Everybody with me? So what we have got here? We discussed angina, breathlessness and palpitation. We have discussed here. So what we know? Again, I am repeating for you. Now each one of you is expected to know the normal function of the heart, the parameters to assess cardiac function, and the three cardinal symptoms of cardiovascular system disease and how to clinically approach these symptoms. Because in theory we know that if any one or more of the above symptom is present, any one or more of the above symptom is present, we must suspect cardiovascular system disorder. we must suspect cardiovascular system disorder, and that calls for evaluation. That calls for evaluation. Evaluation means our assessment methods. Evaluation means we must know about the assessment methods. Right here. So evaluation means we must know about the assessment methods. I want you to learn. So let me take you back. How we have approached this? I will take you back. Integrated medicine. How have we approached this? Everybody, come on. So we have studied review of physiology. We have studied review of physiology. Now we know the symptomatology of cardiovascular system disorders. We know symptomatology of cardiovascular system disorders. And now we want to learn the assessment methods. Now we want to learn the assessment methods and classify the disease before we go to individual topic. We want to learn assessment method and classify before we go to individual topics. So write down please, new page, new page. What are the assessment methods in cardiology? I want you to take a new page. What are the assessment methods? What are the assessment methods in a patient of suspected cardiovascular system disorders? What are the assessment methods that we must know in a patient with suspected cardiovascular system disorder? What are the assessment methods in a patient with suspected cardiovascular system disorders? Okay, so I want us to write the flow chart here. Write down the flow chart here. Right. So assessment method. I hope all of you know now how to suspect cardiovascular system disease. Now we proceed further. In every patient, Harrison says, in every patient must undergo number one, detailed clinical examination. The patient must undergo detailed clinical examination. Write it with me, please. Write it with me. Patient with suspected cardiovascular system disorder must undergo detailed clinical examination. Must undergo ECG. Must undergo ECG. Must undergo echocardiography. Must undergo echocardiography with color Doppler of the heart. Echocardiography with color Doppler of the heart. Every patient must undergo. Please remember. So every patient with suspected cardiovascular system disorder must undergo detailed clinical examination. Must undergo electrocardiogram. Must undergo echocardiography with color Doppler of the heart. With color Doppler of the heart. We must understand. Now, what detailed clinical examination must we do? In the detailed clinical examination, I want us to learn about we want to learn about arterial pulse examination. Arterial pulse examination and JVP interpretation. I want us to learn about arterial pulse examination and JVP interpretation. I want us to learn about pulsus paradoxus. We want to learn about pulsus paradoxus and Kussmaul's sign. Pulsus paradoxus and Kussmaul's sign. I want you to learn about the cardiac sounds, heart sounds and murmurs. The heart sound and murmurs. This is what I want us to learn. So again, please remember, make a clear pattern how to approach the topic. So once we know that the patient is a suspected case of cardiovascular disease, we must examine the arterial pulse. We must check for JVP. We must check for pulsus paradoxus and Kussmaul's sign. We must auscultate for heart sounds and murmur. We must record ECG. What does the ECG tell you? It helps evaluate. It is a electrical representation. It is a electrical representation of the cardiac conduction. It is a electrical representation of the cardiac conduction. Electrical representation of the cardiac conduction. And what is ECG? It is the best screening. ECG is the best screening as well as gold standard test for all arrhythmias. It is the best screening test as well as the gold standard test for all arrhythmias is the ECG. Okay, so we want to record ECG along with echocardiography. What does echocardiography tell you? Echocardiography gives you structural assessment. Echocardiography gives you structural assessment, and color Doppler tells you the functional assessment. Tells you the functional assessment. Tells you the functional assessment of the heart. Okay, yes, we have to focus on this approach. So echocardiography with color Doppler together we can say is the best screening. It is the best screening as well as gold standard test for all structural heart disease. For all structural heart disease. So we must know that every patient with suspected cardiovascular disease must undergo all these three tests. Must undergo clinical examination, ECG, echo with color Doppler. Only if all of them are normal, if examination is normal, ECG is normal, echo is normal, you can exclude cardiac disease. Okay, that's the simple point. So every patient with suspected cardiovascular disease must undergo all three tests. Must undergo all three tests. And what is our objective? To make the diagnosis. Our objective is to reach the diagnosis. So let us classify here. What is the classification of cardiovascular system disorders? The classification of cardiovascular system disorders. Cardiovascular system disorders. We want to look at the classification because using the assessment method, we must know what is our endpoint. What is the final diagnosis that we want to reach? What can we do to reach the final diagnosis? So cardiovascular system disorders, broadly, I am going to divide them into three groups. One group is basically the functional disorders. They are the functional disorders. We have got structural heart disease and we have got vascular diseases of the heart. So we will classify cardiovascular diseases into three groups: functional disorders, structural disorders and vascular disorders of the heart. Okay, broadly classify into three: functional, structural, and vascular disorders of the heart. Under the functional disease, we want to discuss the topic of arrhythmia. Under the functional disease, we want to discuss the topic of arrhythmias. Under structural disease, we want to discuss valvular heart disease. We want to discuss cardiomyopathies. We want to discuss cardiomyopathies. We want to discuss pericardial disorders. So first step is to classify the disease so we can plan our day. So under structural disease, there is valvular heart disease, there is cardiomyopathy, or there is pericardial disease. We can see. Under vascular disease, we have hypertension and coronary artery disease. Hypertension and coronary artery disease, which is already covered by Dr. Arvind sir. Okay, so this part we are going to not cover in our session. This will be totally covered by Dr. Arvind sir. So we have attended. You can integrate your notes with both of them. Okay, you can integrate the notes here. Hypertension and coronary. Except for that, all other topics we will discuss in our class. Except for these topics, we will review all other topics in our class. Okay, and the end point of all these diseases, arrhythmia, if it is left untreated, structural disease or vascular disease, if left untreated, the end point of all these diseases is the topic of heart failure. Okay, is the topic of heart failure. Very good. If arrhythmia is also done, I am very happy. So I will ask you questions, so that will make it easy for you, right? So ECG arrhythmia has been covered in detail by Arvind sir. ECG and arrhythmia has been covered by Arvind sir. So we are going to make a simple review. Okay, if you don't want to attend that review, you can easily leave it, no problem. Anna, you can take that extra time for doing time pass, or you can attend and review the topic again, nothing wrong, because these topics are extremely important. That's why we are reviewing. Okay, it is, remember this please, it is always better to learn from different teachers, because you only get more. If you can bridge their notes together, you can only get better idea. Okay, so this is our point here. Okay, this is our point that we want to learn. Okay, in the first 2 hours, this is where we are. So what we have understood: physiology, we know the symptomatology, we know which are the assessment methods, and we know classification of cardiovascular disease. We know the classification of cardiovascular disease. We have got it here. Okay, so what we will do, before we start with our clinical examination, we will take a 15-minute break. Okay, it is 3:10 now. Okay, it is 3:10 now. We will take a 20 minutes break before we start with clinical examination. So 3:30 there is a break. You can have your tea and coffee and you can come back. Okay, we will start with our clinical examination. Right? Chalo, run away everybody. I will join you back at 3:30. We will join you back at 3:30. Right. So welcome back. Yeah. So we'll continue where we have left. So I'm telling you that we will be doing simple small sessions. Okay, sessions which connect the topic together. So it is not about your choice or my choice. The choice of break depends on the topic we are doing. Okay, So let us respect medicine more than ourselves. Let's get going. Right. So to continue this start of the session, we want to begin with the assessment method number 1. Okay, chalo. Now everybody pay attention. We have to start one by one. I hope everybody is clear till symptomatology. Now we are going to start with the assessment methods. We are going to start with assessment methods. So the first step we are going to take in assessment methods, we are going to start with examination of arterial pulse. We are going to start with examination of arterial pulse. Okay, chalo, let's get started. Arterial pulse. So we'll start with the definition of arterial pulse. We'll start with the definition of arterial pulse examination. So please remember, we have to remember how to go about this. Okay. So arterial pulse is defined as the transmitted waveform. It is defined as the transmitted waveform of the left ventricular contraction. Okay, start with the definition. It is defined as the transmitted waveform of the left ventricular contraction. So arterial pulse, we all are familiar that in practical life, whenever you go to a doctor, especially whether or not cardiac disease, the first thing we examine in a patient is the pulse. We examine the pulse. So transmitted waveform of the left ventricular contraction is arterial pulse. So we must know interpretation. So arterial pulse, if it is normal, what can we say? It indicates, if the arterial pulse is normal, it indicates that there is effective left ventricular contraction. It indicates that there is effective left ventricular contraction is what it will tell you. Okay. So indicates effective left ventricular contraction. So if the arterial pulse is normal, it indicates that LV is not just contracting, but it is contracting effectively so as to ensure that the pulse waveform is felt at the periphery. So we can say that it indicates effective LV contraction. What is the best method, best method to examine the pulse? The best method to examine the pulse is called as the method of trisection, 3-finger method. It is the method of trisection, the 3-finger method. So in our viva and in our practical exam, we are always taught by our seniors that pulse pata nahi chalta. You don't know what to do with the pulse, does not matter. But in front of the examiner, make sure you put 3 fingers on the radial pulse, 3 finger on the carotid when you demonstrate examination. So the best method to examine the pulse is the 3-finger method, which is called as the method of trisection. What to examine के पहले आता है, where to examine. So what are the sites of examination we want to see? So what are the sites of examination we want to see? So when we want to check for the arterial pulse, we can examine the arterial pulse at 2 places. Number 1, more commonly we examine the periphery. Peripheral pulse. That means, example, we check for the radial pulse, we check for the femoral pulse, we check for the dorsalis pedis. So when we want to examine, we want to check for the peripheral pulse is checked more commonly. But we all know that pulse can also be examined, central pulse, also called as the carotid pulse, can be examined. Why we do not do this? Basically because in the central or the carotid is mainly to assess, the defect in the waveform, defect in the arterial waveform, which is very subjective, and hence unreliable. It is subjective and hence it is unreliable, we can say that. So we can check for the carotid pulse. It is checked mainly to look for the defect in the arterial waveform. Now most of us after finishing MBBS do not even know the waveform of arterial pulse. So defect समझने का तो क्वेश्चन ही नहीं आता. Even if you find the defect like pulsus parvus, pulsus tardus, these waveform defects are very subjective. Suppose I tell the examiner that sir, on carotid examination I found there is pulsus parvus. The examiner may say no, it looks normal. So what it becomes? The examination finding becomes unreliable. That is why not common in practice but common in MCQ. I told you in the start of the lecture, in medicine you have to learn what is done commonly in practice, and you always will notice what is common in practice never comes in MCQ. What is common in MCQ does not see in practice. That is why we find it difficult to give our exam. So we want to go for both of them, right? So radial, femoral, dorsalis pedis. Dorsalis pedis, we want to examine peripheral pulse. Within the peripheral pulse, what are we going to examine? We are going to examine the following characters. Write it down. We have to examine the following characters. We have to examine the following characters in the peripheral pulse examination. We want to look for the following characters. So I am telling you, we are going to, in this page, listen to me everybody, in this page we are going to only enumerate the characters. In the subsequent pages we will discuss the character one by one. Okay, we are going to write down only the character, enumerate the character. So number one, obviously we are going to check for rate of the pulse. We are going to check for rate of the pulse. We are going to look for rhythm of the pulse. We are going to look for rhythm of the pulse. We can examine volume of the pulse. Volume of the pulse. We can check for condition of vessel wall. We can check for the condition of the vessel wall. We can check for the apex pulse deficit. We can check for the apex pulse deficit. We can check for radiofemoral delay. We can check for radiofemoral delay. We can check for the distal pulsation. Distal pulsation and symmetry. We can look for the distal pulsation and the symmetry of the pulse. Right, everybody? So check with me. It is a clinical point. It's a clinical point. So when you examine the peripheral pulse, how do you report the finding? You say that the radial pulse I examined, the rate is so and so, rhythm, volume, condition of vessel wall, apex pulse deficit, radiofemoral delay, distal pulsations and symmetry we are going to examine. Out of these 8 characters, only few of them need further understanding. Example, rate of the pulse. It is a direct point. You have to only count. The normal rate is 60 to 100 beats per minute. The normal rate is 60 to 100 beats per minute. If it is less than 60, you use the term bradyarrhythmia. If it is more than 100, we use the term tachyarrhythmia. So, number one, we are going to examine the peripheral pulse. You have to count the rate of the pulse. That is simple. Count it. That's all. Normally, it should be 60 to 100. Less than 60 indicates bradyarrhythmia. More than 100 indicates the tachyarrhythmia, we can say. Rhythm of the pulse requires further investigation. Okay, further discussion we want to see. Volume of the pulse, again, it is very subjective and hence unreliable. Don't give it much importance. Volume of the pulse, it is subjective, unreliable, hence don't give it much importance. In examination, we say volume is normal. That's all. We don't have any other way to identify. Condition of the vessel wall. Condition. You have to palpate the vessel. You have to palpate the vessel. So, condition of the vessel wall. Normally, it is not palpable. Artery is normally not palpable. How you have to examine? Look at me. You have to check, roll the fingers over the artery. Suppose you are checking radial artery, you have to roll your fingers to palpate the artery. In normal person, artery is not palpable. But if it is palpable, then we say the patient is having either arteriosclerosis or atherosclerosis. Arteriosclerosis or atherosclerosis, we can say. Arteriosclerosis or atherosclerosis, we can say. Right? In apex pulse deficit. Apex pulse deficit, again, needs further discussion. We have to understand this sign more. So we will mark it for further evaluation. Apex pulse deficit. Radiofemoral delay also. Further evaluation we will mark it for. Further evaluation we will mark it for. Distal pulsation. You just have to palpate. Distal pulsation. So normally they are palpable. Distal pulsations are normally palpable. Distal pulsation, normally palpable. But if it is not palpable, then it indicates peripheral vascular disease. Then it can be a sign of peripheral vascular disease. It can be a sign of peripheral vascular disease. Symmetry is also direct. Normally it is symmetrical. Normally it is symmetrical. We can say that. Okay. So understand this page with me. So when you first examine, okay, take it from the first session. This is a continuation session. When the person is having any symptom of cardiovascular disease, you will start with detailed clinical examination. In the clinical examination, we start with palpation of arterial pulse. Arterial pulse is examined by three-finger method. It can be checked in the periphery, it can be checked in the center. Carotid is not commonly examined, but it is commonly asked in MCQ for assessment of waveform defect. In the periphery, for your practical viva, you have to remember and understand the following characters of the pulse. The characters of the pulse are the rate of the pulse, rate, rhythm, volume, condition of vessel wall, apex pulse deficit, radiofemoral delay, distal pulsation and symmetry. So you can see the pulse is like a screening test. Okay, right now the patient has got a symptom of cardiac disease, but we have written in the classification cardiac disease can be functional, can be structural, can be vascular also. To help identify which disease the patient is having, we have started with examination. So the pulse can tell you rate and rhythm abnormal means arrhythmia is there. Volume is low, dehydration is there. Condition of vessel wall is not palpable, atherosclerosis is there. And remaining, we will see what is the importance of these reasons. What is the importance we want to see. So each out of these 8 characters, we are going to understand the 2, 5 and 6 character in detail. Okay, others are all self-explanatory. Let's go to the next step, rhythm of the pulse. Let us see how we have to understand rhythm of the pulse. Let us see one by one. Rhythm of the pulse. Okay, so write it just with me, that's all, page to page you can copy with me. Rhythm of the pulse. Rhythm of the pulse is normally, the pulse is discussed as regular pulse. Normally the pulse is described as a regular pulse. It must be described as, yes, regular pulse. That's what we are going to say. But if there is abnormal rhythm, what does it tell you? First, interpretation. Interpretation is very simple. Abnormal rhythm. If there is abnormal rhythm, it is suggestive of arrhythmia. Previous session, please recall, what is the definition of arrhythmia? Arrhythmia is defined as disorder of rate and or rhythm. Okay, so if the rate is abnormal or the rhythm is abnormal, that means the patient is having arrhythmia. Direct diagnosis you can make out from the pulse examination. Rate is abnormal means arrhythmia, either bradyarrhythmia or tachyarrhythmia is there. Rhythm is abnormal also, there is arrhythmia, but we want to know which arrhythmia is there. To understand which arrhythmia is there, let us go into further detail. So I want you to illustrate the palpable pulse. Okay, so what I am marking, the point dot represents a palpable pulse. Dot represents palpable pulse. Okay, palpable pulse. So in a normal person, what will you see? There is pulse, pulse. At regular interval, you will be able to palpate the pulse. So draw with me the entire line of your notebook. I want you to make these dots at regular intervals. Make these dots at regular intervals. I want you to make these dots. Each dot represents a normal palpable pulse. The dot represents the palpable pulse. It represents, draw it with me. You don't have to count, just keep making dots. Okay, you don't have to count, just keep making dots. So we have got here that palpable pulse. Each dot represents a palpable pulse. If the pulse is normal, when you palpate, कैसा होना चाहिए? You must feel pulse, 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 pulse. That means it is regular pulse as shown in the illustration. But abnormal rhythm indicates there is presence of one or more non-palpable pulse. Abnormal rhythm means there is one or more non-palpable pulse has to be present. So cross represents non-palpable pulse. So how it can be? Both ways. One way, that there can be two pulses palpable, the third pulse is not palpable. Two are palpable, third pulse is not palpable. Two are palpable, third pulse is not palpable. This is one of the possibilities. Okay, so make a column here. So what we have got? One possibility. We will make a column. So palpable pulse is there, but every third pulse is not palpable. Every third pulse is not palpable. So what we call this? We call this as regularly irregular pulse. We call it as regularly irregular pulse. Remember this very simple approach. We call this as regularly irregular pulse. We can call this as. So when you palpate, what you feel? Pulse, pulse, miss. Pulse, pulse, miss. Pulse, pulse, miss. Means regularly irregular pulse. Or the other possibility, two are palpable, third is not palpable, three are palpable, fourth is not palpable, random. So there can be any permutation combination of randomly non-palpable pulse. We call this as irregularly irregular pulse. We call this as irregularly irregular pulse. Please remember. So what does the basic concept say? The basic concept says that the presence of abnormal rhythm tells you there is arrhythmia. But to identify which arrhythmia, you are going to further check the character of the abnormality. Whether it is regularly irregular or is it irregularly irregular pulse. You want to check that. Okay. Now the next point. What can be the mechanism of this non-palpable pulse? Yaad kariye. Last page. I want you to remember. Remember this last page. What have we written? What is arterial pulse tell you? Arterial pulse tell you there is effective LV contraction. Matlab, if the pulse is palpable, that means there is a effective LV contraction. So आप उसको reverse कर दो. Make it opposite. Make it opposite. That why will the non-palpable pulse be? Pulse is not palpable means A, there is no LV contraction. One mechanism, if the pulse is not palpable, one mechanism is there is no LV contraction, or the other mechanism is that there is a ineffective LV contraction. There is a ineffective LV contraction. Very simple. Come on, try to understand this. The concept is very simple here. So when the person has got abnormal rhythm means either the patient has got a non-palpable pulse which can be due to no LV contraction or due to ineffective LV contraction. These are the two mechanisms, not arrhythmia. So why should there be no LV contraction? Think about it. Why should there be no LV contraction? No LV contraction can be seen when there is a AV block. When there is a second degree AV block, atrioventricular block. Atrioventricular, that is also called as heart block. So the cause, one of the causes of abnormal rhythm, is the AV block. That means The sinus node produced the impulse, but impulse did not reach the ventricle, right? So in a AV block, depending on if the AV block, it is a fixed second degree AV block. If it is a fixed second degree AV block, you will get regularly irregular pulse. But if it is a variable second degree AV block, it is a variable second degree AV block. Okay, so there you will get irregular pulse. So please remember, the cause of regularly irregular pulse, one cause is fixed second degree AV block. In heart block, the sinus impulse does not reach the ventricle, so the ventricle does not contract, so the pulse is not born, so it will not be palpable. That is one point here. Other possibility, ineffective LV contraction. In this, we have got the topic of VPC, ventricular premature complex. We have got the topic of ventricular premature complex or ventricular ectopic beats. Whatever we can call this, ventricular ectopic beats, VPC or VPB, we can call this. So ineffective ventricular contraction, it can be two in number. Ineffective can be either isolated or they can be fixed. Okay, so ventricular premature contraction, this is called as Gemini rhythm. This is called as Gemini rhythm when the ectopics occur at regular intervals. When the ectopic occurs at regular intervals. Ectopic occurs at regular interval. Example, patient is having a trigemini. In a trigemini, every third beat is a VPC. Every third beat is a VPC or a VPB. So in Gemini rhythm, when it is due to ventricular premature complex or VPB, you can get regularly irregular pulse. But in a sporadic or isolated VPC, we call it sporadic or isolated VPC, you can get irregular pulse. You can get irregular pulse can be seen here. So why there is ineffective LV contraction? Because in VPC, the LV contracts against a closed AV valve, against a closed aortic valve. It comes early, no? As the name tells you. Ventricular premature complex, मतलब वक्त से पहले, it has come before time. So the aortic valve is not open, and that is why even though the left ventricle contracts, it is not felt at the periphery. Even though the ventricle contracts, it is not felt at the periphery, making it a ineffective LV contraction. Ineffective LV contraction. But remember, the automaticity of the ventricular tissue, automaticity is very, very low, and hence the VPCs are always less than 10 per minute. VPCs are always less than 10 per minute. When they become more, they can become ventricular tachycardia. But as far as they remain ventricular premature complex, they are always less than 10 per minute. That is an important clue in clinical examination. Because we know automaticity of SA node is highest, followed by automaticity of AV node, followed by automaticity of a ventricular tissue. So automaticity is low. That is why the number of VPC is usually or rather always less than 10 per minute. Number of VPC is less than 10 per minute. That's what we have done. So if the patient has got a VPC, in VPC, LV contracts against closed aortic valve. Closed aortic valve. They are one and the same. VPC, ventricular premature complex. Ventricular premature beat. VPC, VPB. They are one and the same. Okay. VPB, VPC, beat or complex, whichever way we call this. And the third cause, odd cause here, is the atrial fibrillation. Okay, we have got the atrial fibrillation here. So let's write it down here. Atrial fibrillation. What happens in atrial fibrillation? In atrial fibrillation, by definition, atrial fibrillation means the atrial rate is minimum more than 350 beats per minute. Fibrillation means it is more than 350 beats per minute. It is more than 350 beats per minute. Atrial rate is more, but AV node has got a refractory period. AV node has got a refractory period. So all impulses are not conducted to the LV. So there is going to be erratic conduction. There is erratic conduction of impulses into the LV. Impulses into the LV. And that is why you will get irregular pulse. You will get irregular pulse in atrial fibrillation. But since the rate is more, irregular pulse will be seen in atrial fibrillation. Okay, so now look at the answers. So if the patient has got abnormal rhythm, please remember that abnormal rhythm causes are divided into two. It based on whether it is irregular pulse or irregular pulse. So try to remember the answers or the causes of abnormal rhythm. Causes of abnormal rhythm. ये देखिए table. So when the patient has irregular pulse, one cause is fixed second degree AV block. Number two, it can be seen in Gemini rhythm. So MCQ question, what are the causes of irregular pulse? Irregular pulse. But in a patient with irregular pulse, the causes are variable second degree AV block. Number two cause is the sporadic or isolated VPC. And the third cause, that is how we came to AFib, is the atrial fibrillation. Okay, so we have connected the atrial fibrillation finding. So in variable second degree block, in a isolated VPC, and in atrial fibrillation, what kind of pulse can you expect? You can expect irregular pulse. You can expect irregular pulse. Okay, this will be differential diagnosis. This will be the differential diagnosis. Okay, there is nothing to explain. इससे clear और क्या मैं लिखूं, है ना? So यहाँ पर क्या हो रहा है? What is happening here? Ineffective contraction in VPC. Trigemini means every third beat is the VPC. And that beat will not be felt. Every third beat will not be felt. Non-palpable होगा. That is why you will get it as a regularly irregular pulse. That's all you have to remember. Okay. VPC and extrasystole is the same. There are different names. Automaticity low, that is physiology, है ना? मैं क्या? I am not nature, no. I have not created. I have not created that there is a SA node as automaticity. Automaticity is going to be decided by physiology. That is the point here. So we have got mechanism. A and B are mechanisms of abnormal rhythm. And we have got the causes, which are the arrhythmias, which abnormal rhythm. Abnormal rhythm can be either AV block, can be VPC, or can be atrial fibrillation. It can be there. Now further, we want to know exactly which arrhythmia. So let us take up the next concept here. Next concept is to understand apex pulse deficit. Next is to understand apex pulse deficit. Concept is to understand apex pulse deficit. The apex pulse deficit we want to understand. We want to understand apex pulse deficit. Okay, we will complete. आपको पूरा समझ जाएगा, है ना? So just first you copy it down and then you will be able to understand it better one by one, है ना? First time सुन रहे हैं तो difficult to understand, आगे आगे understand हो जाएगा. So what is this apex pulse deficit? What is this apex pulse deficit? In apex pulse deficit, what we are going to do in the apex, we are going to auscultate for S1. We are going to auscultate for S1 because what does S1 do? It marks the onset of ventricular contraction. Marks the onset of ventricular contraction. ये देखें. Okay, erratic conduction, है ना? सब लोग स्ट्रेस में आ गए. ठीक है, एक पेज पीछे जाता हूं. So atrial fibrillation में, in atrial fibrillation, atrial rate is very high. So impulses from the SA node or the atria reach the AV node very fast. Remember, AV node has got two refractory period. There is absolute refractory period when there is no conduction possible. Then there is the relative refractory period which can sometimes conduct the impulse. Okay, so understand this, that relative refractory period में अगर impulse आ गया, that impulse can be conducted further into the LV. Otherwise, it may not be conducted to the LV. Let us see this. Yeah. So there is a relative refractory period where some impulses may be conducted. So हम क्या बोल सकते हैं? That some impulses may reach the LV. But these impulses also reach the LV early. Remember physiology. Reach the impulse early because conduction delay होना चाहिए था AV node में. But some impulses, because the rate is so high, can reach the LV early, not giving enough time for LV to fill. And by Frank-Starling law, if the volume is low, the force of contraction is low. That is why we call them as ineffective contraction. We call them as ineffective contraction. Okay, relative refractory period. Relative refractory period होना चाहिए. Okay, so just to take it from there, one by one, we have to focus on. So if you understand, it's okay. These are all very conceptual points. You need final answer. Final answer, the causes of irregular pulse, I want you to know. If you understand, it is good. If you didn't understand, forget it. Just for understanding it is. It is unlikely that anybody will ask you unless the examiner is me. So it is unlikely. So we may not get question, but we must remember the points. Right. Let us continue further. We come to the next sign. So take it from here. We are taking it step by step. मैं आपको पढ़ा रहा हूँ that in the arterial pulse, we have seen that rhythm should be normal. Go back to this page. It must be normal. But if it is abnormal, what are the differentials? Abnormal. The differential can be AV block. The differential can be VPC, or it could be atrial fibrillation. ऐसा लिखना. This is correlation. So go back to the page. Rhythm page, where you have enumerated. Yes, sometimes we have to do that. Okay, it takes years to understand the concept. Sometimes you have to know the backdrop of physiology. It's okay if you don't get everything today, but as you get more classes, you will be able to understand them better. Okay, so we have got here. So rhythm should be normal, but if it is abnormal, what are the causes of abnormal pulse? Rhythm can be seen in AV block, ventricular premature complex, or atrial fibrillation. Right? Volume, subjective we have written. We are taking the next point now, apex pulse deficit. We are taking the next one, apex pulse deficit. We are going to understand. So what is this apex pulse deficit? In apex pulse deficit, first we are going to auscultate for S1 at the apex. Go back to heart sound. S1. In S1, when the LV contracts, mitral valve closes. LV contracts, mitral valve closes. That is why we say, if you can hear S1, that means the patient, the left ventricle has started to contract. Same time, you will palpate the pulse at the periphery. You will palpate the corresponding pulse. In the periphery. You will palpate. Now what happens in a normal person? Every beat is effective. And hence the contraction is conducted as pulse. Contraction is transmitted to the periphery as pulse. Remember this. So what we are going to do? We are going to calculate apex pulse deficit. That means difference. We are going to calculate the difference between the number of audible S1 minus the number of palpable pulse. Okay, so apex pulse deficit means, so when I say apex pulse deficit means difference is calculated as number of audible S1 minus the number of palpable pulse in a minute. Number of palpable pulsation in the minute you are going to calculate. So examination, apex pulse deficit. We are going to see apex pulse deficit. Since the physiology, every beat is normally effective and hence contraction is transmitted, felt as a pulse. That is why in a normal person, apex pulse deficit is 0 or absent. Normally, there should be no difference. Between the apex S1 and the number of palpable pulsation. That is normal. So reverse it, pathology. So if deficit is present, what does it indicate? indicates that there is presence of, indicates ineffective LV contraction. It indicates presence of ineffective LV contraction is present, we can say. Are you able to correlate? Okay, take your time. Concepts take time. We will understand them and then move forward. So if the patient, you can hear S1 but you cannot feel the pulse, that means kaisa hua? S1 is there, means LV has contracted, but you cannot feel the pulse. That means that contraction was ineffective. That contraction which is not transmitted in the periphery is considered as a ineffective LV contraction. Considered as a ineffective LV contraction. So where to use this concept? Very important point. When the patient, in a case of irregular pulse, in a case of irregular pulse, the apex pulse deficit is very important to reach the diagnosis of the arrhythmia. So where is this sign important? I am trying to make you understand when you have to examine this apex pulse deficit. You have to examine especially in a case of irregular pulse to identify the diagnosis. Because what are the differentials? It can be second degree AV block. We have just discussed. Could be second degree AV block. It could be ventricular premature complex, ventricular premature beat, or it could be atrial fibrillation, How to differentiate between them is the concept of apex pulse deficit. So when you check for, there is a patient having abnormal rhythm and the rhythm is irregular. We studied that there are 3 abnormality arrhythmia possible. To reach which is the abnormality, we want to use apex pulse deficit. So you can say, what will happen to the apex pulse deficit in second degree AV block? In second degree AV block, the mechanism क्या लिखा हमने? Mechanism is no LV contraction. Means S1 is also not there and pulse is also not there. But whatever pulse is transmitted is properly causing contraction. So here the apex pulse deficit is 0 because there is no ineffective contraction. There is no ineffective contraction. Problem is in conduction. So remember, second degree AV block mein, why did you get non-palpable pulse? Because LV did not contract. If LV did not contract, you will not auscultate S1 also. You will not auscultate S1 also. In the other two situations, where it is due to ineffective LV contraction, apex pulse deficit is present. In both of them, apex pulse deficit is present. In both of them, apex pulse deficit is present. Okay. Heart block we have written under A, that is no LV contraction. Under ineffective contraction, we have written 2, ventricular premature complex and atrial fibrillation. But the number of VPC is less than 10. So the apex pulse deficit is less than 10 per minute. And in atrial fibrillation, it is more than 10 per minute. In atrial fibrillation, it is more than 10 per minute. This is how to approach the point. Okay. So go back to your table. Anna, you have copied table wrong if you have written heart block. Anna, understand and write, no? Heart block mein, why pulse is not palpable? Because LV is not contracting. But if LV is not contracting, S1 also not audible. So they cancel each other. Whatever S1 comes is conducted to periphery. So in a patient with irregular pulse, apex pulse deficit is 0. That means problem is AV block. In a patient with irregular pulse has a apex pulse deficit of 6 per minute, answer is VPC. And apex pulse deficit is more than 10, that means 20, 26, answer is atrial fibrillation. Okay, the answer is atrial fibrillation. So this is all a derivation for your MCQ. You must be able to answer the question, clinical based question properly. Clinical based question. So examination of pulse is a sequence. Examination of pulse is a sequence here. So I'll take you back. What did we learn? Examination of arterial pulse. Take the next character. Next character, what we said? Apex pulse deficit should be normally 0. But if it is present, it can help identify arrhythmia. It can help identify the arrhythmia. It can help identify the arrhythmia. Okay. So yes, in Gemini rhythm also, the total number of VPC will be less than 10. Total number of VPC will be less than 10 because automaticity, previous page dekho, automaticity is low. That is why. Helps identify the arrhythmia. Helps identify the arrhythmia here. So what is next? Radiofemoral delay. Let's come to that. Radiofemoral delay. Let us see this. So radiofemoral delay we want to explain. So we have got radiofemoral delay. So the sign in the pulse character, radiofemoral delay. For that, first we must know normal points. First we must know normal points. So let us see. This is the heart. Left ventricular contraction is transmitted in the periphery as the pulse. Okay, transmitted to the periphery as a pulse. So from the LV, the first pulse is palpable in the carotid. The pulse is first felt at the carotid. Pulse is first felt at the carotid. After the carotid, there is lower limb circulation and there is upper limb circulation. Lower limb circulation, upper limb circulation will occur here. So second, where will you see? Where will you understand? First, the LV contraction is felt at the carotid. The second site is at the brachial artery. Is at the brachial artery. Brachial artery. Third, it is felt at the femoral. Third, it is felt at the femoral artery. And just after the femoral, it is felt at the radial artery. This is the concentration. This is what? The conduction of the pulse. So in a normal patient, radial pulse comes before the femoral. In a normal patient, the femoral pulse is felt before the radial pulse. This is normal. The femoral is felt before the radial pulse. Femoral is felt before the radial pulse. But what is radiofemoral delay? When the femoral is delayed. So the radial pulse is felt before the femoral. That means the femoral is delayed. That is why the name radiofemoral delay. That is why the name radiofemoral delay. So we are going to have abnormal. Radiofemoral delay should be normally absent. Normally absent. Radiofemoral delay present is abnormal. It is abnormal. And what does it indicate? Indicates aortic arch disorders. Indicates aortic arch disorders, right? Because the simple point, if the femoral has to be late, that means there has to be a pathology here, aortic disorder. There has to be aortic disorder. So we can say presence of radiofemoral delay indicates aortic arch disease. MCQ, what is most common cause of this sign? What is most common cause? Read the question fully. Most common overall cause occurs in young. It is different in elderly. In the young person, the most common cause is coarctation of aorta. The most common cause is coarctation of aorta, which is a congenital heart disease. Coarctation is a congenital heart disease. So, in a young patient, presence of radiofemoral delay. In a young patient, presence of radiofemoral delay, the answer is coarctation of aorta. But in an elderly patient, it cannot be coarctation. In an elderly patient, it indicates severe atherosclerotic disease of the aorta. Indicates severe atherosclerotic disease of the aorta. Severe atherosclerotic disease of the aorta. It indicates. What are the other causes? Other rare causes. These are the other rare causes only for MCQ. Common causes for practice, rare causes for MCQ. Rare causes for MCQ. Rare causes will include aortic dissection. It can be due to aortic dissection. It can also be due to aortoarteritis. Aortoarteritis. And we know aortoarteritis causes. Aortoarteritis. Old answer was syphilis. Old answer syphilis. In modern era, it is the large vessel vasculitis. It is the large vessel vasculitis. It can be seen in giant cell arteritis and Takayasu's arteritis, which we discussed in rheumatology. Right? So overall, most common cause is coarctation of aorta. Overall, single best answer is coarctation of aorta. Most common cause is coarctation of aorta. But in elderly, we cannot have this coarctation, because coarctation is what? A congenital heart disease. So treat nahi karoge, patient will not survive till old age. So it cannot be coarctation when you get radiofemoral delay in elderly. In elderly, if you get this sign, it indicates atherosclerotic disease of the aorta. It can also be seen in dissection, can be seen in aortoarteritis. You can see this, right? So fill up the table so we get a complete review of the point. So go back to the page of pulse. What can you say about arterial pulse? Isko dekhte hain. Arterial pulse, radiofemoral delay, normally absent. But if it is present, it indicates aortic valve disease. Aortic arch disorders. Indicates aortic arch disorders. Old syphilis means one of the causes of aortoarteritis was syphilis. Olden time, no? Syphilis abhi common nahi hai. Syphilis is not common now. Old cause of aortoarteritis is syphilis. Presently, aortoarteritis is commonly seen with large vessel vasculitis. It is seen with large vessel vasculitis. Okay, so now you get the complete picture. How to calculate means you have to palpate the femoral and radial pulse simultaneously. Radiofemoral delay, you have to palpate radial and femoral pulse simultaneously. Normally, you must feel the femoral pulse just before the radial. Normally, you must feel the femoral just before the radial. But if it happens other way around, you feel radial then femoral, that means there is a delay in the femoral. If you first find radial then femoral, then you mean it is got a radiofemoral delay. Okay, so if it is not mentioned young or old, I told you overall most common cause is coarctation of aorta. Most common cause is coarctation of aorta. Now look at the point. So this is the summary. This is the summary that we have got. This is the summary. Understand and write. कि ये pulse examine क्यों करते हैं? I'm very important. I want you to tell. Pulse is a underestimated examination finding. So why we are examining each character you are going to be seeing. Ana Gemini rhythm में we are not taking it into account. Himanshu, why are you confusing? Gemini comes with regularly irregular pulse. हम लोग किसको डिस्कस कर रहे हैं? Irregularly irregular pulse. Okay, don't confuse now. What is not written only, why are you thinking about it? Are we speaking? We are talking about the, that is very clear. Same thing. You have to look at the, just you have to check for the fixed AV block and Gemini. Same. Apex pulse deficit, present or absent. That's all. Focus on what is there first and read this in a pattern. When you have a patient, now you summarize in your mind. Sit back 1 minute and think about it. When the patient comes to you, ध्यान से सुनिए, summary. Listen carefully, everybody. Sit back and think very clearly. When the patient comes to you with a symptom of cardiovascular disease, you suspect cardiovascular disease. Once you suspect cardiovascular disease, you start with pulse examination. In the pulse examination, you start with peripheral pulse. In the peripheral pulse, first you will count the rate and check for the rhythm. Count the rate and check for the rhythm. If rate and rhythm are abnormal, you can say patient is having arrhythmia. You will check the volume, but it is unreliable. Condition of vessel wall, palpable or not. Apex pulse deficit is important only in patients of abnormal rhythm. Normally we don't check. When to check apex pulse deficit? In a patient with abnormal rhythm, you will check apex pulse deficit. Radiofemoral defect is normally not there. But if it present, it tells you aortic arch disease. Distal pulsation can tell you peripheral vascular disease. Symmetry is just a character. So this is the importance. So you can see how important pulse is. Pulse can be a very good screening for arrhythmia, can be a good for structural disease, aortic disease and peripheral vascular disease. That is why we are going to start with the pulse examination. In radiofemoral delay, I'll just show you the slide for a minute before we go further. Radiofemoral delay. Come on. Right. Now tell me. Okay. So clear. We will come to dicrotic pulse na abhi, Vaibhav. Yeah, everybody is in a hurry. I cannot believe it. We have only done peripheral pulse. We have not even started. We have not started the central carotid pulse. Ready everybody? Chal, let's go ahead. So after the peripheral pulse, let us go to central pulse waveforms. Let us go to central pulse waveform, carotid pulse waveform. Carotid pulse waveform. So for that, you want to understand normal arterial pulse waveform. Normal arterial pulse waveform you want to understand. You want to check the normal arterial pulse waveform we want to see. Okay, normal arterial pulse waveform we want to see, right? Yes. So normally, how do you draw arterial pulse waveform? Please remember, you have to match it with the cardiac cycle. Match it with the cardiac cycle. Try to recall cardiac cycle. So arterial pulse is LV contraction. Arterial pulse is transmitted LV contraction. So please recall cardiac cycle from physiology. Okay, recall cardiac cycle from physiology. That's what you want to check for. So to understand the different phases of arterial pulse waveform, recall cardiac cycle. Just remember systole. Focus on systole now. Focus on systole. So what happens in the systole? The ventricular systole begins with the S1. Begins with the S1. Right? Begins with the S1. So S1 means left ventricle has started to contract. Left ventricle has started to contract. Okay, write it only for your understanding. I'm writing it here. Normally S1 means there is onset of ventricular contraction. I'm going to rub it after this, so note it down if you want. S1 indicates onset of ventricular contraction. That is why we used it in the apex pulse deficit. Mitral valve closes. Ventricular systole begins. In the ventricular systole, within the ventricular systole, divided into three phases. Ventricular systole divided into three phases. Ventricular systole divided into three phases. So this phase we want to understand here. So draw with me. So here we have got, okay, so S1, what are the phases here? From the systole, just recall the systole. We will be doing cardiac cycle again. Systole, there is first isovolumic contraction. There is isovolumic contraction. So first phase, there is no blood flow into the aorta. Left ventricle begins to contract and generate pressure. Then the aortic valve opens and then there is rapid ejection. Then there is rapid ejection where maximum blood flows into the aorta. And then there is delayed ejection where the quantity of blood becomes lesser into the aorta. Everybody, recall the cardiac cycle. Without physiology, difficult to understand medicine. So I want you to recall cardiac cycle, especially systole. S2 marks the onset of diastole. Second heart sound marks the onset of ventricular diastole, ventricular relaxation. Okay, this is our cardiac cycle. Just recall that. Then there is diastole. Diastole is longer than systole and the next cycle will begin. Next cycle will begin with S1. Everybody, can you recall these points first? Okay. Remember this first. To understand arterial pulse waveform, we need to do a quick review of cardiac cycle. We have written it for you. I have put it in front of you. So LV starts to contract, mitral valve closes, S1 is produced. After the mitral valve is closed, LV continues to generate pressure, but aortic valve is closed. So there is no flow into aorta. That is why it is called as isovolumic contraction. After that, aortic valve opens and blood gushes into the aorta. Rapid ejection. As the aorta becomes full and LV starts to reduce in volume, force becomes less and the flow into aorta also becomes less. Then the aortic valve closes, that is S2. Aortic valve closes, that is S2, and the ventricles begins to relax. Ventricle begins to relax. Okay, ventricle begins to relax. These are the phases of ventricular systole. I am rubbing it away. Now we want to match it with the pulse. We want to match it with the pulse. तो इसको मैं हटा देता हूं यहां से. I hope you have remembered this, है ना? More than writing, remembered, understood the flow that occurs at different phases. Flow that occurs at different phases. Because ये क्या है? इसको देखते हैं यहाँ पर. So what is this waveform represent? The arterial waveform. Write it down properly. Arterial waveform. The arterial waveform represents the blood flow into the aorta. Just for convenience, blood flow into the aorta. Okay, arterial waveform represents blood flow into the aorta. Arterial blood flow waveform represents the blood flow into the aorta. So when you palpate the carotid, so where it is best assessed in central, best assessed in carotid pulse, best assessed in the carotid pulse. We have written it already. So arterial waveform is best assessed in the carotid pulse. So हम क्या देखते हैं? Write it down, follow it with me. So when the patient pulse starts, है ना? Pulse यहाँ से palpate शुरू करते हैं, है ना? Palpation. Try to remember this. Now here we have got, okay. So in the S1, I am making a comparison. यहाँ से pulse start हो गया. So first, in the isovolumic phase, is there going to be blood flow into aorta? In the isovolumic contraction, no blood flows into aorta. So the pulse waveform remains flat. Pulse waveform remains flat. No blood flows into the aorta. Isovolumic contraction, the arterial waveform remains flat. In the rapid ejection phase, what we have next is the rapid ejection phase. There is going to be flow of blood. So what happens? The waveform gets the peak of the waveform. Maximum blood flows into the aorta. Maximum blood flows into the aorta. So you get a peak. So you get a peak. Okay. So here there is no blood flow into aorta. Isovolumic contraction. Maximum blood flows into the aorta. So there is a peak of the contraction. In the delayed ejection, the blood flow starts to reduce. Blood flow starts to reduce. Okay, it starts going down. After it starts going down, at the S2 level, what is happening? Aortic valve closes. Aortic valve closes. At this part, there is a dip in the waveform. There is a dip in the waveform till the next cardiac cycle. There is a dip in the waveform. This is your arterial pulse waveform. So let us understand what are these points here. This is the peak anacrotic shoulder. This is the peak anacrotic shoulder. This green fellow is the dicrotic notch. And this remaining is the diastolic runoff, the waveform where blood empties into the periphery. Diastolic runoff. So blood flow into aorta during the LV contraction. Initially no blood flows. Maximum blood flows into aorta. Reduced blood flows into aorta. There is dicrotic followed by diastolic runoff. Because after the LV contraction is over, the blood in the aorta is distributed to the periphery. Okay, याद समझ के लिखना, distributed to the periphery. This is called as diastolic runoff. So what is the concept of this dicrotic notch? Why is it there? So dicrotic notch. So dicrotic notch, we can see, corresponds to S2. Why? That is MCQ. Corresponds to S2. But why? So the dicrotic notch basically divides the waveform into the systole and the diastole. Divides the waveform into the systole and the diastole. That is what it does. The dicrotic notch divides the waveform into the systole and the diastole. Because what happens during the S2, that is aortic valve closure, during the S2, that is aortic valve closure. Okay, 1 minute. Yeah. Yeah. So divides into, wait, let me go slow here. Yeah. Yes. So here during S2 means during aortic valve closure. During the aortic valve closure, what happens? The flow, the blood between the columns, the blood which is present in the leaflet, within the leaflet, the blood column which is present between the leaflet, is going backflow into the LV, gets the backflow into the LV, leading to a dip in the waveform, So what we are going to say, the column of blood. So understand this, column of blood. So even though, watch this carefully after you write down, the column of blood, the leaflet is like this. So there is some column of blood between the leaflet of the aorta. When the aortic valve closes after the annulus, this is the aortic valve opening. Beyond the opening, the blood has come into the aorta. It has reflected in the waveform. But during the aortic valve closure, this column of blood between the leaflet will be pushed back into the LV, which creates a notch, which creates a dip in the waveform, and that is called as the dicrotic notch. And that is why we say the dicrotic notch, practical importance, corresponds to the S2 and divides the waveform into systole and diastole. We can say that, right? So arterial pulse waveform we have studied, which is what? Normal arterial pulse waveform first. Then we will go to the abnormality. So we have understood here that there is no rise after the notch. The blood flow is coming down. So whatever comes down and then it continues further. So that it creates a dip, because the flow which has already occurred, is coming back into the LV. The flow which has already occurred comes back into the LV. and that is why you get a dip in the waveform, and that is called as the dichrotic notch. That is called as the dichrotic notch. Okay, so keep it simple. I want you to remember the events. That is how you will be able to understand abnormality of the waveform. You will be able to understand abnormality of the waveform. Okay, so कैसा होता है ये? Anacrotic shoulder, dichrotic notch, diastolic runoff. But read it like this in your mind. Focus here everybody. I want you to read like this. Arterial waveform कैसा है? Isovolumic contraction यहाँ पर, sorry, there is the isovolumic contraction यहाँ पर है, rapid ejection यहाँ पर है, delayed ejection यहाँ पर है. Okay, so that is how you want to remember this. This is called as the normal arterial waveform. Diastolic runoff means the distribution from the aorta. The volume of blood present in the aorta gets distributed to the periphery. Gets distributed to the periphery. That's what we want to know. Gets distributed to the periphery. Okay, chalo. Next one. Anacrotic shoulder is just the peak. That's all. इसका कोई और वैल्यू नहीं. It is just the peak. That's all. इसको बोलते हैं peak. Okay, that's what we want to know. So just understand. This is normal arterial waveform. Yeah. Yes. This is just for understanding. Again मैं बता रहा हूँ. ये सब old concepts है ना. Arterial pulse examination, carotid examination, nobody does in modern medicine. So these concepts have a bit of controversy in them. Okay, they are old concepts, but they are still like to be asked in examination. So please don't stress so much about understanding. Try to understand. Okay, you are busy typing and less applying your brain. Okay, so please try to get that. Why anacrotic shoulder? Because rapid ejection है ना. Rapid ejection, maximum blood flows into aorta. Maximum blood flows into aorta. That is why you get a peak. That is why you call it as anacrotic. These are just names given. Okay. अगर नहीं समझता, again, if you don't get too much concept, does not matter. Just you have to remember this is the fact. This is the waveform, how it looks. Okay. Just don't stress. We'll go step by step. Chalo, come to abnormal waveforms now. Draw column for abnormal waveforms. Draw the column for abnormal arterial waveforms and their interpretation. Abnormal waveforms and their interpretation and significance. However you want to write. Interpretation or their significance, interpretation and causes of the abnormal waveforms. Okay, अरे rise नहीं होता है. Rise is not there. The dip is because of the backflow. Rise is not the real thing. No, it is an illusion. Because of the dip, it looks like a rise. Okay, because of the dip, it looks like a rise. There is no rise. The dip is because of backflow of blood. Okay, remember that. Now come to abnormal waveforms and their interpretation. Abnormal waveforms. So what are the characters I want you to see? I want you to see what are the points you want to see. You want to see the number of peaks. You want to look at the amplitude of the waveform. You want to look at the duration of the waveform. Okay, characters to be seen. Characters to be seen. The characters to be seen in the arterial waveform. जब एग्जामिन करोगे कैरोटिड को, क्या क्या देखोगे? एक ही पीक होना चाहिए. There is a single peak in arterial pulse. Amplitude should be normal. Duration of the pulse should be normal. We want to know. So abnormal waveform, उसके लिए normal से शुरू करते हैं, है ना? Normal को draw कर लेते हैं, right? So using a pencil, let us take a pencil. Take a pencil and write down that first normal waveform draw करते हैं मेरे साथ, है ना? So there is the baseline, there is anacrotic shoulder, dichrotic notch and the diastolic runoff. This is what is normal waveform that is expected. First, look at the amplitude defect. The pulse starts at the same time. Okay, it peaks at the same time, but the peak is smaller. So what is abnormality here? Amplitude of the pulse is smaller. Amplitude of the pulse is smaller. This is called as pulsus parvus. Amplitude of the pulse is smaller. This is called as pulsus parvus, which is nothing but small amplitude pulse. Which is nothing but the small amplitude pulse. Okay, small amplitude pulse, pulsus parvus. With the gray pencil, that is normal pulse. Pulsus parvus is the abnormal pulse, small amplitude pulse. So think of the causes. What can be the causes of small amplitude pulse? Think about it. First page yaad karte. Okay, let us think of the first page. So first page, what we discussed, the pulse, the cardiac output depends upon, what are the points here? First page yaad karte. What does it depend upon? It depends upon the preload and it depends upon the pump itself. So the amount of blood which is pumped depends upon the preload and depends upon the cardiomyocyte, that is the pump. So where can be the problem? If the cardiac output is low, volume low means low cardiac output state. Amplitude is low means it indicates low output states. So this is the mechanism. What could be low output state? Very good. Number 1, dehydration, hypovolumic states, hypovolumia. Okay, there is hypovolumia is the cause. Number 2, problem can be in the muscle. In the muscle it can be cardiomyopathy, especially dilated cardiomyopathy. Especially dilated form of cardiomyopathy. And number 3, it can be seen in aortic stenosis, LVOT obstruction, left ventricular outflow tract obstruction. Think of it logically. I'll tell you. So when you examine the pulse, you have to check for amplitude of the pulse, the duration of the pulse, and the number of peaks in the arterial pulse. That is just an outline for you to check. Left ventricular outflow tract obstruction. So what are the points here? When the pulse waveform, you palpate the carotid and you find pulsus parvus. Parvus matlab kisme problem hai? Amplitude is the problem. Amplitude is low. That means indirectly what you can say, that the output into the aorta, blood flow into the aorta is less than normal. Think of it like this. Low cardiac output means the outflow, blood flow into aorta is less than normal. वो कब होता है? 1, in hypovolumic state. In cardiomyopathy, especially dilated cardiomyopathy, and aortic stenosis. That is what we want to see. In left ventricular outflow tract obstruction, it is going to cause the problem. Second example, second type of pulse, let us see. Again, first draw normal. Again, practice normal. Isovolumic contraction. There is anacrotic shoulder, dicrotic notch, and there is the diastolic runoff. Second possibility, is that we can tell it is low volume pulse, but उसी को नाम है ना, low volume pulse is called pulsus parvus. That's what we want to see. So second problem, in the duration, it starts at the same correct time, but it takes more time for the peak to occur. More time for the peak to occur. So second problem, amplitude is achieved, but amplitude is taking more time. Amplitude is taking more time. That is why it is called as pulsus tardus. It is called as pulsus tardus. Tardus means lazy. Why it is called lazy? Because it is a slow peaking pulse. It is a slow peaking pulse. Pulsus tardus. It is a slow peaking pulse. Okay. It is in a slow peaking pulse. Cardiomyopathy means muscle is weak. Cardiomyopathy, muscle is weak. That means output will be less than normal. Okay, that's why. So slow peaking pulse. Why should there be slow peaking pulse? Number one cause, LVOT obstruction. Because of the obstruction, it takes more time for blood to enter into the aorta. Because of the obstruction, takes more time for blood to enter the aorta. It can also be seen in intraventricular conduction delay. Intraventricular conduction delay, that is left bundle branch block. That is left bundle branch block, we can see. So always understand the concept here. The concept should be that when you examine the pulse, you must know what to look for. Otherwise, you will not find anything. You must know what to look for. So when you examine, है ना, examine तो करोगे नहीं तुम लोग, but करोगे गलती से. If you check the carotid pulse, next time I want you to see what is the amplitude. Whether the peak is coming immediately or is it taking time, If the peak is small, pulsus parvus. If the peak is delayed, then it is pulsus tardus. Bundle branch block, BBB, bundle branch block, left bundle branch block. So it takes time for the left ventricle to be completely contracted. Take time for it to be completely contracted. So the MCQ question, what are the causes of pulses? What is the cause of pulses? Parvus et tardus. Pulsus parvus et tardus. What is the typical question? So you have to see the common factor. So the common factor is only one. Aortic stenosis. Common factor is only one. It is seen in severe aortic stenosis. It is a characteristic finding in severe aortic stenosis. It is a characteristic finding in severe aortic stenosis. It is a characteristic finding of severe aortic stenosis. है ना, समझ के लिखना. So in early phases of aortic stenosis, in early stage of aortic stenosis, there will be pulsus parvus because the quantity of blood will be less. But as the disease becomes chronic, the left ventricle will hypertrophy, increasing the force of contraction. So it will take more time to achieve the peak, but it will achieve the peak. So that is why you can get little reduction but delay in the amplitude. That is classical of the severe aortic stenosis. This is all based on palpation. Yes, this is what we want to know. This is palpation we are on. Pulse examination is palpation. Radial pulse देखा, अब carotid pulse we are seeing. So we saw here that carotid waveform check करते समय you are seeing the amplitude low है तो parvus. duration prolonged, then it is tardus. So you must focus on amplitude and duration. Now take the number of peaks. Now take the number of peaks. Normally, you will see only one peak. Normally, there should be only one peak. But MCQ examination, but in MCQ, what are they commonly going to ask you? So normally, arterial pulse has only one peak. Normally, there is only one peak in the arterial examination. So MCQ, what are the causes? What are the causes of two peaks in arterial pulse? What are the causes of two peaks in the arterial pulse waveform? This is our common MCQ. This is a common MCQ. What are the causes of two peaks in the arterial pulse? What are the causes of two peaks in arterial pulse waveform? This is the common question. Okay, so causes of two peaks in arterial pulse. What are the causes of two peaks in arterial pulse? So if we have got the two peaks, there are going to be two differential. The common one is the pulsus bisferians. The common one is the pulsus bisferians. You have to remember. Is the pulsus bisferians, that is called as the two peaked pulse. Pulsus bisferians versus, so common in practice, pulsus bisferians, but common in MCQ is the pulsus dicroticus, also called as dicrotic pulse, also called as the dicrotic pulse. It is extremely rare. It is extremely rare. But we want to understand the point, because MCQ is a comparison question. MCQ is a comparison question between the two peaks on arterial waveform. Two peaks on the arterial waveform. Pulsus bisferians and pulsus dicroticus both can have the two peaks in arterial pulse. Can have two peaks in arterial pulse. Let us see mechanism and draw the pulse. What is the cause number one? Pulsus bisferians. Pulsus bisferians is seen in severe aortic regurgitation, with or without aortic stenosis and HOCM. Okay, so pulsus bisferians is seen in severe aortic regurgitation, with or without, listen to this carefully, what is compulsory? Severe aortic regurgitation is compulsory. Aortic stenosis, HOCM, is not compulsory. It is not compulsory. But when it is associated, the chance of finding pulsus bisferians is high. It is seen in severe aortic regurgitation, with or without aortic stenosis, HOCM. Seen in the HOCM, we can say pulsus bisferians. Okay, it is important. What is the difference here? Both the peaks are in the systole itself. Both the peaks are in the systole itself. So between the two, pulsus bisferians is more common. Severe aortic regurgitation, with or without aortic stenosis or HOCM. Both peaks are in the systole. Both peaks are in the systole. HOCM is hypertrophic obstructive cardiomyopathy. HOCM is hypertrophic obstructive cardiomyopathy. इसको बोलेंगे. Both peaks are in the systole itself. On the other side, pulsus dicroticus or dicrotic pulse क्यों बोलते हैं? Because there is one peak in the systole and the one peak in the diastole. One peak in the diastole. Diastole means after the dicrotic notch. That is why the name. After the dicrotic notch. That is why the name is given as dicrotic pulse. It is very, very rare. Only theoretical concept. Okay, it is only theoretical concept. One peak in the systole, one peak in the diastole, because it comes after the dicrotic notch. After the dicrotic notch. What are the causes? The causes include severe sepsis. The causes include severe sepsis, enteric fever, previous. Now enteric fever is readily treatable. Enteric fever, you can get pyemic abscess, enteric fever, pyemic abscess, and in early stages of heart failure, because there is increased nitric oxide release from the vascular endothelium. From the vascular endothelium, we will remember this. Come on, once we go this, we'll understand. Okay, chalo. Have you written till here? Then we will draw the waveform. So when the normally arterial pulse should have only one peak. But if you find two peaks, you have to learn to differentiate between the pulsus bispirians and the pulsus dicroticus. Pulsus bispirians and the pulsus dicroticus. You have to learn to differentiate. So then tell me mechanism and waveform. Mechanism and waveform. So in severe aortic regurgitation, due to severe aortic regurgitation, what is going to happen? Understand this. In severe aortic regurgitation, there is going to be a relative narrowing of the aortic valve. Understand this. Relative narrowing of the aortic valve, okay, which leads to Bernoulli's phenomenon. Okay, ये सब physics principle है, अपने लिए नहीं है ना. Bernoulli's phenomenon. So Bernoulli's phenomena में कहते हैं when fluid passes through a narrow structure. When fluid passes through a narrow structure, then initial flow, early stages, the flow is normal. Initially, the flow is normal, but in mid-flow, the flow is reduced, and again in the end, the flow is normal. In the late, the flow is normal. I'll help you understand. Pyemic abscess means bacterial abscess. Pyemic means bacterial abscess. चलो, इधर ध्यान से देखो, है ना, Bernoulli's phenomena क्या होता है? So what do you say in this point? Relative narrowing of the aortic valve means what? Let us understand. If you have got a door, remember this, okay, door, aortic valve is like a door. When blood has to pass through the door, the door can become narrow, or the blood can become so much that the door appears narrow. Okay, so suppose a person has to walk through the door. Why does the person find difficult to walk through the door? Either the door is small or the person is large. Okay, that is also possible, no? Okay, Bernoulli's, yeah, Venturi effect. Yes, you can correct that. So old name tha Bernoulli's. We have got Venturi's effect. I will correct it. Sorry. So Venturi effect. Bernoulli's bhi hai. Abhi aa gaya Venturi phenomenon. Thank you very much, है ना? Kinal. Thank you very much. So we'll put it as Venturi effect, है ना? Bernoulli's old name capillary का. So Venturi effect is more preferred name. It's a combo scientist, but correct, you are corrected. Venturi effect. So what it says that aortic valve has become narrow. Not actually narrow, But because of regurgitation, the blood in the left ventricle is so much that it has to be pumped through the aortic valve. Aortic valve appears narrow. The aortic valve appears narrow, and that is why there can be a reduction in the blood flow into the aorta during mid systole. There is reduction to the blood flow into the aorta during mid systole due to Venturi effect. Due to the Venturi effect, right? So what we have got here? So because of this effect, I'm going to rub this off to draw the diagram here. Because of the Venturi effect, this is just for understanding what happens to the waveform. So normally the waveform should have been like this. Normally the waveform should have been like this, right? So the waveform should be like this. But in this, initially the LV contraction begins. LV contraction begins. But before it can reach the peak, aortic stenosis is there. It becomes less. Mid-cycle flow is less. You get one more peak, and then you get the dicrotic notch followed by the diastolic runoff. So you are going to get a double peak. Here one peak, second peak, then there is the dicrotic notch. Okay. So what we have to draw here in the MCQ, you will find this diagram. Image based MCQ S2 will be given to you. And if you find that there are two peaks in the systole, that means it is called as pulsus bisferians. So Venturi phenomena, due to this severe aortic regurgitation, there is going to be reduced flow mid-cycle. There is going to be reduced flow in the mid-systole, leading to the two-peak phenomena. Okay, and that is called as the pulsus bisferians. So Venturi effect. So what is important? याद से देखते हैं. What is compulsory? Severe aortic regurgitation has to be there. Due to severe aortic regurgitation, more blood comes back into the left ventricle. So there is more blood in the left ventricle, volume overload state. So this extra blood has to pass through the normal aortic valve. But now the normal valve appears narrow because the blood is more. So when it passes through a narrow passage, relatively narrow passage, there is a Venturi effect, because of which the blood flow into the aorta during the mid-cycle becomes less. During the mid-systole becomes less. And that is why we have got it here, right? So we have got here the pulsus bisferians. Other side, pulsus bisferians or dicrotic pulse. Pulsus bisferians, dicrotic pulse. Okay, so this can be little controversial. There can be different concepts to based on why there is going to be the dicrotic pulse. But let's try to understand here. So first we will make normal waveform. So we'll draw a normal waveform here, right? So what happens in severe sepsis? Let us note down what happens in severe sepsis. Endotoxin release leads to vasodilatation. In early heart failure, nitric oxide disease causes vasodilatation. So enteric fever, sepsis causes endotoxin release. Okay, vasodilatation, which causes very rapid, what is there? There is going to be rapid redistribution. Rapid distribution of blood into the periphery. Rapid distribution of blood into the periphery. There is going to be the rapid distribution of blood into the periphery. अब इसको सोचते हैं क्या होगा. So take your imagination little clearly and then we will understand this. So याद करिए, everybody with me. चलिए, so everybody with me. So what we have got, imagine this is the left ventricle, this is the aorta. Left ventricle, this is the aorta. So normally what happens when the left ventricle begins to contract, है ना, याद से देखिए, ventricle begins to contract, LV pressure is high. So उसके वजह से as soon as aortic valve opens, blood gushes into the aorta. But the pressure in LV slowly starts to reduce. Pressure in the aorta slowly starts to increase. When the aorta pressure becomes more than the LV pressure, aortic valve closes. That is S2. After that, no further blood can flow into the aorta. Listening everybody? So after the aortic pressure becomes more than the LV pressure, aortic valve closes and no further blood can flow into the aorta. But in this situation, in the patient when there is sepsis or early heart failure, the aortic blood rapidly gets distributed to the periphery. So the pressure in the aorta can dramatically fall, allowing small volume of blood to flow into the aorta even during ventricular systole. तो वेंट्रिकल को कुछ नहीं हुआ, वेंट्रिकल बेचारा वहीं पर है, वेंट्रिकल इज इन द सेम प्लेस, बट द प्रेशर इन द aorta dramatically drops, allowing some blood to flow from the ventricle into the aorta even during diastole. That is why you get a second peak in the diastole. So how will you draw this? We have got normal systole. So there is low cardiac output because sepsis can suppress myocardium, heart failure, suppressed myocardium is there, followed by dicrotic notch. Then there is the second peak followed by the diastolic runoff. So in the MCQ, focus on position of the S2. Position of the S2 is important. So one peak is here, other peak is in the diastole, other peak is in the diastole, and that is why you get a second peak in the diastole. That is called as dicrotic notch. Dicrotic notch we want to remember. So further difference for MCQ, image based difference is 1. For MCQ, odd man out, pulsus bisferians is better felt at periphery. It is better felt at periphery. MCQ question, better felt at periphery. Dicrotic is better felt in the central. Better felt at the carotid or the central pulse. Okay, so this is what we want to know. Comparison table. I will rub away the pencil marking so that you can see the image clearly. I'll take away the pencil markings so you can see the image clearly. Okay, so these are the two pictures that you can get. So when you get a image based MCQ, focus on where is the S2. If S2 is after the two peaks, it is pulsus bisferians. When S2 is going to come between the two peaks, that means you are talking about dicrotic pulse. That is the state of dicrotic pulse. Okay, there is a stages, no, in sepsis. Endotoxin causes peripheral vasodilatation. That is what you call a septic shock. In septic shock, there is going to be peripheral vasodilatation. Why low amplitude? Because sepsis suppresses myocardium. In heart failure means myocardium is weaker than normal, and that is why we are going to see. Okay, there is no specific reason why bisferians is better felt at periphery. It is just a concept here, right? So take it from here. So what did we see? Understand and write. So when we want to examine the pulse, we want to first start with peripheral pulse examination. Then do central pulse examination, where you studied in the carotid, you look for amplitude, abnormal parvus, duration, abnormality tardus, number of peak is 2, abnormality can be bispherians or pulsus dicroticus, or there can be pulsus dicroticus, right? Next one, last of the arterial pulse waveform. Last of the arterial pulse waveform, we want to study pulsus alternans. We want to talk about pulsus alternans. That is totally different from this. We have got the pulsus alternans. We have got pulsus alternans. What is this pulsus alternans? Let us study. Okay, pulsus alternans we want to study. So pulsus alternans means what is happening? One pulse is normal, other pulse is small. So one pulse is normal, other pulse is small. There is a parvus in between. Then there is a normal pulse. And then there is a small pulse. So alternating pulse is abnormal. Alternating pulse is abnormal. That's what we want to know here. Now, what is the mechanism? So this is seen in severe LV dysfunction. In severe LV dysfunction, classical example, dilated cardiomyopathy. In a dilated cardiomyopathy, very important, dilated cardiomyopathy, okay, severe LV dysfunction. Most common condition leading to alternance is dilated cardiomyopathy. We saw that in dilated cardiomyopathy, in severe LV dysfunction, what happens? Due to low stroke volume. So what is there? Due to reduced stroke volume. There is reduced stroke volume. So you are going to get pulsus parvus. You are going to get pulsus parvus. That is marked here, pulsus parvus. You are going to get pulsus parvus. But because of the reduced stroke volume, there is going to be increased end diastolic volume. There is increased end diastolic volume, EDV, end diastolic volume. For the next beat, there is end diastolic volume more for the next beat. Because of the Frank-Starling law, there is improved force of contraction. Because of the Frank-Starling law, there is improved force of contraction in this pulse now, in this beat now. That is why you can get a normal amplitude of the pulse. You can get normal amplitude of the pulse. But after this pulse is there, the LV dysfunction is unmasked. This will unmask the underlying LV dysfunction, and the patient will get next beat as pulsus parvus, and that is the cycle continues. That's why we call it as pulsus alternans. I'll give you simple analogy to understand, don't worry. So pulsus alternans मतलब क्या है, ध्यान से सुनिए. Pulsus alternans, listen very carefully. So it is seen in severe LV dysfunction, most commonly seen in dilated cardiomyopathy. Due to LV dysfunction, the force of contraction is less, so pulse volume is small. But because of less cardiac output, more blood remains in the ventricle for the next beat. So in the next beat, because of Frank-Starling law, the next beat is better than the first, which can lead to a normal amplitude pulse. After all the blood is ejected, the volume becomes less, and patient again, the LV dysfunction is unmasked. LV dysfunction is unmasked, leading to pulsus parvus. Okay, can you hear the volume now? So volume is okay from my side. Okay, absolutely okay now. Okay, volume is maximum now. I cannot see. Okay, just listen carefully. Okay, all nothing has happened actually from my end. I cannot move. It's a laptop audio only. So this is the mechanism, pulsus parvus. Okay, this is the mechanism which leads to pulsus alternans. Again, pulsus alternans is an exception. It is again better felt at the periphery. It is again better felt at the periphery. Okay, so remember for MCQ, they are exception to the rule. Okay, let us just complete this concept and then we will take a small break if at all there is no adjustment here. Okay, chalo. So this is our pulses alternans, and this is also better felt at the periphery. So among the arterial pulse waveforms, these are the two exception to the rule. Among the two arterial pulse waveform, this is exception to the rule that pulses bisperians and pulses alternans are better felt at the periphery. That is the difference that we know. Are better felt at the periphery. Okay. So this is our arterial pulse waveform that we have completed. So among the assessment methods, okay, so one by one we are taking on. So among the assessment methods, we have completed the topic arterial pulse examination. We have completed the topic arterial pulse examination. We have completed, right? So this is what we are going to know. So arterial pulse, I hope you understood. There is peripheral examination, central examination. That is what we are at, right? So going on to JVP interpretation. So after arterial pulse comes jugular venous pulse. Comes the jugular venous pulse. Okay. So what we are going to do, it is 3:35. Okay, we will take a 10-minute break. Okay, 10-minute break till 5:45. Chalo, have coffee. I'll fix the audio and get back. Chalo, run. 10-minute break. Okay, chalo. So let us start here. Right. Okay. Chalo. So let us continue here. So pulses alternance, I'll just go through quickly and then go on to JVP interpretation. Let us go through one by one. So pulses alternans, I was telling you pulses alternans. Pulsus alternans is the severe LV dysfunction. So when you get a low stroke volume, the end diastolic volume for next beat is better, and that is why there is improved force of contraction. That is what is the concept here. It's a very simple one. So I give the analogy like for a food. So suppose you want to eat a full meal. A full meal costs you, let us say, 75 rupees. Okay, so every day you are getting 50 rupees. So you got 50 rupees today. Okay, so 75 rupees you want, 75 rupees you have a meal. Next day, today you don't have 75, you have only 50. So what you do, you actually have a 25 rupee meal. So 25 rupees remains balance. So next day again you get 50 rupees. So you can have a 75 rupee meal next day. So it is like that. Just remember this. So it is the analogy that suppose to have a full meal, you require 75 rupees. Normal cardiac output should be have been 75 rupees, but your heart is pumping only 50. So you are, rather than getting 75 rupees every day due to LV dysfunction, you are only getting 50. So with 50 rupees you cannot have a full meal, but you can have a short meal of 25 rupees and save 25 for the next day. So next day when you come and again get that 50, you are able to afford a full meal. But after eating the full meal, the third day, your kangalipana or your having less money is exposed because you have only 50 rupees. So what happens is that there is going to be alternating. There is alternating. Alternance is the typical feature of a severe LV dysfunction. Okay, chalo. So let us take it forward to JVP examination. So after arterial pulse comes the JVP examination. We want to see. So jugular venous pulse. Pulse waveform typically represents the changes in the RA pressure, in the right atrial pressure. JVP waveform reflects or represents the changes in the right atrial pressure. Represents the changes in the right atrial pressure. Represents the changes in the right atrial pressure. Okay, so take it from here that JVP waveform, jugular venous pulse waveform, we have come to, represents the changes in the right atrial pressure. The JVP waveform is best examined in the internal jugular vein. It is best examined in the internal jugular vein because it is a valveless vein, and that is why it conducts the right atrial pressure accurately. It is going to conduct the right atrial pressure accurately. So jugular venous pressure represents the changes in the right atrial pressure. It is best examined in the internal jugular vein because it is a valveless vein. Okay, so let us draw. How is it different from the arterial waveform? Here there are normally also two peaks in the JVP. Unlike the arterial waveform, the JVP normally has got two peaks. Unlike arterial waveform, which has only one peak. Here we have got two peaks in the JVP waveform. Learn to draw with me. Learn to draw the JVP with me. First we have got the positive A wave, which is most prominent, followed by the small C wave. There is the X descent, there is the V wave and the Y descent of the JVP. So label with me please. So we have got the most prominent wave of the JVP is the A wave. We have got one more small, that is the C wave, V wave, the X descent and the Y descent of the JVP are present. So there are two peaks, that is the A and the V are the two peaks of the JVP waveform. Most prominent is the most prominent peak we have to see here. This C we don't get to see. C is very inconspicuous. We may not be able to see nor palpate. So there are the two peaks that come in the JVP. Let us see how they are formed. The small portion which is there from A to C, this is called as the X dash. This is called as the X dash. Let us try to remember. Now, how to remember? So JVP questions jab aate hain, most of us get afraid of JVP questions because we are actually not clear with the physiology. So today we are going to anticipate the questions of the JVP. The whole idea is to anticipate the questions of the JVP. What we will do, divide the JVP questions into three. First, based on physiology. Number two, based on the defects and causes. And number three, image based JVP questions. Okay, three levels. So first one, physiology. So what we want to do, which are the different waves of the JVP? Which are the different waves of the JVP with the corresponding cardiac event? So first, physiology with the corresponding cardiac event. That's all we want to know. So what are the different waves of the JVP and what are the corresponding cardiac events is the first level of MCQ in JVP. Most prominent is the A wave. Okay, X is not a point, X is the descent. The going down waveform is the X. This C to down is the X descent. V to down is the Y descent of the JVP. Okay, it is not a point here. So what are the waveforms and how to remember? I'll give you a very simple way to remember the corresponding cardiac events. Okay, everybody, let's start. So simple way to remember, A for A. A wave represents right atrial contraction. It is the most prominent, represents the right atrial contraction. So A for A, atrial contraction. All of us can easily understand when the atria contract, the pressure in the chamber will be maximum. The pressure in the chamber will be maximum, and that is why it is the most prominent wave of the JVP. Most prominent wave of the JVP. Second, we have got the C wave. Simple to remember. C for C. C is due to right ventricular contraction. Contraction of the right ventricle. Contraction of the right ventricle which causes bulging of the tricuspid valve into the right atrium. Okay, so A wave, A for atrial contraction. C wave, contraction of the right ventricle which causes the bulging of tricuspid valve into the right atrium. Into the right atrium. We have got the X descent of the JVP. We have got the X descent of the JVP. So X descent is due to atrial relaxation. Remember like this, atrial relaxation. Due to atrial relaxation. After the atria has pumped the blood into the ventricle, it is going to relax. So the pressure in the chamber starts to reduce. As it is reducing, there is the V wave. Where does the atria receive the blood from? From the vena cava. Right atrium receives blood from inferior and superior vena cava. V for V. Vena caval filling of the right atrium. Filling of the right atrium. And finally, we have got the Y descent of the JVP. Y descent is due to emptying. Okay, emptying of the atria into the ventricle, into the right ventricle. This is how to remember the physiological events related to the JVP waveforms. Okay, so number one here we have got it now. Jugular venous pulse waveform reflects the changes in the right atrial pressure. It is best examined in the internal jugular vein. Unlike the arterial pulse, it has got two peaks. Okay, the most prominent wave is the A wave because RA pressure is maximum when the right atrium is contracting, followed by the C wave. After the atria has contracted, ventricle starts to contract. In the ventricle, there is the tricuspid valve bulges into the right atrium, leading to small increase in the right atrial pressure. Atria continue to relax, leading to X descent of the JVP. V wave is due to the vena cava filling. It receives blood from the vena cava. And Y descent is emptying of the right atrium into the ventricle. Okay, so very simple here to remember corresponding cardiac events to the different waveforms of the JVP. Different waveforms of the JVP. Y is a descent, A is a peak. Swati, there is a total difference between the two. Okay, so this is our first step of JVP, that is physiology. Let's come to the second step. Second step of JVP is the pathology. Second step of JVP is the abnormal. Simple questions that come. What are the questions? Which are the JVP abnormalities? Which are the JVP abnormalities? And what is their clinical significance? What is the clinical significance we want to see? So second level questions. First level questions are based on physiology. This year also we got a question that the C wave corresponds to which cardiac event. Okay, just that much we have to remember. Okay, so C wave, that's what we want to remember. Now we want to know the abnormality. After normal comes the abnormality. Abnormalities of the JVP with the significance. Most common are related to A wave. Due to A wave, JVP abnormality, A wave defects. Let us start with the A wave defects are most common. So since it is most prominent wave of the JVP, abnormalities also are typically found in the A wave. A wave defects are divided into three. There can be one giant A wave or the prominent A wave. Giant A wave or the prominent A wave can be there. Number one, giant A wave or the prominent A wave can be there. So think about it. Think about the physiology. What does the A wave represent? Which event does it represent? Atrial contraction. So when it is more prominent, that means the pressure in the atria is more than normal. Why will the pressure be more than normal? When the RA contracts against resistance. When the RA contracts against resistance, then the pressure will be more than normal. When it contracts against resistance, that means the pressure in the RA will be more than normal. All of us can easily remember this very small diagram here. Okay, so the small diagram, right atrium. Okay, so this is the internal jugular SVC, IVC, and we have got the RA. So from the RA, the blood passes through the tricuspid valve into the RV. From the RV arises the pulmonary artery. Pulmonary artery is there. So we have got the tricuspid valve, right ventricle, the pulmonary artery is present. So if the RA has to contract against resistance, where can be the defect? Defect number one. Defect number one. Just give numbers. Defect number one, tricuspid valve defect. There can be tricuspid valve defect. And what is the disease? Tricuspid stenosis. Very simple. You can easily write down, understand the causes rather than memorize them. So right atrium contracts against resistance. First resistance can be at the level of tricuspid valve. If the tricuspid valve is normal, second defect can be at the level of right ventricle. So there is impaired right ventricular compliance. So the right ventricle is unable to accept the blood. So second mechanism is impaired right ventricular compliance. Right ventricle is not ready to receive the blood. What can be the causes? It could be the muscle itself. There could be restrictive cardiomyopathy. There could be restrictive cardiomyopathy, or outside the muscle there is constrictive pericarditis. There is constrictive pericarditis, or there can be cardiac tamponade, or there can be cardiac tamponade can be present. Okay, keep it simple please. So there can be muscle problem. Ventricular muscle is unable to relax, or outside the ventricle the pericardium has become thick and not allowing RV to dilate, or there is a massive pericardial effusion which is preventing the right ventricle from receiving the blood. And number 3 can be at the level of pulmonary artery. This can be due to pulmonary hypertension. Pulmonary arterial hypertension can be the problem. Pulmonary arterial hypertension can be the problem. Pulmonary hypertension has many causes. It could be isolated, previously called idiopathic pulmonary arterial hypertension. It can be because of recurrent pulmonary thromboembolism. It could be because of cor pulmonale. Could be because of cor pulmonale. So we have got the answers. So MCQ question is, A wave defects are the most common abnormality in the JVP. A wave defects are most common abnormality in the JVP. So one of the defects of the A wave is the giant or the prominent A wave. Giant or the prominent A wave. So if A wave is prominent, that means RA pressure is more than normal. And why it will happen more than normal? Because there is a tricuspid stenosis, or there is problem in the RV compliance, or there is problem in pulmonary hypertension. Simple way, you have to derive the thing. Pulmonary thromboembolism, or there is cor pulmonale. Okay, this is how we want to know. Number 2, there can be problem, can be Canon A wave. It can be Canon A wave. So Canon A wave is giant ka bhi baap, bigger than giant. Means what? Here the RA contracts against a closed tricuspid valve. So here the resistance is how? 100% resistance. There is no blood flowing from the RA into the ventricle. So RA is giving maximum pressure. But still it is not able to deliver the blood into ventricle. So pressure becomes maximum. What it is taken as? It is taken as a sign of AV dissociation. MCQ. It is a sign of AV dissociation. Because in a normal person, atria and ventricle contract in synchrony. When the atria contract, ventricle relaxes to receive the blood. But in some conditions, when atria and ventricle contract together, the atria might contract against a closed tricuspid valve. That's called as AV dissociation. And the number 1 cause is third degree heart block, complete heart block. Third degree heart block or the complete heart block, and ventricular tachycardia. Okay, So please come to this. Okay. So Neha B, have we come to restrictive cardiomyopathy? No, na. So wait karenge. Ana, we will not go into the detail of disease. This is clinical examination I am talking about. Let us understand. As we read the disease, we will learn to correlate the clinical feature along with the disease. So don't worry, we'll get all answers, but be patient. Okay, so number 3, there could be absent A wave, and that is the most easy. Absent A wave, that means there is ineffective atrial contraction. There is ineffective right atrial contraction. That means the patient is having atrial fibrillation. Patient is having atrial fibrillation. That is the correct answer here. That is the correct answer. Okay, so blood will not flow. That is why the A wave will be maximum. No, pressure in the RA will be maximum. Everybody pay attention please. Canon A wave, normally atria will contract first, ventricle will contract second. Okay, this is the normal phenomenon. So when the atria contract, ventricle is ready to receive. That is why blood normally flows. But in third degree AV block, complete heart block, there can be some beats when atria and ventricle both contract together. When both contract together, the ventricular pressure is very high. It will not allow tricuspid valve to open. So atria is contracting, but tricuspid valve is closed. So the blood also is there and the pressure is also there. That is why the RA pressure becomes more than normal. That is why you get a Canon A wave. In ventricular tachycardia also, in few beats, you hear in ventricular tachycardia, there is a ventricular ectopic pacemaker, but there can be some occasional sinus beat also. So when they fuse, what can happen? Sinus, atria is contracting, ventricle is contracting to ectopic pacemaker. So there can be few beats, not all of them, few beats when the both atria and contract together. That is called as AV dissociation. There is no relation between atria and ventricle. When they contract together, then what happens is we get a Canon A wave. We get a Canon A wave on the JVP. Canon A wave on the JVP. Absent A wave means there is ineffective RA contraction. Ineffective RA contraction. That is atrial fibrillation. We discussed in the previous session that in atrial fibrillation, the minimum heart rate is, atrial rate is 350 per minute. So atria are beating very fast, but not enough to maintain any pressure. So that is why we get atrial fibrillation. This is the correct answer till here. So these are for our MCQ, straight answer, abnormality based question. Third level we will come to image based MCQ of the JVP. The commonest image that is asked is what are the JVP abnormalities in severe tricuspid regurgitation. The commonest one, JVP abnormality in severe tricuspid regurgitation. Okay, very important question, because these have characteristic features. Why it is asked in MCQ? Because they are characteristic features associated with only this disease, that is severe tricuspid regurgitation. It is associated with, and that is why they are asked frequently. So let us look at the features in severe tricuspid regurgitation. A junctional rhythm does not cause anything, no, because there is going to be reverse pathway. So it is not a cause, okay. So JVP abnormality in severe tricuspid regurgitation. Try to understand. So first we will draw like we did in arterial waveform. Use your pencil to draw normal JVP. Use the pencil to draw normal JVP. But when you draw the JVP, I want you to read it in the form of cardiac event. Read it in the form of cardiac event like this. So the patient is having right atrial contraction. Right atria starts to relax, tricuspid valve bulging, atrial relaxation, vena cava filling, followed by the emptying into the ventricle, followed by emptying into the ventricle. है ना, ध्यान से सुनो, we are coming to each wave. Why don't you wait यार, है ना, तुम लोग बहुत hyper batch. So we have to wait for the thing. Just we have discussed all A wave abnormality. I'm taking it to the next step, keeping it so simple. So this is the normal. So we have got A wave, C wave, V wave. This is the X descent. There is the Y descent, and this is the X dash. This is the X dash that we have got. Now let us imagine what will happen in a patient with tricuspid regurgitation. What will happen in a patient with severe tricuspid regurgitation? We want to know. So imagine in tricuspid regurgitation, is there any problem of blood flow between RA to the RV? Is there resistance? Answer, no, there is no resistance. So the A wave is normal. There is no resistance. The A wave is normal. There is no resistance. There is no resistance. So the A wave is normal. Atria is normal. It starts to relax normally. The atria is normal. It starts to relax normally. But after that, normally what should have happened? There should have been only bulging of the tricuspid valve. But rather than just bulging, now there is regurgitation. So the blood will come back and fill the ventricle, atria. The blood will come back and fill the ventricle. So rather than receiving the blood from the vena cava, the blood will now be received from the ventricle itself. Will be ventricle from the ventricle itself. So A wave is normal. X descent, X dash is present. But what has happened? The C is there and there is the V wave. But X has gone away. Y is present. X has gone away. So what are the problems here? Number one, there is absent X descent. There is absent X descent. Because we cannot have relaxation because the regurgitant blood from the ventricle fills the right atrium, does not allow further reduction in the right atrial pressure, because of which the C wave is connected to the V wave. That is also called as CV abnormality of the JVP. It is called as CV abnormality of the JVP. Okay, CV abnormality of the JVP. And finally, if I rub these things off, what does it do? This appears, it mimics arterial waveform. The JVP now can mimic the arterial waveform, and that is what is called as ventriculization of the JVP. It is called as ventriculization of the JVP. It is called as. Okay. So remember these points now. So JVP abnormality in severe tricuspid regurgitation is very commonly asked question, because the features of this disease are peculiar to only this disease. So MCQ याद करो. Absent X descent मतलब severe tricuspid regurgitation. CV abnormality, severe tricuspid regurgitation. Ventriculization of the JVP is also severe tricuspid regurgitation. So emptying will be normal, no? Because there is no stenosis. Ventricle will receive the blood. So the Y descent is normal. Only problem is atrial relaxation cannot occur again. So in tricuspid regurgitation, the right atrium contracts and the blood will flow into the ventricle, normal. Once it flows, the right ventricle contracts, and what should have happened? Only it should have caused bulging. But instead of just bulging, the flow from the ventricle increases the RA pressure, and then the RA empties into the ventricle. So why ventriculization? Now it looks like arterial waveform. हमने पढ़ा ना? This is anacrotic shoulder, dicrotic notch जैसा लगने लगता. There is single peak. It appears like a arterial pulse. It appears like a arterial pulse. That's what we must remember. Looks like a arterial pulse. So this is commonly asked question. What remains is the Y descent abnormality. What remains is the Y descent abnormalities remains. Okay, which we will refer to the pericardial disease. So what we will do, keep this place here. You will write here, refer to pericardial disorders. Refer to the pericardial disorders. So when we discuss pericardial disorder, we will fill the points here. Pericardial disorder के साथ we will fill the points here. Okay, so what is to repeat is what I want to understand. What is there to repeat? It's a very simple point, no? So it is blood is coming RV into RA, है What is X? Anyone? X is the descent, atrial relaxation. Atria start to relax, and that beginning is okay. But before the atria can relax further, the regurgitant blood from the ventricle fills the atria, and that is why further atrial relaxation cannot occur. That is what is X descent. Further atrial relaxation cannot occur. Okay. CV abnormality, that's what we call it, and ventriculization of the JVP. Okay, so keep it till here. So we have got the Y descent abnormality. We will study with the pericardial disorder. We will study with the pericardial disorder. Now we will continue further. So what we have got here? So JVP waveform we suggested with arterial waveform we compared. But what I want you to understand, here we want to review the physiology of the ventricular diastole. We want to review the physiology of the ventricular diastole. We want to review the physiology of ventricular diastole. We want to review here. So if you all remember, along with arterial waveform, I told you the phases of the ventricular systole: isovolumic contraction, rapid ejection, delayed ejection. Now here we want to know that what is the physiology of ventricular diastole or ventricular filling, we can say. Ventricular filling. How does the ventricle receive the blood? Receive the blood. So the ventricular filling is divided into two. There is the early filling phase. There is the early filling phase, that is denoted as E. There is the early filling phase E, and there is the late filling phase. Early filling phase and the late filling phase, which is also called as atrial kick. That is why denoted as A, called as the atrial kick, denoted as A. So ventricular filling, we want to see ventricular filling, early filling phase, and there is late filling phase. Okay, early filling and late filling phase. Early filling phase occurs due to the ventricular relaxation, occurs due to ventricular muscle relaxation. That is why it depends on the compliance of the ventricular muscle. Depends on the compliance of the ventricular muscle. Please understand. So how does the ventricle receive the blood? How does the ventricle receive the blood? Ventricle receives the blood when the ventricle relaxes. So as the ventricle dilates, the negative pressure is created and the blood will be sucked from the atrium into the ventricle. So the early filling phase occurs due to ventricular relaxation. That means it depends on the ventricular muscles ability to relax. That is called as compliance. Ventricular's ability to relax. That is called as compliance. Normally, here how much comes? 80 to 90% of the end diastolic volume. 80 to 90% of the end diastolic volume is achieved in this phase. Achieved in this phase, and it is enough to maintain systolic function. Enough to maintain the systolic function. It is enough to maintain the systolic function. Okay. So what did we discuss in first session? That Frank-Starling law. Frank-Starling law. So in the early phase, 80 to 90% of the end diastolic volume comes into the ventricle. That volume is enough to stretch the myocardium so as to maintain the contractility, enough to maintain the systolic function. This is enough. So as long as the ventricular compliance is normal, the patient will be maintaining adequate cardiac output, we can say. On the other hand, the late filling phase, also called as atrial kick, because this is due to atrial contraction. This is due to the atrial contraction. So whatever blood ventricle can receive, 80 to 90% is received. Remaining 10 to 20% has to be pushed into the ventricle during atrial contraction. So as long as if the early filling is normal, A contributes only 10 to 20% only of the end diastolic volume. As long as the early filling phase is normal, atrial contraction is not important because it contributes only 10 to 20% of end diastolic volume. And hence, if the early filling is normal, A is considered hemodynamically insignificant. A is considered hemodynamically insignificant. This is a very important concept I want you to remember. That is why we say that as if the person's heart is healthy, even if there is atrial fibrillation, you will not get hypotension. You will get hypotension when the heart is already weak, when the heart was not getting enough filling. By the compliance, atrial contraction was important. But if the early filling, compliance passive filling is normal, active filling is considered hemodynamically insignificant. We can say it is considered insignificant. We can say. So what is the corollary? We can extract further. We can say that when the A is significant, suppose the A becomes significant, that means there is ventricular non-compliance. We can say there is diastolic dysfunction. So we can say that if the A becomes significant, if the contribution of the A becomes significant, then it is suggestive of impaired ventricular compliance. Suggestive of impaired ventricular compliance. and in other words we can say that is diastolic dysfunction. In other words we can say diastolic dysfunction is present. In other words we can say diastolic dysfunction is present. We can say that diastolic dysfunction is present. We can say that. Okay. All this physiology is relevant for you to understand medicine. Okay. Is important to understand the medicine. This we must remember. But since we are in the JVP, what does it correspond to? Which JVP waveform does this correspond to? That's the question. Which JVP waveform do they correspond to is the question. All of us know that atrial contraction means corresponds to A wave. Atrial contractions means corresponds to A wave of the JVP. Corresponds to A wave of the JVP. But ventricular relaxation means ventricular filling. When does the ventricle fill? When the atria empties into the ventricle. That is why it corresponds to Y descent of the JVP. Corresponds to the Y descent of the JVP. We can say corresponds to Y descent of the JVP. Okay, so A becomes significant means if the contribution of atria is more than 20% of the end diastolic volume, we can say that means that the early filling was not enough. Okay, because early is coming first, no? If it does not fill the ventricle, then only atria have to force blood into the ventricle. So we can say indirectly that if A is abnormal, that means E has to be abnormal. Compliance in a way is corresponding to diastolic dysfunction. We can say there is diastolic dysfunction. So what I am wanting to connect is that previous page we have left it hanging, no? Y descent abnormality. Remember, Y descent abnormalities means indirectly I am saying abnormality of early filling phase. Indirectly I am telling it is the abnormality of early filling phase. Everybody clear? So take it from the start. So this session, where have we started? Let us try to recall. This session we have started with JVP abnormalities. Come on, rapid fire round. Okay, JVP abnormalities. Now we know what are the corresponding cardiac events with the different JVP waveform. Okay, sit back, look in the book and recall with me. Look into the book and recall with me. A wave corresponds to atrial contraction. C wave corresponds to contraction of right ventricle causing bulging of tricuspid valve into the right atrium. X descent stands for atrial relaxation. Okay. V is vena cava filling of the atria. And Y descent is the emptying of atria into the ventricle. Most common is the A wave abnormality. Among the A wave abnormality, you can get giant A wave, Cannon A wave, absent A wave. The causes of giant A wave are those due to tricuspid stenosis, impaired right ventricular compliance, pulmonary arterial hypertension. The cause of Cannon A wave are those diseases causing AV dissociation, that is third degree AV block and ventricular tachycardia. And absent A wave is seen in atrial fibrillation. The characteristic features of the severe TR JVP findings in severe tricuspid regurgitation are CV abnormality, absent X descent and ventriculization of the JVP. So in short, we have talked about A wave abnormality. We have talked the cause of absent X descent. So effectively what is there? There is only Y descent abnormalities that remain. But those Y descent abnormalities become relevant in pericardial diseases, which we are going to discuss now. And to add to that, we have understood a physiology of ventricular diastole or fill. Okay, so let us take it further. So what we have to do is to start with the pericardial disorders. So JVP can be felt also, seen also. JVP waveforms are better seen than felt. They can be seen also, felt also. Seen also, felt also, but better seen than felt. Right? So let us connect our topic here. So the tangent we are starting some part of the pericardial disorders. We are starting with some points about the pericardial disorder, and then we will connect it with our class here. Okay, so let us keep it very simple, very simple. It must be very, very effective. That's the thing. So mainly what are we going to discuss? ये मैं डाल दूं आपके सामने, pericardial disorders. So we want to discuss the pericardial disorders. I'll keep it very simple because we have to know only what we want to know, not unnecessary knowledge. We don't want to waste our brain on all that. Okay, so two topics are important. One is the cardiac tamponade. One is the cardiac tamponade, CT, and you have to learn to compare it with the constrictive pericarditis. You have to learn to compare it with the constrictive pericarditis. Learn to compare with the constrictive pericarditis, right? Everybody, make the column and be ready. Make the column and be ready. We'll keep it very simple. So I'll take you back. Okay, I'll take you back that where we have started this. Just let me take you back to how we have to study medicine. Okay, integrated approach. What I told you, look again. So we have done the assessment methods, we have enumerated, we have classified the disorder. Now we are starting with our first individual disease. We are starting with the first individual disease. Okay, first individual disease we have written down. Okay, so pericardial disease, what points we want to know? We want to know the definition, epidemiology, pathophysiology, clinical feature, diagnosis, treatment and prognosis. Same order I want you to follow. Okay, so let us fill that. Whatever we know we will write, and rest we will keep it empty till we can fill up all the blanks here in front of me. Come on, let us start with this pericardial disorder. Differences between the cardiac tamponade versus constrictive pericarditis. Constrictive pericarditis, right? Start with the definition. So start with the definition of these pericardial disorders. So write with me please. Cardiac tamponade is an acute complication. Why we are reading it together? I will tell you. It is an acute complication of rapid or massive pericardial effusion. So look at the feature it has to have. Massive or rapid pericardial effusion. It has to be there. So it is basically acute complication of a rapidly filling or a massive pericardial effusion. What are the causes? It is most commonly associated with the idiopathic effusion. Most commonly associated with idiopathic effusion. It can also be seen in malignant effusions. Malignant effusion. So most commonly cardiac tamponade as a complication you expect in a massive pericardial effusion. Massive कैसा होना चाहिए? Typically कैंसर में होता है, malignancy में होता है. That is the main problem that we have. But compare it. Constrictive pericarditis. Constrictive pericarditis is a chronic complication. It is a chronic complication of pericardial effusion. It is a chronic complication of pericardial effusion which occurs due to adhesions. In the layers of the pericardium. In the layers of the pericardium, leading to thickened pericardium. And the most common cause of the pericardial effusion is tuberculous pericardial effusion. Is the tuberculous pericardial effusion. It is the tuberculous pericardial effusion which can cause this problem. So first start with the definition. We are reading it together because both of these are complications of pericardial effusion. Both of these are complications of pericardial effusion. But cardiac tamponade is a acute complication, while constrictive pericarditis is a chronic complication of the same problem. That is your pericardial effusion. Cardiac tamponade is seen with idiopathic or malignant effusion, while constrictive pericarditis is a typical complication of tuberculous pericardial effusion. It is a complication of tuberculous pericardial effusion. Now further, what is pathophysiology? Let's write down pathophysiology. What is the pathophysiology that is happening in the disease? Pathophysiology that is happening in the disease. Okay, draw this illustration with me. Come on. So what is happening? There is a massive or rapid collection of fluid in the pericardial sac. Massive or rapid collection of fluid in the pericardial sac. What it does? It exerts the pressure on the ventricle, does not allow the ventricle to relax. It does not allow the ventricle to relax, and that is why it causes impaired ventricular filling. So because of this, there is going to be impaired ventricular filling. Impaired ventricular filling. That means diastolic dysfunction. Right, everybody? That's why we are understanding in pattern. So ventricular filling occurs in two phases. Just now we have studied. Is it the early phase that is affected or the late phase that is affected? Think about it and tell me. In cardiac tamponade, which phase is affected? Predominantly the early phase or the late phase? Which is affected? Think about it. So in a pericardial effusion, it will prevent the passive filling. It will prevent the passive filling. That means which phase is gone? Early filling phase is affected. That means early filling phase is predominantly affected. And all of us know early filling phase is very vital. Early filling phase is very vital. Very good. So early filling phase is predominantly affected in the disease. Along with that, there is also equalization of ventricular pressures. There is equalization of the ventricular pressure. Equalization of the ventricular pressure is seen. So imagine like this. Understand the analogy. The analogy is that suppose you have got two currency notes. One note is 100 rupees, one note is 500 rupees. Okay, so right ventricle hamara 100 rupees, left ventricle strong chamber 500 rupees. But both the currency become different only when they come out of the wallet, no? But if both are kept in the wallet, same wallet, they will be counted as only one note each. They are just counted as one note each. So what happens? The pericardial effusion exerts the same pressure on both the chambers. So both the ventricles have the same ventricular pressure, which basically reflects the outside pericardial pressure. That's why we say equalization of ventricular pressure can occur. And characteristic, we used to say, what is the X-ray picture? X-ray picture can show water bottle appearance. On a water bottle heart, we call this, no? It is called as the water bottle heart of the chest X-ray, water bottle heart. So what is the idea? This water bottle you have generation has never seen. In small, when I was young, there used to be that squeezy bottle which came, which was circular and you have to squeeze that. So typically cardiac tamponade. That's why it was said to be water bottle appearance on the chest X-ray can be seen in a pericardial effusion. In a pericardial effusion. On the other side, constrictive pericarditis. What is happening? Draw with me. Constrictive pericarditis. What is happening? In constrictive pericarditis, there is adhesions between the layers of the pericardium. There is adhesions between the layers of the pericardium, which causes thickening of the pericardium, which leads to thickened pericardium. Which leads to thickened pericardium. So because of the adhesions, there is going to be thickened pericardium is seen in the heart. Thickened pericardium can occur in the heart. Okay, so thickened pericardium, what does it do again? Again, same problem. It also impairs the ventricular filling. It also impairs the ventricular filling. That's why we are reading it together now again. It is impairs ventricular filling also. So look at the pathology. This is also impaired ventricular filling. This is also impaired ventricular filling. So both these defects cause the diastolic dysfunction. They are affecting mainly diastolic function. But in this, what is the difference? What is the thing? Only heart disease. Only heart disease predominantly affecting late filling. Only heart disease predominantly affecting the late filling. Okay, very important. It is the only heart disease predominantly affecting the late filling. Why? What happens to the late filling? Imagine like this. In the thickened pericardium, ऐसे सोचते हैं, the ventricle can receive 100 ml of blood. But because of the outside pericardium, the capacity of ventricle has now become 80 ml only. But the first 80 ml is received by passive filling. So early phase is normal. The blood will come inside. But the late phase, even though atria pumps, already the ventricle is full, and that is why it does not go inside. So atrial kick does not work because ventricle is already full and there is no more place for it to expand. So what happens? The blood remains in the atria. Listen carefully. In the next cardiac cycle, now the atria receive more pressure. Atria is under more pressure. And when the tricuspid or mitral valve will open, there will be rushing of blood from atria to the ventricle. That means early filling phase will be exaggerated. The early filling phase will be exaggerated in the next cardiac cycle. There is the exaggerated early filling. There is the exaggerated early filling phase. Okay. So tell me now, what are the questions we want to look for? So this is what here. So in the constrictive pericarditis, अरे लिसन केयरफुली ना, वेंट्रिकुलर फिलिंग को जगह नहीं देता है ना. थिकन्ड पेरिकार्डियम डज नॉट कॉज एनीथिंग टू द वेंट्रिकुलर मसल, but it becomes like a tight thing, constricts the ventricle. does not allow the ventricle to dilate, and that is why the filling becomes impaired. So after the blood has been received by the early filling phase, where 80% of the blood has come, there is no further space for ventricle to dilate, and that is why you get increased right atrial pressure, and that is why you said it is one of the causes of giant A wave, constrictive pericarditis. It is the cause of giant A wave. We have already written. So when the RA pressure is more in the next cardiac cycle, when the early filling phase starts, the blood will flow more rapidly. Blood will flow more rapidly into the ventricle. That is why we call it as exaggerated early filling phase. There is a exaggerated early filling phase will be there. So this is pathophysiology of the disease. Okay. Now, based on this pathophysiology, can you tell me the clinical feature? Let us see now. Based on this pathophysiology, let us come to the clinical features here. So clinical features, I will continue like this. Clinical feature of the disease. What can be there? Clinical feature of the disease. Okay, clinical feature of the disease. After pathophysiology comes clinical feature. Come on, you will be able to answer. If you know the pathophysiology, you can answer medicine. Try this with me. Come on. So in this situation, what will happen? What will happen to the patient? Cardiac tamponade. Everybody, cardiac tamponade. Early filling phase is affected. And how it has happened? Acute complication. So suddenly, if 80% of the ventricular filling does not occur, what will happen to the ventricular pressure? It will fall. So patient comes with hypotension, because there is a sudden decrease in ventricular filling. There is going to be hypotension. There will be engorged neck veins. There will be engorged neck veins will be present. So there is hypotension. There is engorged neck veins. Patient comes with. Basically, patient has gone into acute heart failure. Because of the low flow, when you auscultate, you will get muffled heart sounds. You will get muffled heart sounds on auscultation. Muffled heart sounds on auscultation. And this together is called as the Beck's triad of cardiac tamponade. These are called as the Beck's triad of cardiac tamponade. We can say this is the Beck's triad of cardiac tamponade. We can say Beck's triad of cardiac tamponade we are going to have. And what did we say? When you suspect cardiac disease, you check the clinical examination, Y descent of the JVP. You will check the Y descent of the JVP. What will you get? What is happened to early filling phase? It is impaired. Early filling phase is impaired. That is why we say absent or attenuated Y descent. Absent or attenuated Y descent, because early filling is not occurring. So dyspnea will be present. Dyspnea is a part of heart failure. Heart failure में breathlessness is a symptom, not the disease. Here the manifestation will say patient comes with acute onset of hypotension, engorged neck vein with muffled heart sound. Heart sounds are muffled because of two mechanisms. One, because of the presence of pericardial effusion, and number two, because of the low cardiac output state. The heart sounds become muffled. Heart sounds become muffled. And because early phase, we have written no, Y corresponds to early phase. Y descent corresponds to early phase. So Y descent is absent or attenuated. But on the other side, in constrictive pericarditis, in early stages, what will happen? Only A is affected. A is affected means small amount of volume is less. So there is decrease in the stroke volume. But to maintain the blood pressure, what is there? There is compensatory rise in the heart rate. Compensatory rise in the heart rate leading to palpitation. So hypotension is not immediate. Hypotension is not immediate. In early phases, there will be small reduction in the stroke volume, which will lead to compensatory tachycardia, which presents as palpitation. But in the late stages, it can lead to tachyarrhythmias and features of heart failure. Tachyarrhythmia risk and heart failure can occur in this patient. Heart failure can occur in this patient. So what happens to the Y descent? Here, Y descent is exaggerated. Y descent is exaggerated Y descent. Exaggerated Y descent will occur. है ना? So in constrictive pericarditis, आप लोग क्या सुनते हो? I have no idea. Compliance of the ventricle नहीं खराब हुआ है ना? Compliance किससे खराब हुआ है? Ventricular muscle relax होता है. That is early filling. Ventricular muscle is normal. Only the space for the muscle to dilate is reduced. Okay, that is how we have to see. Okay, so late, if you do not treat and the constriction goes on increasing, then early filling also will get affected and patient will go into hypotension. Okay, that is a very late complication. It takes 12-15 years for patient to develop heart failure if you don't treat. If you don't treat, it will be taking long time for the heart failure to occur. Is heart failure to occur, right? So this is about JVP connection. This is the JVP connection. Write it back now. Let us write it back. Write it back on the JVP column. Come on, go 2 pages back. Let us go 2 pages back and write down this answer for me. So Y descent abnormality can be 2 in number. Y descent abnormality can be 2 in number. What we have studied? Cardiac tamponade and constrictive pericarditis. In cardiac tamponade, the Y descent is absent or attenuated. It is absent or attenuated. And contrasting with that, Y descent is exaggerated in constrictive pericarditis. It is exaggerated in constrictive pericarditis. Anna, you are all same your question you are asking. It is exaggerated because early filling occurs rapidly. 3 बार समझाया मैंने, है ना? Early filling occurs rapidly. That is why early filling is exaggerated in the next cycle. Exaggerated in the next cycle. Y means early filling. That is why it is exaggerated Y descent in constrictive pericarditis. Okay. So अब इसको पूरा याद करो. JVP abnormalities all complete. A wave abnormality, absent X descent मतलब severe TR, absent Y descent मतलब cardiac tamponade, and exaggerated Y descent means constrictive pericarditis. Then there will be constrictive pericarditis. है ना? So Hemant Panchal, है ना? Hemodynamically insignificant means it is not enough to cause hypotension alone. So how the hypotension does not occur? Stroke volume comes down, but hypotension does not occur because compensatory mechanism like tachycardia can maintain the blood pressure. Does not mean patient is normal. Hemodynamically insignificant is a word used in relation to maintenance of blood pressure does not mean patient is normal. Okay, this is our point here. So we have got all the points of JVP examination, what can occur, and we have also started the series of pericardial disease. So what I want you to do, so in this pericardial disease, I want you to leave one page. In pericardial disease, I want you to leave one page extra. है ना, columns बना के रख देते. We'll make the column and keep so that there is no confusion with you. Okay. So continue. This column बना के रखते हैं. That after this, what are the points we want to write? I'll make the column and keep for you. Then we can fill it up as we learn each topic. We will fill it up as we learn each topic. After this, next clinical examination, याद करिए, we want to study after the arterial pulse and JVP examination. Okay, after the pulse and JVP examination, what we want to study? We are wanting to study pulses paradoxes. So make a column. We are going to study now pulses paradoxes. We are going to study along with pulses paradoxes. We are going to study Kussmaul's sign. We are going to study Kussmaul's sign. We are going to study Kussmaul's sign. Next, we are going to study the heart sounds and murmurs. We are going to study heart sounds and murmur. दो लाइन छोड़ना है. I want you to leave two lines and write the points here. Okay. So we have got clinical examination. I have written down. Clinical examination. I have written down. But after clinical examination, gold standard test चाहिए. So it is echocardiography, structural disease. So what is the most common finding? Most common finding on echocardiography. What is the most specific finding? MCQ changes. You will make this column and keep, no? Most specific finding on echocardiography. ये कॉलम बना के रखेंगे, है ना, so that we will fill it up as we learn each topic. We will fill it up as we learn each topic. And finally, we come to the treatment and prognosis. We will discuss the treatment and prognosis of the disease. So the topic of pericardial disease will be over. Topic of pericardial disease will be over. Yes, continuation of the table. Continuation of the table. So we have to write all these points. Okay, so just you have to leave one page approximately. So that's why I have filled these columns for you. That beyond the JVP, you are going to write down the topics which we are going to learn in the class in this session. Pulses paradoxes, 2 lines. Kussmaul's sign, 2 lines. Heart sound, 2 lines. Most common finding, 2 lines. Most specific finding, 3 lines on echocardiography. And finally, you want to leave the treatment and prognosis. Treatment and prognosis you want to leave, right? So one by one we want to study, and then we will come back to this thing, right? So chalo, let us come back here. So where are we? I'll take you back to the index and then we will keep going ahead. So here we are on the assessment methods. On the assessment methods. Okay, treatment prognosis के लिए 5 lines छोड़ दो. 5 to 6 lines for treatment and prognosis. 5 to 6 lines for treatment and prognosis. That's all you have to see. Chalo. Next one. So what we have done? We have completed the topic of JVP examination also. Completed the topic of JVP examination also. So everybody remain oriented to me. Okay. When we suspected cardiovascular disease, we checked for peripheral pulse, central pulse. We examined JVP interpretation. What is left now? Next, we will learn about pulsus, paradoxus and Kussmaul sign. Learn it together. Pulsus, paradoxus and Kussmaul sign. We will learn them together. Let us see this. Pulsus, paradoxus and Kussmaul sign. Pulsus, paradoxus and Kussmaul sign. Okay, so let us start here. Pulsus, paradoxus. Yes. So to understand pulsus, paradoxus, we want to first review the physiology of respiration. We want to first know physiology of respiration. Then only you can understand pulsus, paradoxus. So we will start with the physiology of respiration. Okay, this is the physiology of respiration. We have to go step by step. That's all. Fill in the blanks. Medicine may just fill in the blanks. So physiology of respiration. Let us. So respiration, what happens? Especially we want to know during inspiration. Especially during inspiration, what happens? So during inspiration, what happens? There is a negative intrathoracic pressure. Okay, so basically during the inspiration, diaphragm moves down. Write it properly. During inspiration, diaphragm moves down, leading to negative intrathoracic pressure. There is a negative intrathoracic pressure, and that is essential for the lungs to expand. There is a negative suction in the thorax. There is a negative suction in the thorax so that the lungs can expand. Remember. So during inspiration, diaphragm moves down and the thoracic cavity expands. Means the pressure becomes negative. Negative intrathoracic pressure will occur. Due to this negative intrathoracic pressure, what is going to happen? Lungs are inflated. This leads to inflation of the lungs. Write it properly, please. There is inflation of the lungs. Due to the negative thoracic pressure, there is inflation of the lungs. Due to inflation of the lungs, there is pooling of blood. There is going to be pooling of blood in the pulmonary circulation. There is pooling of blood in the pulmonary circulation. There is pooling of blood. Pooling of blood in the pulmonary circulation. If more blood remains in pulmonary circulation, okay, inflation causes increased pooling of blood in pulmonary circulation. That will reduce the venous return. To left side of the heart. It will reduce the venous return to left side of the heart. I hope you remember your anatomy. Pulmonary veins open into left atrium. Pulmonary veins open into left atrium. So the left side of the heart gets less blood during inspiration. When the lungs are expanded, the capillaries are open. Lungs are expanded, the capillaries are open. So more blood remains in the lung, because of which there is decreased venous return to left side of the heart, and that will cause reduced systolic blood pressure. Because we know blood pressure corresponds to left ventricular force. So what we expect during inspiration, we expect a small drop in the systolic blood pressure, that is physiological. We expect small drop in the physiological blood pressure, systolic blood pressure, that is physiological. Look at the other side. What is happening in the heart? The same negative intrathoracic pressure causes emptying, okay, causes emptying of the column of blood, emptying of the column of blood in the SVC, IVC into the right side of the heart, into the right side of the heart. Remember the physiology, please. Okay, so the left side gets less blood flow during inspiration, but during the same inspiration, right side gets extra blood. Right side gets extra blood. Now, this extra blood in the right side, this could have potentially pushed the interventricular septum into the left side of the heart. So, when the right side gets more blood, what is separating the two ventricle? Interventricular septum. It could have pushed into left side of the heart, but it is prevented. Does not happen. But it is prevented by the high LV pressure. It is prevented by the high LV pressure. So this shift normally does not occur in physiological condition. Please remember, this is the septum, left ventricle, right ventricle. Okay, I want you to start picturing like this. Okay, when you sit and imagine, your right hand is the right side of the heart, left hand is the left side of the heart. This is the interventricular septum. During inspiration, right side gets more blood flow. During inspiration, left gets less blood flow. So what can happen potentially? The septum can be pushed to the left. If the septum was pushed to the left, then the left ventricular filling will become more impaired. But in a normal person, it does not occur because left ventricle is a high pressure chamber. Okay, so remember, just because right ventricle gets little extra volume doesn't become the dawn and pushes the septum other side. The septum remains in the center. It is prevented by high left ventricular pressure. That is what is normally happening. Okay, so now keep this physiology on one page. Okay, keep this physiology on one page. Now let us understand the pulses paradoxes. Let us come to the problem. The problem is pulses paradoxes. The problem is pulses paradoxes. Okay, so there is pulses paradoxes. So what is this pulses paradoxes basically? So pulses paradoxes is basically drop in the systolic blood pressure by more than 10 millimeter on deep inspiration. Okay, so during inspiration, we have studied physiology. During inspiration, you are going to get IVS is interventricular septum. Okay, so what we have got here, there is decreased systolic blood pressure. So normally also there is fall in the blood pressure, but then the fall in the blood pressure is less than 10. But if there is fall of more than 10 millimeter systolic blood pressure, then we call it as pulses paradoxes. I will show you pulses paradoxes. So I want you to write the mechanisms and the causes. I want you to write the mechanism and the causes of pulses paradoxes. So we will never forget. We will write down the mechanism and the causes of pulses paradoxes. Mechanism and causes of pulses paradoxes. We will see here. Okay. So pulses paradoxes is defined as drop in the systolic blood pressure by more than 10 millimeter on deep inspiration. Okay, let's go on one page back to the physiology. Let me go one page back to the physiology of respiration. So normal person also, the blood pressure decreases during inspiration. Blood pressure decreases. But normally the drop in the systolic blood pressure is less than 10 millimeter of mercury. So normally also it is less than 10 millimeter. It drops, but the drop is less. The drop is less. But in pulses paradoxes, the drop is more than 10 millimeter. So let us write it here. Pulses paradoxes means the drop in systolic blood pressure is more than 10 millimeter. The drop in the blood pressure is more than 10 millimeter. Means basically there is double reduction in the systolic blood pressure. Write it with me, otherwise you won't understand. Write it with me, otherwise you won't understand. Please write it clearly. So pulses paradoxes means the fall in the blood pressure is more than normal. It has got more than normal. तो कैसे होगा? That means venous return to left side is further reduced. एक और red arrow आ गया. Venous return to left side is further reduced. Means क्या हो गया? Pooling of blood in the lung is more. Pooling of blood in the lung is more. And why should it be more? At number one mechanism. Number one mechanism. When there is not just inflation. Number one mechanism. There is hyperinflation of the lungs. So there is hyperinflation of the lungs. That is the first mechanism. So the first mechanism is hyperinflation of the lungs. If it was inflation, it is normal. But hyperinflation of the lungs can lead to pulses paradoxes. Can lead to pulses paradoxes. So match the number. First mechanism, hyperinflation of the lungs is the problem. So hyperinflation में नंबर वन कॉज क्या लिखोगे? सिवियर acute asthma. Severe acute asthma is the most common cause of pulses paradoxes. The severe acute asthma is the most common cause of pulses paradoxes, followed by severe advanced COPD. Severe or advanced COPD. Yes, emphysema. Chronic obstructive lung disease. Chronic obstructive lung disease. Very correct. So please remember, pulses paradoxes, most common cause is respiratory. Most common cause is respiratory. Okay. Come to the second mechanism. Second mechanism. So if it is not the lung, we want to focus on heart now. We want to focus on heart. Now please focus here. You will be able to catch the problem. So if it is not the lung, where else can be the problem? The septum is pushed. The IVS is pushed into left side. This is prevented by high LV pressure. Prevented by high LV pressure. But we know a condition. What is the condition? When there is equalization of the LV pressures. When there is equalization of the ventricular pressure. Mechanism number 2. COLD is chronic obstructive lung disease. Chronic obstructive lung disease. One and the same. They are one and the same. Okay. So second mechanism को देखो. Second mechanism क्या है? It is equalization of the ventricular pressure. Second mechanism is equalization of the ventricular pressures. अभी हमने पढ़ा, very good, equalization of ventricular pressure, excellent, cardiac tamponade. So the most common cardiac cause is tamponade. Most common cardiac cause is cardiac tamponade. It is the cardiac tamponade that is important to us. Okay, number one. But rare causes, 30% cases of constrictive pericarditis. 30% cases of constrictive pericarditis can also cause this problem. Okay, so in constrictive pericarditis, pulses, paradoxes can occur, but it occurs only in advanced disease and not common. Advanced disease, not common. Okay, third mechanism देखते. What is the third mechanism can be there? There is already impaired ventricular compliance. There is already impaired ventricular compliance. मतलब the filling was already low. There is impaired ventricular compliance. The filling was already low. And further reduction happened. So number 3 problem, the venous return was already low. Venous return was already low from before, and during inspiration the return became even less, which led to the drop in the systolic blood pressure. So write down third mechanism, already impaired ventricular compliance. There is impaired ventricular compliance is there. Number 3, and impaired ventricular compliance is there. Number 3, and what is the cause? Impaired ventricular compliance. Sorry, I should have written it here. So sorry, just write it here. Okay, just write this same cause down here along with the mechanism. So here we can say it is seen in 30% cases of constrictive pericarditis. Same line down. Constrictive pericarditis. It is seen in 30% cases of constrictive pericarditis and restrictive cardiomyopathy. So they can also cause the pulses, paradoxes, but only 30%. They can also cause pulses, paradoxes along with the mechanism. Same, cause is same, but just put it in a line below so that you can understand mechanism better. And number 4 are unknown mechanisms, which are rare causes, unknown mechanism. These are rare causes, which are for only MCQ. Superior vena cava obstruction. Tension pneumothorax, and massive pulmonary thromboembolism. We want to remember. Okay, very good. So what we have studied here, every step to learn the pathology and to understand the cause, we want to take the help of physiology. So once you know the physiology, okay, we know अरे वेंट्रिकुलर कंप्लायंस मसल में है प्रॉब्लम या फिलिंग में है, वो ध्यान दो, है ना. एप्सिक्सिमैब, आई थिंक यू नीड टू रिलैक्स, है ना. यू नीड टू टेक अंडरस्टैंड and put your doubts together. I'll answer you in the end, so because you are confusing the everybody, just stay calm. So what we have got here, simple steps we put in. So each level of physiology, if it goes wrong, we can have these problem. Yeah, so we have got the respiratory causes, cardiac causes, and rare unknown causes. Rare unknown causes which we cannot explain. Which we cannot explain. Okay. Superior vena cava obstruction, tension pneumothorax, and massive pulmonary thromboembolism. Okay, that we cannot explain. Unknown causes, we will keep it as pulmonary thromboembolism, PTE. It's the pulmonary thromboembolism. Okay, so we have got here, summarize in the physiology, you see it once. In the physiology, just to take it once, during inspiration, normally the drop in pressure is less than 10. The drop in pressure is more than 10 because venous return to left side is less than normal. It is less than normal because either there is increased pooling in pulmonary circulation, which is increased because there is, number one, hyperinflation of the lung. Number two, it can be in cardiac tamponade. When the pressure becomes equal, then high LV pressure is not there. So the IVS can be pushed into left side of the heart, which can reduce venous return to left side of the heart, which can lead to pulsus paradoxus. And finally, impaired compliance. Already ventricle was getting less return. During inspiration, it has become more worse, leading to pulsus paradoxus. And number 4 is the unknown mechanism. Number 4 is the unknown mechanism. Yeah. So constrictive pericarditis, write it only in the third box. Okay, not in the second. I have rubbed it, no. So only in the third point you will write. Along with the third mechanism, you will write it. Okay, this is the clear picture. I have not left anything to the idea. It's very, very simple. Now, what is the next sign? Kussmaul sign. We have got the Kussmaul sign. So, pulsus paradoxus, follow it up with Kussmaul sign. So, follow it up with the Kussmaul sign. We have got Kussmaul sign. Okay, so we have got here, there is the Kussmaul sign. What is Kussmaul sign? There is either, there is absence of fall in the JVP or paradoxical increase in the JVP. Absence of fall in the JVP or paradoxical rise in the JVP during inspiration. On inspiration, easy to understand, on inspiration. So we have said here that there is during inspiration, the right side column of blood in the superior vena cava will be sucked into right side of the heart. So we will draw this illustration here during inspiration. So during the inspiration, the column of blood from the IVC is sucked into the right atrium. Is sucked into the right atrium. That's what is going to happen. But what is happening in Kussmaul sign? There is no drop in the JVP or paradoxical increase. Because what is normal? 1 to 2 centimeter drop in the JVP occurs on inspiration is normal. 1 to 2 centimeter drop occurs because the column of blood empties into the right atrium. Empties into the right atrium. Empties into the right atrium. But when does this emptying does not occur? Very simple. So when does this the emptying does not occur? When the RA pressure is higher than normal. When the RA pressure is high, it cannot accept. When the RA pressure is high, it cannot accept the extra blood during inspiration. It cannot receive the extra blood during inspiration. And we have already written RA pressure is high means the causes are same as same as of giant A wave on the JVP. Causes are same as giant A wave on the JVP. Okay, so keep it simple here. So Kussmaul's sign is absence of the drop in the JVP which normally occurs during inspiration. It can also happen that there is paradoxical increase in the JVP on inspiration. So what does it tell you? Why does the column of blood not enter the right atrium during inspiration? Because right atrium is already full. Why is right atrium already full? Right atrial pressure is higher than normal. That means the A wave is giant. Remember this. What will be the causes of Kussmaul sign also? There will be tricuspid stenosis. Tricuspid stenosis. Number 2, it can occur prominent in constrictive pericarditis. Constrictive pericarditis or restrictive cardiomyopathy. Restrictive cardiomyopathy. It is very rare in tamponade. For MCQ, remember it is absent only. It is very rare in tamponade, and it can be seen in patients with pulmonary arterial hypertension. It can be seen in the pulmonary arterial hypertension. Okay, so already described during inspiration, we have written in physiology that the column of blood will enter into right atrium. Will enter into right atrium means that column will become less during inspiration. But here there is nothing less, rather it remains the same or it worsens. Okay, that is why this is called as Kussmaul's sign. Okay, this is called as the Kussmaul's sign. Okay, till here this is called as the Kussmaul's sign. Okay, let us take it forward. So these two signs, let us put in our pericardial disease. Let us put in our pericardial disorder. Page kholiye, pericardial disorder. Come on, keep comparing. Pericardial disorder. Tell me how to remember. In pulsus paradoxus is common and prominent in cardiac tamponade, while Kussmaul's sign is very rare or absent. In constrictive pericarditis, the pulsus paradoxus is rare only in 30%, and Kussmaul's sign is common. Kussmaul's sign is common. Okay, you don't have to remember why rare in tamponade. It is a complex mechanism. The pericardial effusion can compress the vena cava route also. It is not important for you to remember because it's just an MCQ question. Remember the permutation. Pulsus paradoxus present, Kussmaul's sign absent means tamponade. Both are present. Think of constrictive pericarditis. Think of constrictive pericarditis. That's what we have written, right? So next we come to auscultation. Auscultation of heart sounds and murmur. In cardiac tamponade, we have already written heart sounds are muffled. Let us see what we get in constrictive pericarditis. Okay, so we want to study auscultation of heart sounds. Let me take you back to the column. So in the assessment methods, of cardiovascular examination, I hope we are all understanding. We have studied the topic of pulsus paradoxus. We know the causes with mechanism. We also know Kussmaul's sign, causes and mechanism. We know. So we finally come to auscultation. So auscultation of heart sounds and murmurs. We come to the topic auscultation of heart sounds and murmurs. We want to study. Come to the topic of auscultation of heart sounds and murmurs. Okay, everybody with me? Auscultation of heart sounds and murmurs. We have come here. Okay, so we are at 7:35. ठीक है, चलो ले लेते हैं थोड़ा सा ब्रेक. So before we start auscultation थोड़ा ले लेंगे. Okay, 20-minute break. So till 8 o'clock. So class will continue from 8 to 10:30. Okay, class will continue till 8 to 10:30. Is that okay? Okay, so break is important not because of anything else, because these topics are very heavy. These topics are not commonly discussed. Okay, so that's why the problem. We can take a small break if you want. Okay, we'll take a 10-minute break. We'll take a 10-minute break. So we'll save some time. So we will come back here. Thoda 10-minute break, refresh quickly. Okay, and we can come back. So we'll start at 7:50 and we will end at 10:20. चलो 10 minute concession. चलो run. Okay. So this session we are going to start with the auscultation of heart sounds and cardiac murmurs. We want to complete heart sounds and cardiac murmurs. We want to talk about echocardiography and complete our pericardial disease. Okay. So just we'll go through this. So there is heart sound, auscultation and auscultation of murmurs. That is the first point of this session. Okay, right. So we want to start with auscultation of heart sounds and murmurs in this session, and then we will go on to echocardiography and we will complete pericardial disease. So we have the fixed menu. See, I'm just taking 2 2 hour sessions so that we can concentrate and we don't get stressed, because in online, yes, I understand it's not like a live atmosphere. So we'll continue one by one, we'll keep understanding our points, right? So we come to the topic of heart sounds. So we want to understand broadly what are these heart sounds and what is cardiac murmur. So this topic we want to start with the auscultation. So now let's just look at the summary here. Let us look at the summary here, right? So patient came to your clinic in the morning. Okay, patient had either symptom of angina, breathlessness and or palpitation. So you suspected cardiovascular disease. In all patients with suspected cardiovascular disease, you perform detailed clinical examination. So you first checked the arterial pulse, one in the periphery, one in the carotid. You also checked for JVP waveforms. You checked for pulsus paradoxus and Kussmaul sign. Now you will pick up your stethoscope and auscultate the cardiac area for heart sounds and murmurs. You are going to start for heart sounds and murmurs. So let's understand what they are first. So heart sounds are typically sounds produced due to. They are the sounds produced due to the opening or closing of the valves. Due to opening or closing of the valves. Okay, so again this basis of this definition is historical, because in modern medicine auscultation has become just a formality, because we rely on echocardiography report than our clinical skill. But we must try to know what is historical so that we can use it in select resource limited situation. So heart sounds produced due to opening or closing of the valves, and that is why more commonly they are physiological, because opening and closing of the valves are typical, common in all of them. They are typical in all of them. But when you compare it to murmurs are produced due to, they are the sounds produced due to turbulent flow across the diseased structure. Turbulent flow across the diseased structure. And hence more commonly they are pathological. So when we auscultate, first we auscultate for the heart sound, then we auscultate for the cardiac murmur also, on a cardiac murmur also, which is more likely to be pathological. Clear till here? Now, when we want to auscultation, we want to first start with the areas of auscultation. The areas of auscultation typically basically correlate with the anatomy, surface anatomy of the valves. They correlate with the surface anatomy of the valves. Okay, so when we pick up the stethoscope, we must know where to place the stethoscope to auscultate for the heart sounds and the murmurs. So we have typically designated cardiac areas of auscultation, which are nothing but the surface anatomy of the underlying valve. So you can draw it with me, please, right? So we have got the sternum. Everybody, you draw it with me, please. So we have got the sternum. We have got the clavicle on both sides. So we will draw intercostal space. This is just an illustration. Don't look for accuracy here. Second intercostal space, third intercostal space, fourth intercostal space, fifth intercostal space. Okay, just for a pictorial representation of the auscultation areas, we are drawing this picture. So this is the sternum, this is the clavicle. So we are looking at the different intercostal spaces. So quickly make this picture with me. So we are looking at this picture with me, the clavicle, the sternum and the intercostal spaces. One by one we want to just draw for illustration purpose. So surface anatomy of the valve. So which are the areas, you can write it down. So this is area number: first intercostal space, second intercostal space, third intercostal space, fourth intercostal space and fifth intercostal space on left and the right side. So the most famous, the first area of auscultation, you start with the mitral area. We start our auscultation with the mitral area. I think all of you know mitral area is present in the left fifth intercostal space in the mid clavicular line. It is present in the left fifth intercostal space in the mid clavicular line. You are going to first auscultate in mitral area. Second, where is tricuspid area? Tricuspid area is in the fourth intercostal space. Fourth intercostal space, left side, parasternal area. Left side, parasternal area. The aortic area, right second intercostal space. Left second is the pulmonary area. Is the pulmonary area. So these are the conventional, what we call them, classical areas of cardiac auscultation. But with echocardiography, we have special areas. Special areas. Special areas. Number one, first intercostal space is called as the Gibson's area, where you can hear the murmur of patent ductus arteriosus best. That is why the PDA murmur is also called as Gibson's murmur. PDA murmur is also called as Gibson's murmur. That is the Gibson's area of auscultation. And we have got the third intercostal space on the left side, which is called as the Erb's or the neo-aortic area. Neo-aortic area to auscultate for the neo-aortic area, right? So these are the areas of auscultation. So when the patient has come to me with suspected disease, after examining the pulse, the JVP, pulsus paradoxus and Kussmaul sign, I am going to auscultate in these areas for the presence of heart sounds and murmurs. Okay, the heart sounds and murmurs I am going to auscultate for. So now with this background, let us start with the auscultation of heart sound first. Auscultation of heart sound and then go on to the cardiac murmurs. Ready everybody? Chalo. Heart sound we will start with. So whether it is heart sound or the murmur, we want to understand the various different heart sounds and their relation to the cardiac cycle. And their relation to the cardiac cycle is essential for us to know. This is the MCQ questions that we get. So heart sounds and relation to the cardiac cycle has to be known. Okay, these are the cycles we want to know. So heart sound and relation to cardiac cycle. Relation to cardiac cycle. Sorry. Come too much. Yeah. So we want to understand here the heart sounds and relation to cardiac cycle. Heart sounds and relation to cardiac cycle. For that we want to first draw the cardiac cycle. So I want all of you to draw this with me. I am going to draw it side by side. You can draw it whichever way you want to fit it in your book. Okay. So cardiac cycle first. Cardiac cycle, we will make two semicircles, one small semicircle, one large semicircle to denote the systole and the diastole. The systole is 0.3 seconds, the diastole is 0.5 seconds. So cardiac cycle, draw with me. Cardiac cycle, draw with me. So cardiac cycle consists of the systole and the diastole. The systole is smaller, 0.3 second. Diastole is larger, 0.5 seconds. Divide the systole into three equal parts. Divide the systole into three equal parts. Divide the diastole into 5 equal parts. Divide the diastole into 5 equal parts. Everybody, can we hear it very clearly? So in the cardiac cycle, we have got the systole and the diastole. Systole and the diastole. So we will divide them into parts of 0.1 second duration. So there will be total 8 equal parts of 0.1 second duration. Okay. Now, what are the sounds? How many heart sounds do you know? Typically, an MBBS graduate has heard about S1, S2, S3 and S4. So for majority of us at MBBS level, we know that there are 4 heart sounds. But for MCQ, we want to learn 4 more. That means total we want to learn about 8 heart sounds. Total we want to learn about 8 heart sounds. Let us start from the basic. So please remember in the previous session how we did. On the first page we enumerated the characters of the pulse, and in the subsequent pages we discussed about each character. Same way, here we are going to illustrate each heart sound and relation to cardiac cycle, but we are going to write in the subsequent pages. So today we are going to read about 8 heart sounds. Let's go there. So starting with the first most basic heart sound that all of us are familiar with. Draw a bold rectangle. Draw the first most prominent heart sound. Most prominent heart sound, that is S1. the most prominent heart sound, that is S1. So it is shown as a single bold line. Okay, so this is our S1. This is our S1. Okay, so we have written in the previous session, please try to recall, previous session I told you S1 marks the onset of ventricular systole. It begins, and what is ending? S2. S2 is always depicted as a split sound. S2 is depicted as a split sound, which marks the onset of ventricular diastole. Okay, ventricular diastole. So this is the broad concept here, which all of us know. So broad concept we are familiar, S1 and S2. Okay, let us write about them. So I'm going to keep this page empty to write about the miscellaneous and illustration. You can start writing on the next page about S1, S2 and so on. Okay, so first we will start with S1. Let us start with S1. Okay, S1. Let us begin with. So what is this S1? Yes, without auscultation. I know examination in MBBS is just random. For cardiovascular system, we just write S1, S2 normal, no murmur, and it's done. Okay, so but we want to learn a little more about the heart sound. It's very interesting. So what is S1? S1 is the sound. It is the high pitched sound. S1 is the high pitched sound which is produced due to the closure of the atrioventricular valves, that is mitral and the tricuspid valve. That is the mitral and the tricuspid valve. Okay, so what we have got here, high pitched sound produced due to closure of atrioventricular valves, that is mitral and tricuspid valve. What are the points here? The S1 marks the onset of ventricular systole. And what does it correspond to? When you auscultate for the S1, how do you identify S1? You have to palpate the carotid impulse. So the S1 is the sound which corresponds to the carotid pulse. It corresponds to the carotid pulse. So these are the salient features here. So high pitched sound produced due to closure of atrioventricular valves, that is mitral and tricuspid valve. It marks the onset of ventricular systole and corresponds to the carotid pulse. What we must focus on? Focus on its intensity. After identifying the S1, we focus on the intensity of the sound. Why? Because the questions are like that. You have to answer what are the causes of loud S1 and what are the causes of soft S1. You are supposed to answer. So when we auscultate S1, the first step is to identify it correctly. If you mix S1, S2, already game over. After identifying S1 properly, you will focus on the intensity of the S1. Because the causes are based on whether the S1 is loud or soft. So what are the causes of loud S1? Loud S1 can be seen in which all conditions? Very good. Mitral stenosis definitely is a front runner. But I want you to understand this story. Okay, each heart sound comes with a story that I want you to relate to. So let's visualize. Come on, let's visualize. Mitral valve has got two leaflets. Everybody, loudly. Mitral valve has got two leaflets. So compare the mitral valve leaflet to a door. To a door. दरवाजे के दो हिस्से होते हैं. Compare it with the door. And if you know old time movies, old time government offices, police station, what kind of door they have? Half door. You call that as saloon door. Saloon में कैसे होता है? Half door होता है. It is only the plank of wood is there in between and it is automatic. You open and it will automatically close. So you compare this door to the S1, to the leaflet of the S1. So when you open the door forcefully, open the door with force, more is the distance traveled from the center, louder will be the closure. Louder will be the closure. So that is what occurs in hyperdynamic states. That is what occurs in the hyperdynamic states. There is forceful opening, and that is why the closure is also loud. Classical example, as you already told me, mitral stenosis. And number 3, when you auscultate a person with lean, thin chest wall. When you auscultate a patient with lean, thin chest wall, you will get loud S1. Soft S1, just have to make it opposite. You will see it in hypovolumic states. You will see it in mitral regurgitation. And when you auscultate a patient with obese chest wall. Auscultate a patient with obese chest wall. You can remember, right? And number 4, we must also add the pericardial effusion. When there is a pericardial effusion, the conduction of the sound becomes muffled. And we have written muffled sound where? In cardiac tamponade. In the cardiac tamponade, we have written it. Okay. So what we have got? S1. S1 is the most prominent sound that you hear on auscultation. To identify S1, you match it with the carotid pulse. If it is loud, it can be just that the person is thin or hyperdynamic or mitral stenosis. But if it is soft, it could be hypovolemia, mitral regurgitation, obese chest wall, or conduction defect due to presence of pericardial effusion or cardiac tamponade can be present. Cardiac tamponade can be present. Right? So this is about S1. Come to S2. Come to the S2. After the S1, let us come to the S2. These are the two common sounds which most of us know. What is S2 described as again? High pitched sound. It is again as high pitched sound. High pitched sound which is produced due to the closure of the semi-lunar valves. Due to closure of the semi-lunar valves, that is aortic and pulmonary valves. Aortic and pulmonary valves, and that is why it has got two components, A2 and P2. It has got two components, that is got A2 and P2. So high pitched sound produced due to closure of the semi-lunar valves, that is aortic and pulmonary valves, that is A2 and P2 components are present in the S2. It is present in the S2. Okay. Okay, before I continue, lot of students are asking the doubt why the sound S1 is loud in mitral stenosis. उसको complete कर देते हैं. So please remember, in mitral stenosis, no, it is not the force. In mitral stenosis, imagine there are two doors. You open it forcefully, they go and come back faster. One, that is hyperdynamic steam. In mitral stenosis, the valve area, the door has become narrow. So to allow maximum blood to flow, the leaflet is stretched to the limit. So not just this much and here, it is stretched to the limit and remains there for longer to allow more blood to flow. So when it comes back, the rebound velocity is more, and that is why you get loud S1 in mitral stenosis. You get a loud S1 in the mitral stenosis. Okay, moving forward. So S2 is a high pitched sound produced due to closure of semi-lunar valves. What does it do? It marks the onset of ventricular diastole. Marks the onset of ventricular diastole. And what it does corresponds to what we discussed in the previous session, corresponds to the dicrotic notch of the cardiac impulse. Corresponds to the dicrotic notch. Corresponds to the dicrotic notch. Okay, so everyone we must correlate with the same timed sounds or the same time events so that you can identify the disease. So in the patient with S2, here the focus is not on the intensity but focus is on the split. Focus is on the split. Correct, no? So in S1, we want to focus on the intensity of the heart sound. In S2, you want to focus upon the split of the S2. Want to focus upon the split of the S2. So how do we see this? Focus on the split of the S2. Draw it with me. So how to identify? On auscultation. On auscultation findings, based on the auscultation findings, you can identify whether the patient is having a physiological split. You can identify whether the patient is having a physiological split. The physiological split is denoted as A2-P2. It is denoted as A2-P2. We are going to denote it as A2-P2. So based on the auscultation finding, we want to know about the splitting of the heart sounds. So there can be physiological splitting. The pathological splitting can be further divided into two. One, there can be wide split. Where the A2 component remains first, followed by arrow or P2. Widened split. Or there could be reversed or paradoxical split. Where the P2 comes first, followed by the A2. P2 comes first, followed by the A2. So auscultation finding for S2, we are focusing on the split of the second heart sound. We want to look for. So to identify the split, what we are doing? We are trying to understand auscultation finding. So auscultation finding, we want to auscultate during quiet breathing. We want to auscultate the patient during quiet breathing. And you want to auscultate again during deep inspiration. You want to auscultate again during deep inspiration. So try to remember the physiology of inspiration. Remember the physiology of inspiration. What did we say? During inspiration, right side gets more blood. So what happens? The pulmonary component will be delayed. More blood is there to pump. Left ventricle gets less blood. So that is why A2 comes early and P2 comes late. That is physiology. Based on the physiology, we can derive this point. Based on the physiology, we can derive this point. That auscultation finding, okay, split means separate two sounds you can hear, okay. So during quiet breathing and during deep inspiration, you will auscultate. Based on the physiology that we studied, A2 will be early because left side gets less blood flow. P2 will be late because right side gets more blood flow, more blood flow. So we say that physiological split. During quiet breathing, there is no audible split. During quiet breathing, there should be no audible split. There should be no audible split. It is only during deep inspiration that the split may be audible. The split may be audible because the increase in the distance between the two. So between A2 and P2, the distance increases. So you may be able to auscultate only on deep inspiration, only on the deep inspiration. That is physiology. Wide split and this. When the split is audible, it is abnormal. If the split is audible on quiet breathing, it is abnormal. Now you want to know whether it is wide split or it is paradoxical split. Why if the split is audible, it is abnormal. You want to know whether it is wide split or paradoxical split. So how do we know? In wide split, during inspiration, A2 will be early here, P2 will be late. So the split becomes more prominent. The split is already audible and it becomes more prominent on inspiration. You can say it is a wide split. You can say it is a wide split. But in paradoxical split, A2 comes early, P2 comes late. They merge into one. The split may disappear. The split may disappear. And that is opposite of normal. That is opposite of normal. Okay. So this is the identification of S2 splitting we want to know. Identification of S2 splitting we want to know. Once we identify, you can write down the causes. You can write down the causes of the abnormal splitting. Causes of the abnormal splitting. You can write down causes of abnormal splitting. The causes, remember always, the cause is typically the defect is always in the delayed component. The defect is always in the delayed component. Please remember, defect is always in the delayed component. That is the very important clue for exam. Means in the wide split, defect is in P2. In the paradoxical split, defect is in the A2. Remember the dictum. Okay. So in case of wide split, the problem is in the P2. In paradoxical split, the defect is in the A2. Just remember like this. Okay. So now let's know the story. How does it work? What is the story of S2? So let us imagine, again, go back to the previous session I told you, to help understanding. We will visualize right ventricle, right hand, left ventricle, left hand. So right ventricle, less muscular, left ventricle, more muscular. So suppose both are pumping the same heartbeat. The stroke volume will be same in the same beat. Suppose right pumps 90 ml, left will also pump 90 ml in the same beat. So the patient has got a parallel. So stroke volume is the same. So suppose, imagine right and left ventricle are running a race. Okay, running a race. Both of them are pumping same quantity, means both are running same distance. Number two, the impulse of the right ventricle, starting whistle, comes from right bundle branch. Left ventricle gets impulse from left bundle branch. In physiology, we learn that both the ventricles depolarize simultaneously. So when they are running a race, the race is of same distance and both of them hear the starting whistle at the same time. They start running. Once they start running, there is the road, there is the track. Right ventricular outflow tract, pulmonary artery. Left ventricular outflow tract, arch of aorta is there. That should be clean. The track should be normal. And finally, the resistance, means the load that they are carrying, should be also proportional. Load that they carry should be proportional. Right ventricle pumps against pulmonary artery pressure. Left ventricle pumps against systemic vascular resistance, which is higher. Right? So what we want to know here? So here we will see that defect in a wide split, where the problem is in the P2, pulmonary component is losing the race. In a normal person, both of them, right ventricle, left ventricle, finish the race at the same time, almost the same time, that you cannot hear the split, you cannot make out. But when the split is audible, that means there is a clear winner and the second fellow is the loser. Loser means site of defect. Okay, loser is site of defect. So wide split में loser है pulmonary component. Pulmonary component means right ventricle. Right ventricle race क्यों हार गया? Why should he lose? Because right ventricle did not hear the whistle. Right bundle branch is blocked. Right ventricle did not hear the whistle because right bundle branch is blocked. So left started running early. That's why finished the race early and right could not reach in time. Or number two, there is pulmonary hypertension. The right was forced to carry extra load. The right was forced to carry extra load. Or there is a right ventricular outflow tract obstruction. That is your pulmonary stenosis. So right ventricular outflow tract was obstructed. There is pulmonary stenosis. Or there was extra load, left to right shunt. In left to right shunts, classical example ASD and VSD, more blood has entered from left to the right side. So right side has got increased load, run extra distance to run. Left side has that much distance less to run. That is why the P2 gets delayed. P2 gets delayed. So just you have to think like this, that they are running a race. Right ventricle P2, left ventricle A2, running a race. In a normal person, both develop typically normal time they start, they have similar resistance and that is why they reach the finish line together. But if there is a loser, second is the loser, that is the site of the defect. So when you get a wide split, means right ventricle has lost the race because it started late, it was carrying more pressure, It was obstructed or it carried extra volume. That's all. It carried extra volume. Other side of the thing. Paradoxical split means left ventricle is the loser. Why should left ventricle lose the race? Because left bundle branch was blocked. Left bundle branch was blocked. There was severe systemic hypertension. There was LVOT obstruction. There was LVOT obstruction. And that is why there is a problem. LVOT obstruction can be classified into three. It can be aortic stenosis, HOCM, or coarctation. The causes of LVOT obstruction can be aortic stenosis, hypertrophic obstructive cardiomyopathy, and coarctation is the problem. Okay, so look at this chart. Very simple chart to help us in both clinical question and MCQ. Clinical question and MCQ. So when you talk about S2, you are to focus upon the presence of split. Normally, split should be absent. Split should be absent. But if the split is audible, that means it is abnormal. Then you have to understand whether it is wide split or paradoxical split, which will help you understand the probable cause of this finding. The cause of this finding. Right? Chalo. Let's go further. Back to the cardiac cycle. Let us go back to the cardiac cycle. Then we will take it here. Right? Let's go to the cardiac cycle. Pe chalte hain. So take it back to cardiac cycle. Then we will take more. So we now know what are the how normal about S1, S2, abnormalities about S1, S2. What is more? So let me take you one more page back to definition of heart sound. What is the definition of heart sound? The definition of heart sound says that heart sounds can be produced due to closing of the valve S1, S2. Closing is S1, S2. Also opening of the valve. So what are the sounds due to opening of the valves? What are the sounds due to opening of the valves? Let us write it here. Opening of the valves. Write it please with me. So here we said isovolumic contraction followed by aortic valve opening causes ejection click. Cardiac cycle, please recall, after isovolumic contraction, aortic valve opens. This is your ejection click. Write down about points. EC is the ejection click. So ejection click is the high pitched sound. Ejection click is the high pitched sound which occurs due to the aortic valve opening. Which occurs due to aortic valve opening. Occurs due to aortic valve opening. It is likely to be, may be physiological. It may be physiological, or it could be a sign of aortic stenosis. Or it could be a sign of aortic stenosis. It could be a sign of aortic stenosis. Okay, please remember. So normal person also can have ejection click, but in the presence of symptom, it can favor the diagnosis of aortic stenosis. On the other way, so cardiac cycle, please remember what are the components of cardiac cycle? Isovolumic contraction. There is isovolumic contraction, aortic valve open. There is rapid ejection phase. There is rapid ejection phase. There is delayed ejection phase. And there is the S2. In the diastole, what we must know here also, isovolumic relaxation. Isovolumic relaxation followed by early filling. 0.2 second is the early filling. Early filling. There is the state of diastasis followed by the late filling phase or the atrial kick. Late filling phase or the atrial kick, we want to know. Okay, atrial kick or the late filling phase. So after the isovolumic relaxation, which valve will open? Mitral valve opening produces opening snap. So second, we have got opening snap. We have got here opening snap. Again, what is opening snap? High pitched sound due to mitral valve opening. It is high pitched sound due to mitral valve opening. High pitched sound due to mitral valve opening. That's what we have got here. Okay, so why? Your questions are all very bad in the way that you have never attended a clinic. Okay, you have never tried to auscultate, nor have you read about it. So what is my request? That today first you be with me. Okay, do not ask questions. Do not ask questions, because these questions are quite terrible. You listen, you copy. Today let it be monologue. Tomorrow when we come to the disease, no, let us try to correlate better. Okay, then what questions are there, I will definitely answer for you. Don't worry, it's not that I don't want to, but you are all very misplaced questions. Okay, you have to visit the ward, you have to auscultate, you have to read a clinical book, then understand. These are MCQ questions we are quickly making. So again, opening snap may be physiological, or it can be a sign of mitral stenosis. It can be a sign of mitral stenosis. E का मतलब है early filling, A का मतलब है late filling, diastole already studied today only. We have studied them today only. Try to correlate please, otherwise we will be in deep trouble. Next one, what we have got here, pericardial knock. Add one more, come on, pericardial knock. So pericardial knock, we have got here pericardial knock, which is again high pitched sound. Pericardial knock, which is a high pitched sound, where it is seen in constrictive pericarditis. Seen in constrictive pericarditis. Why? When there is the ventricle, when the dilated ventricle knocks on the thickened pericardium, then we call it as pericardial knock. So try to correlate. Dilated ventricle knocks on the thickened pericardium. So we have already studied the topic. What is constrictive pericarditis? In constrictive pericarditis, the pericardium becomes thick like a coconut shell, as the exaggerated early filling dilates the ventricle. What is there in constrictive pericarditis? Exaggerated early filling. As soon as the valve opens, the blood rushes into the ventricle. This dilated ventricle knocks on the thickened pericardium, which is why it is called as pericardial knock. Okay. Next sound we have got here is the tumor plop. Let us make one sound. We have got the tumor plop. So tumor plop is the only low pitched sound now. It is the low pitched sound. Tumor plop, low pitched sound, which is seen in the left atrial myxoma. It is a characteristic sound of the left atrial myxoma. So where is this left atrial myxoma? You can draw this interatrial septum. This is left atrium. This is mitral valve opening. This is the mitral valve opening. This is the left atrium. This is interatrial septum. Interatrial septum. So the tumor is how? Pedunculated tumor, which is floating in the LA cavity. Left atrial myxoma is typically a pedunculated tumor. Left atrial myxoma is a pedunculated tumor. It is a pedunculated tumor which is floating in the LA cavity. Which is floating in the LA cavity. Physiologically, when the blood flows across the mitral valve opening, physiology, the blood flows from atria to the ventricle. The tumor plops itself on the mitral valve opening. So during the blood flow across the mitral valve, the tumor plops itself on the mitral valve opening, producing the sound that is tumor plop. Producing the sound that is the tumor plop. Producing the sound that is the tumor plop. Okay, tumor plops on the mitral valve opening. It may be followed by this tumor plop on the mitral valve opening may be followed by a mid-diastolic murmur because it mimics mitral stenosis. So in a left atrial myxoma, the tumor plops itself and it obstructs the mitral valve opening. So it can cause a feeling of a mitral stenosis. So after the plop, there can also be mid-diastolic murmur. After the tumor plop, there can be mid-diastolic murmur which can be heard, and that is why left atrial myxoma is a differential for mitral stenosis. It can mimic mitral stenosis. Okay, so we have got the extra 4 sounds that I told you about. So apart from S1, S2, S3, S4, we have understood 4 new sounds here. Okay, IAS is interatrial septum. Interatrial septum. Just you have to keep this illustration for last day revision. Very important high yield question. Heart sounds we want to remember. So going back to S3 and S4, okay, let us write about it and then mark. Where is S3 and S4? Let us write and then do the reverse. So S1, S2 we already studied. What about S3 and S4? Let us write. Both are low pitched diastolic sounds. Both are low pitched sounds. S3 and S4 both are low pitched sounds. S3 and S4 both of them are produced due to the rapid flow. It is due to the rapid blood flow into the partially filled ventricles. Rapid blood flow into partially filled ventricles during, that's the difference. So S3 and S4 are both low pitched diastolic sounds. They are both low pitched diastolic sounds. Low pitched diastolic sounds which are produced due to rapid blood flow into partially filled ventricle during the early filling phase and the late filling phase. During the early filling phase and the late filling phase respectively. late filling phase respectively. That's what we want to know. Late filling phase respectively. Okay. So why are we getting confused? In ejection click, AV stands for aortic valve. In ejection click, AV stands for aortic valve. Okay, why it mimics left atrial myxoma, plonks itself on the mitral valve opening, causing obstruction of the mitral valve area. Obstruction of mitral valve area looks like mitral stenosis. Okay, problem can be in the valve or because of tumor. It looks like mitral valve stenosis. Okay, coming back, S3 and S4, S3 and S4, come on, due to early filling phase, late filling phase. So S3 we all know is more likely to be physiological, more commonly physiological, in young asymptomatic cases. In the young asymptomatic cases, because we know during the early filling normally also the blood flow is rapid, it is normal, but in elderly and symptomatic cases, it is considered a sign of heart failure. It is considered as a sign of heart failure. We can say that. In elderly and symptomatic patients, it is considered as a sign of heart failure. We must know. While we know a late phase normally is clinically insignificant. That is why presence of rapid flow during late filling is more commonly pathological, and it is considered a sign of heart failure. It is more commonly pathological and considered a sign of heart failure. Okay, so it's very important for you to understand the description of the heart sound. First, what is normal? Then what is the interpretation of the abnormalities in cardiac auscultation? Okay, simple here. So S3, S4. Now mark it on cardiac cycle. S3, S4. Mark it on cardiac cycle. Where does S3 and S4 fit in? In the cardiac cycle. Mark it here, please. So S3 comes here. There is S3 during the early filling, and during the late filling we can get S4. During the late filling we can get S4. Okay, so these are all our heart sounds and relation to the cardiac cycle. All the heart sounds and relation to the cardiac cycle. Okay, so again take you back here. So when you want to auscultate the patient, all of you please listen. Those questions that you had put, please listen carefully. When you auscultate, first you put the stethoscope on the mitral area. First you will put the stethoscope on the mitral area. In all the 4 areas, you are expected to auscultate for the heart sounds. Okay, in all the areas you have to auscultate for the heart sounds, but typically we focus on the mitral area findings. So in the mitral area, first you will identify S1, look for intensity. In the mitral area you will look for S2, look for the split. Then you will auscultate for the presence of other sounds. So in the presence of other sounds, if there is ejection click, maybe normal, maybe aortic stenosis. Opening snap can be normal, can be mitral stenosis. Pericardial knock is specific for constrictive pericarditis. Tumor plop is specific for left atrial myxoma. S3 more commonly physiological, S4 more commonly pathological. But in presence of symptoms of heart failure, both of them can be considered as signs of heart failure. They can be considered as signs of heart failure. We can consider them as. Okay. So this is how you auscultate for heart sounds. And this image relation to heart sound is extremely important to you. This is how questions are framed. Right? Chalo. Let us go further to cardiac murmur. So we have taken care of the heart sounds. It is time to deal with the cardiac murmur, right? So we have understood here what are the different heart sounds we have taken care of. Heart sounds. Now we have to focus on the cardiac murmurs. Ready everybody? We have to focus on the cardiac murmurs. Come on everybody, keep awake. These are all. See, today first day class of cardiology. I know that I get lot of dirty looks because of the simple reason that you have rarely examined a cardiovascular case in detail. That is why you find it difficult to understand. But all these clinical features are very important for practice as well as MCQ. So even though you can give me dirty looks, but don't miss the topics. Don't miss these points. They are very critical for our exam. So coming to auscultation of cardiac murmurs. So as we know, normally murmurs are not present. We get away by saying no murmur. We get away by saying no murmur, right? But if there is a murmur, what should we do? What are the characteristics of the murmur? What are the characteristics of the murmur that you are supposed to auscultate if it is present? Okay, we want to know. So cardiac murmurs are not common finding. Okay, cardiac murmurs are not common finding. But if present, we must know. We must know what characteristics we must say for and why should we do this for. Okay, so what to auscultate in the murmur and why to auscultate for that character in the murmur is equally important, right? So first one, what is most important is timing of the murmur. Timing means relation to cardiac cycle. Timing means relation to cardiac cycle is the most important character. Is the most important character. It is the most important character. The timing versus relation. It is the same. Relation to cardiac cycle. And that is why I have just drawn the cardiac cycle for you. Because you must learn to correlate. Okay, timing is the most important. After timing is the radiation of the murmur. Radiation of the murmur. If present, the intensity of the murmur. It is no longer important again because it is subjective and hence it is unreliable. So this is not much important right now. It is not much important right now. Number 4 is the relation to respiration. Is the relation to respiration. Based on our respiratory physiology, we know during inspiration, during expiration, which murmurs are better heard is the question. So based on the physiology of respiration, murmur depends upon the flow across diseased structure. During inspiration, right side gets more blood flow. That is why right-sided murmurs are better heard. During inspiration, right side gets more blood flow. And that is why right-sided murmurs are better heard during inspiration and left-sided murmurs are better heard during expiration. So now you understand all this is based on the physiology of inspiration. The answers of all these questions is based on physiology of inspiration, because during inspiration right side gets more blood flow. That is why you get right sided murmurs are better heard on inspiration. And finally, most difficult, but I will make it most simple, is the dynamic auscultation. Dynamic auscultation means relation to maneuvers. Dynamic auscultation means relation to maneuver of the murmur. Okay, so look at the points carefully. What are you supposed to do when you auscultate? Remember, when you auscultate, you have to auscultate ideally all four areas. So I'll tell you in case presentation how you are supposed to describe. In a case presentation, I expect the student to tell me that in the mitral area S1 is present and normal in intensity. S2 is present and no split is audible. There is no S3, no S4, no murmur. Same thing they have to repeat in all the areas ideally, but no examiner will force you. Mitral valve is the common area where we look for. Mitral area, we want to learn it like this, right? So we are going to look at them very clearly. After the heart sound, we will write about the murmur. Normally murmur is not there, but if murmur is present, likely to be pathological. Likely to be pathological, right? So we want to see, to identify the cause of the murmur. We want to look at timing of the murmur, radiation of the murmur, intensity of the murmur, relation to respiration, and dynamic auscultation. This we want to see, right? So this is what we want to see. So let us take it up one by one. Intensity ko chhod do, because that is subjective, not very important. Relation to respiration already you have written down. Relation to respiration you have already written down. So let us discuss the other points. So first start with timing, relation to cardiac cycle. So based on relation to the cardiac cycle, based on the timing. So next page, based on the timing. How many types of murmur are present? Can you help me with that? Come on. I will keep the cardiac cycle in front of you. Okay. I will keep the cardiac murmur cycle in front of you based on the timing of the murmur. Based on the timing of the murmur. On a timing of the murmur. What are the different types of murmur? एक बार देखिए ध्यान से. Okay, please look at it carefully. When you auscultate and you hear a murmur, what will you first see? Whether the murmur is heard between S1 and S2. If the murmur is heard between S1 and S2, what we call them? Murmur is heard between S1 and S2. We call them systolic murmur. When it is heard between S2 to S1, then we call them as diastolic murmur. And when it is heard throughout the cardiac cycle, then we call it as continuous murmur. Very good. So we are going to be three types of murmur. We will first classify based on the timing. We will first classify the murmur into three types of murmurs. There are the three types of murmurs based on the timing. So number one, we will write it here. There is the systolic murmurs. So we can say there are the systolic murmurs. We will leave a small column here for the phase affected. There is diastolic murmurs. Diastolic murmurs. And we have got the continuous murmurs. And we have got the continuous murmurs. So based on the timing of the murmur, timing means relation to the cardiac cycle, we will divide the murmurs into three types. है ना, pan, mid, sub ये सब type है, not the main type. So we will divide them broadly into systolic murmur, diastolic murmur and continuous murmur. We will divide them. पहले continuous को divide कर देते. Continuous murmur based on the following. Based on the site heard, divided further into types. Based on the site, continuous murmur heard over the precordium. Continuous murmurs heard over the precordium include patent ductus arteriosus, aortopulmonary window, and ruptured sinus of Valsalva. And the ruptured sinus of Valsalva. So there is patent ductus arteriosus, aortopulmonary window, and ruptured sinus of Valsalva. Patent ductus arteriosus, aortopulmonary window, and ruptured sinus of Valsalva. So continuous murmur MCQ, continuous murmur MCQ based on the site where it is heard. If you get a continuous murmur over the chest wall, precordium, the differential diagnoses are patent ductus arteriosus, aortopulmonary window, and ruptured sinus of Valsalva. Number B, when you hear continuous murmur over the lesion, it includes AV fistula, arteriovenous fistula, and vascular tumors. Vascular tumors, example, hemangioma and hepatoma. Hemangioma and the hepatoma. इसको out कर देते हैं. So based on the site where they are heard, we can call this as arteriovenous fistula, vascular tumors, example, hemangioma, hepatoma. And number C, the only venous cause of continuous murmur, MCQ, the only venous cause of continuous murmur is the mammary scuffle, which occurs due to breast engorgement, seen in pregnancy or lactation. So for MCQ, we will take it like this. For the MCQ, we will take it like that. So continuous murmur, you must remember at least 7 of them, 7 examples. PDA, aortopulmonary window, ruptured sinus of Valsalva, AV fistula, hemangioma, hepatoma, and mammary scuffle. So this is the way to answer your questions. Okay. Other side, within the systolic and diastolic, we will divide into early systolic, early diastolic. Early systolic murmur is uncommon because याद करिए early systole में क्या होता है? Early systole में होता है isovolumic contraction. ब्लड फ्लो ही नहीं हुआ तो मर्मर कहां से आएगा? बट रेयर स्पेसिफिक कॉज है हमारा acute mitral regurgitation, small VSD. Acute mitral regurgitation and the small ventricular septal defect. So early systolic murmurs are not common. Early systolic murmurs are not common, but they can be seen in acute mitral regurgitation. How it happens, we will discuss. I have put a star. Tomorrow when we discuss the topic of MR, we will come to know. Early diastolic murmurs include aortic regurgitation, pulmonary regurgitation. Aortic regurgitation, pulmonary regurgitation, right? Then there is mid-systolic, which is the most common on both sides. Most common phase affected is mid-systolic, mid-diastolic. So this is called as ejection systolic murmurs. Mid-systolic is also called as ejection systolic murmur. This is your MDM, mid-diastolic murmurs. Mid-diastolic murmurs, right? So ejection systolic murmur क्यों होता है? तो सोच के देखिए, रैपिड इजेक्शन के टाइम maximum blood flows into the aorta and pulmonary tree. So obstruction, LVOT obstruction, RVOT obstruction. LVOT obstruction, RVOT obstruction is the cause of mid-systolic murmur. Is the cause of mid-systolic murmur. While mid-diastolic murmur, mitral stenosis, tricuspid stenosis, left atrial myxoma. Already we know. Mitral stenosis, tricuspid stenosis, left atrial myxoma. Left atrial myxoma. Then there is the late systolic, late diastolic murmur. Only one answer. Mitral valve prolapse. Only one answer. Mitral valve prolapse. Tomorrow we will discuss MVP. Tomorrow we will discuss MVP, mitral valve prolapse. So here we have got getting only mitral valve prolapse, right? In the diastolic, late diastolic as well as mid diastolic, extending on both sides, is the Carey-Coombs murmur. Is the Carey-Coombs murmur. Carey-Coombs murmur is seen in acute rheumatic fever due to mitral valvulitis. Due to mitral valvulitis, Carey-Coombs murmur. It is mid-diastolic also and late diastolic also. Can extend into late diastole. Can extend into late diastole. We want to know. Extend into late diastole. Okay. So we must know, based on the physiology, flow across diseased structure. Flow across the diseased structure. Acute rheumatic fever. Acute rheumatic fever due to mitral valvulitis. And finally, we have got only one type, that is the pan-systolic murmurs. There is no pan-diastolic. There is pan-systolic murmur. Pan-systolic murmur can be seen in chronic MR. Can be seen in chronic MR, chronic tricuspid regurgitation and large ventricular septal defect. Large ventricular septal defect. Okay, come on. So let us look at this carefully. So when we look at the murmurs, the most important character which helps identify the probable cause of the murmur, है ना, ये difficult नहीं लगेगा. Once you are able to orient yourself to what is the objective of hearing the murmur. When you get a murmur, the question you have to answer is, what is the cause of the murmur, what is the differential diagnosis, है ना? This is in front of you. So if you get a murmur, आप क्या करोगे? टाइम करोगे. पहले देखोगे whether the murmur is systolic, diastolic or continuous. If it is continuous murmur, you will see whether it is heard over the precordium or over the lesion itself, or the patient is pregnant. If the patient has systolic or diastolic murmur, you will divide further that which part of the systole or diastole is affected. Is it early, mid, late or pansystolic? Once we know that, we will be able to understand the probable cause of the murmur. Acute rheumatic fever, we will be able to understand the probable cause of the murmur. So if you look at this table, what we have seen here, that every box may have one or two differentials. But the common confusion, if you look at it carefully, is between the left side and the right side murmurs. The common confusion is between left side, right side, left side, right side, left side, right side murmur, left side, right side murmur. So to differentiate that only, we have already written character, relation to respiration. We have written the character, relation to respiration. So if I say, for example, patient has got early diastolic murmur, which is best heard on expiration. पूरा murmur सुनिए. Early diastolic murmur, best heard on expiration, मतलब aortic regurg. Best heard on inspiration, मतलब pulmonary regurgitation. So we have to add the character together to reach the final diagnosis. Okay, add the character together to reach the final diagnosis. But उसके बाद भी कुछ बच जाते है ना? Even after doing that, you will have few differentials left, and that is where you come to the concept of radiation of the murmur. Okay, I'll extend this column, radiation of the murmur, because all these causes, let me say further, pansystolic murmur, which is best heard on expiration. Pansystolic murmur, which is best heard on expiration. ऐसे बोलते, what is out? Best heard on expiration means it is not TR. If I say best heard on expiration, it is left-sided murmur. But left-sided murmur में दोनों हो सकता है. It can be chronic MR versus large VSD. Here we take the help of radiation of the murmur. Chronic MR murmur radiates to the axilla. Chronic MR murmur radiates to the axilla, while VSD murmur radiates to the apex. Radiates to the apex. Radiates to the apex. That's how we want to remember. So first we have to look at timing of the murmur. After the timing, you will fine tune with the inspiration, expiration, right sided, left sided murmur. And even after that, if there is a differential, you will look for radiation of the murmur. You will look for radiation of the murmur. Another example I'll give you of radiation. If you get ejection systolic murmur, which is best heard on expiration. Another example, ejection systolic murmur, which is best heard on expiration. What will be the thing? Ejection systolic murmur, which is best heard on expiration, means left ventricular outflow tract obstruction. It means there is left ventricular outflow tract obstruction. Okay, so you have to look up only. We have written all these points here. What are the points here? That ejection systolic murmur is basically mid systolic murmur. Differentials are LVOT obstruction versus RVOT obstruction. But when I say expiration, means it is left sided. So I say that it is LVOT obstruction. But LVOT obstruction can be divided into subvalvular HOCM. It can be valvular at the level of valve, aortic stenosis, or it could be supravalvular, that is coarctation. So paradoxical split के साथ हमने लिखा LVOT obstruction can be 3. LVOT obstruction can be 3 in number. LVOT obstruction can be 3 in number. And a relation to respiration is a finding. Respiration is a finding, right? So what we are going to look at, HOCM murmur, there is no radiation. Valvular aortic stenosis classically radiates to the carotids. That is characteristic finding. And coarctation murmur radiates to the back. This is what is important to us. So ejection systolic murmur. So all this I have summarized in a single page for all of you. So all you have to do is follow the chart. When you get an MCQ question, you have to follow the chart. First see murmur diya hai kya? Murmur diya hai. Very good. So murmur is present means likely to have some structural disease. Then you look at the timing of the murmur. Based on the timing, you will identify whether systolic, diastolic, continuous. Systolic, diastolic further subdivide based on phase that is affecting. After then, you look for relation to respiration and radiation of the murmur, and that will give you most probable cause. Because हमको क्या चाहिए? Single best answer. We want to know single best answer only. Supravalvular stenosis. Okay. Radiation, how you see clinically, you please see the clinical medicine videos, then you will understand. You can see it's there on the clinical courses. See in the clinical courses. Chalte. So what we have covered, we have understood. If the murmur is audible, we have to look at timing of the murmur, radiation of the murmur, relation to respiration. That will tell you most probable cause of the murmur. This does not have to be mugged up. I have derived all of this. You don't know the physiology. That's why you have to mug up. There is nothing to mug up. It's based on physiology. Because murmur is based on the flow across the structure. Right? So to finish this cardiac murmur, let us write about dynamic auscultation. So dynamic auscultation means relation to maneuvers. That's all. Which one radiates to carotid? Aortic stenosis. Aortic stenosis radiates to the carotid. Okay. So dynamic auscultation का मतलब लिख देते हैं relation to the maneuver. Dynamic auscultation is relation to the maneuver. So very simple way to remember. I'll tell you the relation. Dynamic auscultation. Just remember the dictum. Okay. The effect of the maneuver. Just remember the effect of the maneuver. The effect of the maneuver on the murmur. The effect of the maneuver is the same which is present on the preload or the afterload. Okay, the effect of the maneuver is the same as on the preload or on the afterload. On the preload or the afterload, it is the same. ऐसे याद रखते हैं. Effect of the maneuver is the same on the murmur as the effect on the preload and the afterload. On the preload and the afterload, we can say. Means what? So the intensity of the murmur, if the preload decreases, murmur also decreases. So preload decreases, murmur also decreases. Or preload afterload increases, murmur also increases, except in HOCM and MVP. That is for MCQ. Except in HOCM and MVP, where the reverse occurs. So remember this very simple dictum. The effect of the maneuver on the murmur is the same as on the preload and the afterload. Is the same as on the preload or the afterload. We can say effect is the same as on the preload or on the afterload. Just 1 minute. So, for example, if the intensity of the murmur decreases, preload decreases, intensity of the murmur decreases. Preload afterload decreases, intensity also decreases, except in HOCM or MVP, where the effect is opposite. I'll tell you, don't worry, just write this down and we will follow it up. So first, which are the maneuvers that reduce the preload? Preload का मतलब क्या? Reduces preload, reduces venous return. How to reduce venous return? Valsalva maneuver and standing posture. How to reduce the afterload? Amyl nitrate inhalation. Okay, so what happens to intensity of the murmur? They also reduce. So maneuvers which reduce the preload, maneuvers which reduce the afterload, what happens to the intensity of the murmur? Also decreases. Intensity also decreases, except in HOCM और mitral valve prolapse. है ना? जिसको समझ में नहीं आ रहा है वो समझने की कोशिश भी मत करो, है ना? This is not the time to understand. Right now you take it down, है ना? As you go ahead and learn more physiology, you will be able to understand these points better. I'll explain to you once. I will try my best, but try to concentrate. Enumerate maneuvers which increase the preload. How can I increase the preload? By leg raising, by performing the squatting posture, and by doing hand grip exercise. So when I do this exercises, what happens here in hand grip exercise? Intensity of the murmur increases. Chalo, first you note down the point. I will try to explain to you. Okay, these are all very simplified charts. When you understand this, just you have to follow it in the exam and you will get the answer. You will just get the simple answer, right? So what is the point? Try to understand. That's why definition I gave you. Murmur is defined as the sound produced due to turbulent flow across the diseased structure. When the flow decreases, murmur also decreases. When the flow increases, murmur also increases. The flow depends on the preload, depends on the afterload. Everybody repeat. So preload reduces, afterload reduces, means the flow across the diseased structure also reduces, and that is why intensity of the murmur also reduces. But when the preload and the afterload increase, the flow also increases, and that is why intensity of the murmur also increases. But exception to this rule are HOCM and MVP. Exception to this rule are the HOCM and MVP. That is why they are commonly asked in the MCQ. Commonly asked in the MCQ. Commonly asked in the MCQ. Okay. So what is there here? This is the dynamic maneuver. Dynamic auscultation matlab effect of the maneuver is the same on the intensity as on the preload, afterload and the intensity. So when preload decreases, afterload decreases, intensity decreases. When the preload increases, afterload increases, intensity also increases. Except in HOCM and MVP, where opposite response occurs. Why it occurs is not important to know, but in MCQ you must know they are exception to the rule. They are exception to the rule. That's all you have to understand. Okay, that is all you have to understand, right? So we have understood that this is the auscultation of the murmur also. I know today's session is all like that. This is auscultation of the murmur also. So taking you back here, so what have we completed in the clinical assessment methods? We have understood clinical assessment methods. Now we have completed detailed clinical examination. We have understood here, है ना? सबसे पहले से करना. So first is what? Copying तो करना पड़ेगा. Then we have to understand. It is step by step process. So when a patient comes to you with suspected cardiovascular disease, we first check arterial pulse, carotid pulse, JVP, pulsus paradoxus, Kussmaul sign, auscultate for heart sounds and murmur, and you can screen the patient for cardiovascular disease. Screen the patient for cardiovascular disease, right? So to complete our today's point, ECG you have covered with Arvind sir. ECG you have covered with Arvind sir. So please go through those notes. We will review them tomorrow. ECG we have covered. We want to learn about echocardiography. We want to learn about echocardiography. Okay, chalo. Let us write about echocardiography and color Doppler of the heart. So ये सब मैं क्यों पढ़ा रहा हूँ? I am teaching all this because most of us do not give attention to these basic points. Now most of us didn't even know what is color Doppler, and for most of us, है ना, echo examination हम सबने देखा है. We have seen echo report, especially of one of the family member. But all we have read in the report is the ejection fraction. वो छोड़ के हमने echo कभी समझा ही नहीं. So we want to understand what is this echocardiography and color Doppler. What is this echocardiography and color Doppler? Okay. So echocardiography on one side, and we want to understand color Doppler of the heart. Echocardiography and color Doppler of the heart. Echocardiography and color Doppler of the heart. Let us write this page and then we will integrate all this information with our pericardial disease column. We will integrate with the pericardial disease column. Right here? Yes. So break का तो सवाल नहीं है. There is no break here. This is the last one. We have to complete and go. Right. चलिए. So echocardiography versus color Doppler. How to interpret this report? है ना? What do we do? So what should we do? Echocardiography. So echocardiography. Let us see. है ना? So Achin is back to defend me from Binod, है ना? So Binod से मैं नहीं बच सकता, but Achin can save me. So thank you very much for saving from the Binods of today's class. Right. So let us come to Binod ke Papa is back for the last half an hour. Binod ke Papa is back. Let's go for him. Anna, 3 cheers for Binod ke Papa. Anna, we need some cheers for him. Let's start with echocardiography. So echocardiography basically gives you structural assessment. Okay, gives you structural status of the cardiovascular system. So understand what are the points here, Anna? So what are the points for echocardiography? What do you see? Echocardiography में number 1 point is situs. Number 1 point is situs. If you see the report, Anna, if you see the report, situs, first line on the report will be the patient has situs normalis. And abnormality, I am sure all of you know, is dextrocardia. So echocardiography can tell you whether the situs is normalis or there is dextrocardia. Number 2, it comments upon the great vessels. It comments upon the great vessels. So if you read the echo report, which all of you have at home, Anna, there must be at least something which is there. Anna, some relative has undergone echocardiography report. See that report today and you will remember this forever. So here great vessel, aorta and pulmonary tree. So you can see aortic disease, aortic and pulmonary artery disorders can be picked up on echocardiography. So whether it is coarctation, whether it is dissection, whether it is pulmonary dilatation, you can see it on echocardiography. Number 3, it comments upon the chambers. So it tells you about the number and the size of the chambers. Number and the size of the chambers. So atria, ventricle, enlargement, hypertrophy can be seen on the echocardiography. Enlargement can be seen on echocardiography. Then we will see about the septum and the valves. The septum and the valves. And then there will be miscellaneous finding if present. Like there is a tumor, there is an effusion, can be seen on the echocardiography report. Okay, so on the echocardiography, you do not see ejection fraction. Ejection fraction is a part of color Doppler, not of echocardiography at all. Echocardiography only tells you structural stages. तो आपको दिखेगा what is the situs, what are the great vessels, how are the chambers, how is the septum, the valve, and miscellaneous findings can be seen on echocardiography. Echocardiography has 2 types. The preferred type, preferred method for screening. The preferred method for screening is to go for the transthoracic echocardiography. So echocardiography has 2 methods. The preferred one for screening is the transthoracic echocardiography, which is routinely done. Transthoracic echocardiography, because it is non-invasive. You can use this because it is non-invasive. You can try that first. Okay, so transthoracic, you place the ultrasound probe over the chest wall. Non-invasive, that can be used for screening. But the specific is to go for transesophageal echo. The specific is to go for transesophageal echocardiography. So we mainly, it is specific, not preferred, because it is invasive. It is specific, because it is invasive. It gives you more detail, but because it is invasive, there are specific indications. There are specific indications here. What are the indications? MCQ. Indications for transesophageal echo. Left atrial defects like myxoma or a clot. There are specific indications. Left atrial defects like myxoma or clot. For aortic defects. For aortic defects like coarctation or dissection. Coarctation or dissection. We want to go for transesophageal echocardiography. Number 3, you want to do it specific points for when you have a patient with suspected infective endocarditis. In a patient with suspected infective endocarditis, to look for vegetation and the presence of paravalvular abscess. So in a patient with suspected infective endocarditis, in a patient with cardiomyopathy, to look for infiltration, to look for infiltrative disorders. In a patient of cardiomyopathy, you want to perform transesophageal echo to look for infiltrative disorders. For pre-operative assessment, of mitral valve and aortic valve defects. So please remember, transesophageal echocardiography, we do it only specifically for certain indication, before surgery, before valve replacement, and in a patient with young unexplained stroke. Patient with young unexplained stroke, less than 40 years of age, to rule out PFO, to rule out patent foramen ovale, which is a source of paradoxical embolism. To look for patent foramen ovale, which is a source of paradoxical embolism, Okay, so you must know specific indications. MCQ, specific indications for transesophageal echo. So echocardiography gives structural assessment of the heart. It can be performed using either transthoracic, which is simple, preferred screening, but more specific but invasive is to go for transesophageal echo, which has got specific indications as we have written here. Specific indications that we have written here. Cardiomyopathy, CMP is cardiomyopathy. Right? Come to the other side. What about color Doppler? Color Doppler tells you the functional assessment. color Doppler tells you the functional status, है ना. ये सब after reading it becomes very interesting. Okay, remember this, है ना. Remember this. Patent foramen ovale paradoxical embolism means what? The clot from the venous circulation enters into the right atrium through the PFO, enters left atrium and causes arterial infarct. So clot is in the vein, but infarction is in artery. That is called as paradoxical embolism. That is called as paradoxical embolism. Yeah. So this is what we are looking at. So functional status. I'm telling you this because you know how it is in medical college. है ना. याद करिए कुछ 5 minutes you take time to introspect and relive your life during the clinical ward rounds. वार्ड राउंड्स में हम लोग कितने बार जलील होते हैं ना. हाउ मेनी टाइम्स वी गेट ह्यूमिलिएटेड, इंसल्टेड, टॉर्चर्ड बाय अवर प्रोफेसर. एवरी टाइम ऑन द राउंड हम लोग को हिस्ट्री नहीं आता है, एग्जामिनेशन वी डोंट नो, रिपोर्ट हाथ में दिया वो भी नहीं आता है ना. सो द एग्जामिनर और द प्रोफेसर एक्सपेक्ट्स यू टू आंसर द क्वेश्चन अबाउट द रिपोर्ट्स. बट एमबीबीएस का दिल क्या कहता है ना. मोस्ट ऑफ द टाइम एमबीबीएस स्टूडेंट क्या सोचता है ना. they give you ECG, they give you echocardiography and they ask you questions, but the professor when you don't answer the question they tell you अरे बेसिक भी नहीं आता है ना. बेसिक भी नहीं आता. कितना इंसल्टिंग लगता है ना. मेडिकल स्टूडेंट फील बेसिक भी नहीं आता, छोटा फील करता है ना. ऑलमोस्ट सुसाइड. वी फील बैड कि बेसिक भी नहीं आता. But as a medical student, I always wanted to tell the bloody professor, अबे बेसिक का मतलब कंजेनिटल नॉलेज नहीं होता है, सिखाना पड़ता है ना. बेसिक डज नॉट मीन दैट वी नो इट फ्रॉम बर्थ. इट स्टिल हैज टू बी टॉट. नो, तूने पढ़ाया नहीं तो मुझे कैसे आएगा है ना. अनलेस द बेसिक्स आर टॉट, हाउ विल वी बिकम बेटर. सो अनफॉर्चुनेटली our interpretation of lab test is bad because we are never taught about it. It is bad because we are never taught about it. Not because we are bad, we are good, but सिखाना तो पड़ता है ना. Echocardiography क्या देखने का we don't know. Then how can we interpret the report? But all that should change from today. All that should change from today. ECG, Arvind sir has taught you in detail, right from pathophysiology to how to interpret ECG and the manifestation of each arrhythmia, right? So today I want you to know functional status, how to understand what is the functional status. So function, cardiac function, we have to know both systolic function as well as diastolic function. So systolic function is measured in terms of EF, that is ejection fraction. It is measured in terms of ejection fraction, that is EF. So please remember, what is EF? EF is nothing but the measurement of systolic function, because systole is a positive phenomenon. You want to see how much of the end diastolic volume is pumped into the circulation, and that is called as ejection fraction. Normal ejection fraction is 60 to 70%. If it is less than equal to 40%, it is called as reduced left ventricular ejection fraction. Okay, so please remember. So how to interpret the report? How to interpret the report? So systolic function is measured in terms of ejection fraction. Measured in terms of ejection fraction. Okay, normally it is 60 to 70, but less than 40% is called as reduced left ventricular ejection fraction. But the challenge was always to measure the diastolic function. Measure the diastolic function. So diastolic function is measured in terms of E:A ratio. Measured in terms of E:A ratio. Okay. So what is this E:A ratio? we have discussed diastole filling occurs in two phases, early filling phase and the late filling phase में होता है. Normally early filling phase is 80%, late filling phase is only 20%. Means normally ratio should be 4:1. Normal ratio should be 4:1. So we want that normally when the ratio is more than 1 is considered normal. As long as early filling is more than the late filling, it is considered normal. But when the ratio becomes what we call it, it is called as normalization or reversal of the ratio. Normalization of reversal of the ratio. That is when it becomes less than equal to 1. It is considered diagnostic of diastolic dysfunction. It is suggestive of diastolic dysfunction. So MCQ. So normalization and reversal of E:A ratio. E:A ratio is suggestive of diastolic dysfunction. Indirect one. So correlate with what we learnt in physiology. What we learnt in physiology, that we learned that if A becomes more, that means indirectly E has to be abnormal, and that is why it is diagnostic of diastolic dysfunction. But there is exception to the rule. Exception to the rule, except in the topic, except constrictive pericarditis. Except for constrictive pericarditis, where the E:A ratio remains more than 2 in spite of impaired ventricular filling. In spite of impaired ventricular filling. And why is that? Because it is the only heart disease which affects the late filling predominantly. MCQ question. Normalization matlab equal रे. Normalization is equal. When it becomes equal or reversed, that's what it is called. Equalization. E is early filling. Volume of blood in the early filling. Volume of blood in the late filling. You divide the two. Normally it is 80% and 20%. That means it is 4:1. But if the ratio becomes 1 or less, that means A has become more. Why A has become more? Because E is abnormal. That means diastolic dysfunction is there. Except for one condition, cardiac constrictive pericarditis. Constrictive pericarditis, where the ratio remains normal in spite of impaired ventricular filling, because it is the only heart disease affecting late phase, not early phase but late phase of the ventricular filling. Late phase of the ventricular filling, right? So now we know all the assessment methods. So now we know all the assessment methods. So let us complete our table of pericardial disease. Let us complete the table of pericardial disease and call it a day. Chalo, last table fill करना है. Pericardial disease. I hope you can recall now. So all that we studied, cardiomyopathy, Harshit, Hana, you are very much sleeping, boss. CMP has come 100 times. It is cardiomyopathy. Come on. So cardiac tamponade versus constrictive pericarditis. Chalo, fill up the points here for me. So heart sound in constrictive pericarditis, pericardial knock may be present. Pericardial knock may be present. Very important, no? Because it is characteristic, not common. It is characteristic, not common. Okay, so heart sound, pericardial knock in constrictive pericarditis, चलो आगे fill करते हैं. Cardiac tamponade, first we will fill it up. Cardiac tamponade, first we will fill it up. So most common finding is the presence of pericardial effusion. Minimum effusion to cause tamponade is more than 200 ml. More than 200 ml. Okay, more than 200 ml. Most specific finding is early right ventricular diastolic dysfunction. Right ventricular diastolic defect. Diastolic dysfunction. There is diastolic collapse. Is the characteristic finding on echocardiography. On the echocardiography, we are going to see. Okay, so what happens? Remember, in cardiac tamponade, the patient early filling does not occur. So during the early diastole, rather than ventricle dilating, ventricle collapses. Rather than dilating, it collapses. And that is specifically for the cardiac tamponade. How will you treat? It is an emergency, acute condition. Emergency pericardiocentesis. Emergency pericardial tapping is the first one. Pericardial tapping is the first one. Pericardial tapping is the treatment of choice. The prognosis depends on the treatment. Please remember, pericardial prognosis depends on the treatment. Post-treatment, the prognosis is excellent recovery. Post-treatment, there is excellent recovery. But without treatment, delay in the treatment can cause high acute mortality. Can cause high acute mortality. We can say that. So please remember. How do I remember the patient? That when the patient right ventricular diastolic collapse, that is earliest. LV pressure is little more than RV, initial stages. So earliest and specific finding we see is the right ventricular collapse. So please remember the dictum. If you get a patient of cardiac tamponade, in your emergency room, if you treat the patient will go home the same evening. If you don't treat the patient will die the same evening. Iska matlab one thing is for sure. If you get a patient of cardiac tamponade, you will be filling 1 DC within 6 hours. The DC can be either discharge card or death summary. That's the choice you have to make. If you treat, patient will be discharged. If you don't treat, you will be filling death certificate of the patient. So you have to remember this point here. Very simple. So if you treat, good prognosis. If you don't treat, high mortality, because it is an acute complication. Compare it now. On the other side, constrictive pericarditis में क्या होता है? In constrictive pericarditis, most common finding on the echo is thickened pericardium. Most specific finding is ratio more than 2 in spite of impaired ventricular filling. Characteristic coli. In spite of impaired ventricular filling. and treatment, only treatment is surgical pericardiectomy, excision of the pericardium. Surgical excision of the pericardium is the only cure, only potential cure. But unfortunately, surgery is high risk surgery. It is a high risk surgery. Hence, overall, it is a unfavorable prognosis. The only treatment is the surgical excision, because here there is no medicine to dissolve the adhesion. You have to strip the pericardium, you have to remove the pericardium, but the surgery itself is high risk surgery. Most surgeons will refuse to do the surgery, because when you remove the adhesed, very thickened pericardium, you can injure the myocardium, which can lead to torrential bleeding on table. So when they do the surgery, it is high risk surgery. So prognosis remains unfavorable. Prognosis remains unfavorable. So that is what your pericardial disorders. This is our summary of pericardial disorders. Okay. So see, the idea is what you know. So even though there is a small mix of your regular and foundation batch, I hope the foundation have to little bit catch up. If you don't catch up also few points, it's okay. Try to take down notes. Next year you may attend again and you will catch up with this. But regular, for that, more often than not, you are looking at a revision and a quick revision which you want to catch up. Okay. So these are the shortcuts that you want to do, that you will help us remember salient important features of the thing. Right. So next point, what I want to summarize today, that what we have finished at end of the session. So today at the end of the session, I'll keep you aware that what have we completed. So understand this. So today we have completed assessment methods. We have completed the assessment methods. So with the assessment methods, let me take you back to the first page we did today. So in the integrated approach to medicine, when you know, read it carefully, when you know the physiology, symptomatology and the classification, what you have become now today, you have become a good MBBS in cardiology. You have become a good MBBS in cardiology once you know these parameters. So tomorrow, whole day, we are going to focus on becoming DM cardiology by learning individual disorders, right? So in rheumatology, we already have a fellowship. In rheumatology, we already have a fellowship. Tomorrow, we will become DM in cardiology. I hope today you can consolidate the knowledge. You can consolidate the knowledge. Please read the ECG class notes by Arvind sir. Try to consolidate the knowledge. If there is any question, please free to ask me, ask sir, put it on the club, so that we don't have any confusion. So we have become a good MBBS today. Tomorrow 9 a.m. we will start on the quest to become a good cardiologist, right? So what topics we will cover tomorrow? Let me put it in front of you. So in the classification, as you all told me, I will try to put it differently. So hypertension, coronary, we have given away. So we have to do arrhythmias, rheumatic fever we have done, valvular disease, endocarditis, pericardial disease we have already completed today. Pericardial disease we have completed today, right? So what we will start with tomorrow, 9 o'clock, we will start with a quick review of arrhythmias. Okay, read your ECG, read Arvind sir's notes, and then come tomorrow. We will review our arrhythmias before going on to further structural disease. Right? Chalo, run away. Good night. Any doubts are there, I'll post it for you. You post it on the club. I will form a link today, right? So we will do cardiovascular class today, right? Day 1. I will post it on the club. Please post your doubts in below them, so I'll answer it for you, right? So good night, Anas. Run away tomorrow morning 9 o'clock. Tomorrow morning 9 a.m. We will start with arrhythmias. Revise ECG, revise Arvind sir's arrhythmia, and then come tomorrow morning. Chalo, good night.